We are happy to have Praveen here visiting his family and attending the conference. Uh, I think you can start, Dr. Usman. Maybe
Okay.
Praveen will say hello to you.
All right.
Hi, Doc.
I am trying to bring on my presentation, but sharing the screen, but it is not allowing me to. Naresh, can you hear me? Hello?
We can hear you.
Can you? I'm trying to share the screen, but it's not allowing me to. You disabled. They said the host disabled participant screen sharing.
Hello, Dr. Usman.
Yep.
Now you can share the screen.
Okay, there you are. Good. Okay. All right, nice meeting you guys. It would have been much pleasure if I was able to come and be with you guys physically, but at least it's better than nothing. The little guy that you see here was born in the United States a few months before I came from Britain and migrated here. So he basically dictated what I did from then onwards. So I was born and raised in Kenya on the border between Kenya and Ethiopia. My community were farmers and a lot of backaches in that community. So that's really what pushed me into medicine. And I went to Britain where I did my fellowship at the Royal College of Surgeons of Edinburgh, after which then I moved on to work as orthopedic resident in Norfolk Norwich Hospital. I was lucky to work with two very excellent surgeons. One, Keith Tucker, who was a general orthopedist as well as a spine surgeon, an excellent spine surgeon. We did a lot of corrections of spinal deformities and all sorts of problems. And then 6 months after I came there, the team was joined by Malcolm Glasgow, who just graduated as a fellow from Toronto as a knee arthroscopist. So I was very excited when he came, and I worked with him. And in a very short time, I really got control of the technology. From then onwards, for me, then the question is, hey, what can you do to reduce the trauma of spine surgery? Can this technology be transferred to the spine? You know, but this was just kind of some imaginations at that time. After finishing my training there, I went back to Edinburgh to join Michael McMaster as a spine fellow. So almost 100% of the work that I did was spine surgery. That's really when I also learned quite a bit, and an event that really pushed me into getting into endoscopy was 3 young girls, 14, 15, and 16 years of age, who came from Saudi Arabia with for correction of scoliosis. And, you know, kind of psychological trauma to people coming so far away at their very fragile age, and the physical trauma of the surgery is really what ultimately made me feel, okay, it's time to really go and look into this option of endoscopically doing spine surgery. I was lucky to get a fellowship position at University Hospitals of Cleveland, Ohio, where I came and started working in 1992. Between 1992 and 1993 and 95, we were able to do 3 new techniques: transforaminal thoracic decompression and fusion, transforaminal decompression of stenosis in the lumbar spine, as well as trans-iliac approach, which Mahesh referred to. One of the things that actually prevented me from coming to United States, to pursue this technology was the fact that after my training as a resident as well as a fellow in Britain, I was supposed to come here, and if I am not interested in doing orthopedics, then I had to repeat the entire residency program, which was crazy. But that was really made it easier for me by my son who was born just a few months before I came here. So after finishing my fellowship, I had to go into orthopedic residency again at University Hospitals of Cleveland for 4 years before I, was able to go and do my board certification and be able to practice. By that stage, a few things had happened. Of course, for those years, I was completely away from spine surgery. But by the time I finished, Sextant, which was a percutaneous pedicle screw developed by Medtronic, had been approved in the United States. And then a year later, in 2002, a recombinant BMP had also been approved by FDA, and people had just begun using it for ALIF fusions. So after working for about 2 years as an attending here in Maryland, basically all I was doing was just routine open surgeries, except for disc surgeries and decompressions. So I said, okay, with these 2 technologies, i.e. percutaneous pedicle screws and the BMP, it may just be possible for me now to start doing fusions that way instead of ALIF or open surgeries, decompressions, and what have you. And what would be the desirable things that I want to get out of such an approach? Number one, reduce the trauma, reduce blood loss, reduce anesthetic time, hospital stay, postoperative pain control, and ability of patients to come back much earlier with limited time spent on rehabilitation. And of course, ultimately, minimizing complications as well as cost of treatment. And again, what I found, after coming to United States here, old people don't just want to sit at home and enjoy coffee and stuff like that. They want to run, they want to do things. And to be able to allow them to do that was also a very major interest for me. But like I said, at that point, all I did was just endoscopies, decompression and not fusions. So that is really what led me to kind of work on this project of trying EndoLIF in order to see if, in fact, it can achieve those goals which I wanted. So the first cases that I did were all, case series, one as they come along without making any choice, but it was a prospective study, which was very, very important for me so that I can actually follow the progress and how the patients did. So the outcome measures, operating time, intraoperative blood loss, hospital stay, versus cause for back and leg pain, and all those studies, and also postoperative images to kind of confirm that fusions are actually successful. So we had about 60 patients at the beginning, 30 male and 30 female. Majority of the problem was basically degenerative motion segments of the spine. The routine for the operation is basically just a standard, nothing special. And the procedures were endoscopically decompressing the spine, end plate preparation under the guidance of the endoscopy, then percutaneous interbody fusions and pedicular screw instrumentations. At that time, really, there was not much emphasis. Very few people were really interested in spine, endoscopic spine surgery here in the United States, particularly after a few surgeons who tried the new techniques came up with a lot of complications as a result of injuries to the nerve roots. So I had done and published a cadaver study on an endoscopic approach. So I basically relied on the outcome of that work in order to determine portal site, angle of instrumentations, and where to hit the disc depending on the pathology. And again, in 1995, I also did the next study, which was to compare endoscopic foraminoplasty versus laminectomy, because I thought, well, if I can go through the foramen where the stenosis is taking place and lateral recess, why do I need to go and open the spine and do laminectomy and all that kind of stuff? So I did a cadaver study again, and we found that 45.5% increase in the area of the foramen was achieved through endoscopic foraminotomy versus 34.2% if we did laminectomy and partial facetectomy. And also there was no instability as a result of transforaminal approach, because I'm not really interfering with the stability of the spine versus loss of stability in extension and rotations when we did laminectomy. So that also made me fairly comfortable to basically use this particular approach, whether it's just for decompression or for decompression and fusion. And then the last thing that I did before I finished my fellowship there is go transiliac approach to basically come through the posterior aspect of the ilium, coming to the into the disc at L5S1, where the L5 where the iliac crest gets in my way. So later on, I found that it worked very well when you have moderate or less severe stenosis in the foramen and in the lateral recess. But what if there is a lot of thickening of ligamentum flavum with central narrowing, as well as hypertrophy of the facets and bulging disc and what have you, which could also interfere with reduce the capacity of the central canal. So that led me to then to develop image-based classification of the motion segment based on the alignment, disc, facet, and ligamentum flavum, so that I can then use these parameters to determine what would be the best way to go. Is it just go transforaminally alone, or can I go and do what I later labeled as laminoforaminoplasty, in which case basically I may have as many as 3 portals bilaterally. That is something that I'm still developing. I haven't had a lot of opportunity to develop on that. And again, at that time, other than the skin that you are making incision through and the disc and the bone that you are seeing through the fluoroscope, you really don't see anything else. So I thought it's very important to know that, there's a fascia to go through, there are muscles to go through. Sometimes when you're pulling herniated material out, you may actually lose the fragment inside the tract that you are pulling out. So So it's important that people, particularly who are learning at this time about the approach, to have a reasonably good idea about what structures you are going through. And again, the facet, for instance, the framing is basically like a room. It has got walls, it has got a floor, it has got a roof, and has got contents. The most important content being the exiting nerve root and the triangle, the Cambin triangle, basically being formed by exiting nerve root, traversing nerve root, and the superior end plate of the caudal vertebra. That is really where you aim for getting into the disc as shown here. If you go too laterally, you may actually hit the exiting nerve root. If you go too medially, you may hit the traversing nerve root. So it is very, very important to stay in the interlaminar spaces, medial and lateral interlaminar spaces as you hit the disc. So those initial guidances were very, very important to avoid injury to the nerve. And I really didn't have any guidance other than the study that I did to make sure that injuries to the nerve are minimized. So when I started doing arthroscopy, obviously, that time endoscopy, in fact, Cambin, what I learned from Cambin is a biportal bilateral approach with an endoscope from one side and instrument from the opposite side. But, what I noticed immediately was, hey, you are inside the disc space and what you're looking at is basically instrument from the opposite side. There's really not much you see. But actually, by that stage, Cambin was already in the process of developing a channel for instrumentation, also using the same portal. But when it came to decompression, particularly in the thoracic area, I just didn't feel very comfortable just relying on one portal through which the endoscope and the instrument went, particularly in the thoracic spine, where you have got a lot of hardened disc that is herniated and causing compression on the spinal cord. So that's really when I came up with a biportal approach, ipsilateral biportal approach is transforaminal, so that I can visualize all the time, keeping an eye on the spinal cord while I am doing the decompression. So, and the first one was done in 1995, and then in 1996 I did the first lumbar biportal approach like this one. I was lucky to have a team of a company that was willing to do some stuff to help me, including developing instruments and endoscope, as well as a REMA, which really I needed for end plate preparation. And here it is. You basically here you have the instrument, the REMA that is coming through here. Here you can see a lateral view with an expandable REMA, as well as a portal for instrument insertion and visualization endoscopically while you're doing the procedures. And then here, basically, you see endoscope from one side and expandable REMA on the other side. And I can then visualize, see how much am I taking away enough bone. As you can see, the subchondral bone is fairly wide, a little bit different from what you see when you're looking at the cancellous bone underneath it. And protecting the subchondral bone, even at that stage, to me was very, very important, because you can avoid subsidence because of pressure once the patient starts weight bearing. And basically, when you're seeing petechial bleeding like this one, I felt that was really good enough for me. It tells me now I've gone through the, the fibrocartilage. I am now looking at the end plates. And that was really very important to me from the beginning. But like I said, at that point, there were no interbody devices that you could put in percutaneously. But the BMP had come and everybody was celebrating this, device that allows, osteogenesis. So I thought, okay, I could use the same portal that I use for decompression of the disc and end plate preparation, use the chemical, the BMP, mixed it and wrap it in the collagen carrier, which will be impregnated with the BMP, and basically sew it, make it like a cigar, and then just put through this tube into the disc space. Once that is done, then as far as I'm concerned, then the fusion, bone grafting is done. It is now a question of now putting in percutaneous pedicle screws. And the first one that came out was the sextant screw. And here you can see the screws are inside there. These are the extensions through which the set of screws being inserted. And this is a guide that allows you to insert the rod into it. The problem with it was you have to make an extra hole in order to be able to kind of insert the rod. And what problem I ran into is if I'm doing more than 2 levels, it becomes a little bit difficult then to negotiate the portals and missing a screw, particularly the ones in the middle, tended to be fairly common. So that's really what made me move away from that to the next one, which is the K2M system called the Denali pedicle screws and the Serengeti retractors. The Serengeti retractors are basically just plastic retractors, if you like, which fits inside, underneath the screw tops, and you can then insert it and put in Gelpes retractors, and then open it up. And what it does is it allows you to see the instrument, the screws. It also avoids you making an extra hole like for the sextant. So I was fairly comfortable with that, and in fact, that is the one that you use most of the time. So what you can see here is basically a retractor with the screws in place, the Gelpai here opening up the space so that I can see the screw, and basically fixing it that way. So what you have here is the bone graft that we have put in there, screws set in, and basically I was very comfortable with that one for quite a while. Here's a lady who basically had open decompression about 15 years before I saw her, but coming back with neurogenic claudications and also problem above the level of previous surgery. She had basically some slight deformity, which we're able to correct and at least minimize and stabilize it, basically using just the BMP for interbody fusion. And this is her 3 months after her surgery, absolutely no pain. And you can see, this is about 3 months. Usually, with white patients like this one, at about 1 year, if you make transverse incision, you don't even see the scar tissue. With a vertical incisions, as you can see here, done 15 years before, you can still see the scar, but with this one, it is in the natural skin crease, so you don't see much of that. So as time went by, more technologies are being developed, and here is one of them now. We had a percutaneous cage that we can insert over a guide wire instead of me just relying on the BMP. This was one that was actually developed by Amendia. Here, so I have the cannula in place and a reamer there. Here now I'm inserting a spacer over a guide wire to make sure that I have got the right sized cage to go inside there. And here I'm putting in the bone graft, and the cage is going in. Here, AP and lateral cages in place. So basically, This is actually the patient. I did 2 levels on him. This is 3 hours after his surgery. He's walking. He went home instead of staying in the hospital. This is a 84-year-old man who had also similar type of procedures at 2 levels, 20 years prior to that, to coming and seeing us. He had decompression, doing very well, but 6 months before I saw him, he basically started developing leg pain, back pain, weakness, and he came in a wheelchair. This is now him 3 weeks after his surgery, coming for first postoperative visit, and basically able to walk even without a brace in his hand.
Can come back.
So they are 84 years old, 3 weeks post-op, didn't have even a cage in it, walker or even a cane in his hand. So we did about, these are 60 first patients that we did, average age of 52.7 years, and basic overall, the average duration of the illness was about 5 years, ranging between 2 months and 32 years. We followed them up for average of 12 months, ranging 6 to 25 months. The pre-op complaints were mainly back as well as leg pain in all the patients. The majority of cases that we did were L4 to S1 fusion. 16 patients and 13 of them were just L5 S1. And the higher up you get, the less the number of cases that we did. So I started with sextant, as I said. That is the first one that we did. We did about 17 on those. And then Denali came along, and I used the other systems which are not, generally they were almost copying each other. So follow-up, then I said, okay, here are the figures that I wanted to know. How much time are we spending on surgery, for instance? The mean number of hours, the time was 174 minutes, ranging 117 to 250 minutes. And these are also at the beginning, so I had to be very, very careful. But over time, obviously, we are able to do things much faster. So the more the number of levels that we did, of course, the more time it is spent. Then blood loss, average 57.6 cc's, ranging between 30 and 100 cc's. And again, the more the number of levels that you're doing, the more the blood loss. Ultimately, really nothing compared with what you would experience if you did operative surgery. And then hospital stay, mean stay 2.6 days, ranging between 1 and 12 days. And again, the more the number of the levels and the age of the patients, the more they stays in the hospital. And again, as time went by, we basically were able to kind of discharge most of the patients within hours of 1 or 2 level fusions. So when looking at the VAS, the average VAS score was 7.5 pre-op and 2 post-op. VAS for the legs, again, 7 pre-op, 1.7 post-op. And then we did patients who had previous surgeries, failed back surgery syndromes, about 10 of them. And what we found that overall, they actually recovery and improvement in terms of back pain and leg pain was much, much better than patients who are having their surgeries for the first time. And also they tend to stay less number of days in hospital than when we did, first, primary surgeries. We're able to review about 45 sets of patients who had fusions. 28 of them had solid fusions. There is stable construct in 15 of them, and 2 of cases had osteolysis with loosening of pedicle screws. So here, this is one of the first cases who had just the BMP and percutaneous fusion, 3 months post-op and 6 months of post-op. And you can see the overflow and how briskly bone was forming. And that's really what got me a little bit worried, because, okay, you can start the osteogenesis and what have you, but how do you stop it? How do you stop it and prevent it from, shutting down the frame and the other areas? That was really something that I was always concerned about, and just hoping that somebody's going to come up with percutaneous pedicle screws. But luckily, we never had any problems. So the complications, one patient had a medial wall penetration of the pedicle with an S1 screw, which required revision, and the other case who had loose pedicle screws which needed to be removed. Right. Other than that, no any other complications. So if you compare endoleaf with X-leaf, MIS, T-leaf, and open T-leaf, PLIF, we find that, the blood loss is actually very, the least amount. Here, those days, when people did X-leaves, they didn't do the X-leaf and pedicle screws at the same time. So they used to do the X-leaf and then maybe 2 or 3 days later go and do the instrumentation with pedicle screws. So that's why you see blood loss is a little bit less here. But, what we are given here is just what they experienced at the, first surgery. Otherwise, you can see the difference, in the blood loss, the length of hospital stays, and complications that the patient suffered post-op. So basically, after this short study, we could, comfortably say, we have avoided violation of natural cavities, whether it is spinal canal or peritoneal space or thoracic spine, chest cavity in the case of thoracic surgeries. We avoided excision of facet joint, avoided psoas space disruption or retroperitoneal space invasion. We reduced surgical time, we reduced blood loss, we reduced hospital stay, and minimal rate of complication with just loosening of pedicle screws. And basically a very excellent, pain relief. So overall, procedures are very well tolerated, even by the elderly people, like the 84-year-old guy whom you just saw walking without even any assistance at 3 weeks post-op. So the stress is also minimized in the operative, operating team, because, the assistance really does very little, to help the surgeon other than handing him some tools. The surgeons can do much more in terms of numbers per day than open cases. So in conclusion, obviously a randomized study was required for accuracy of all the observations that we made, cost effectiveness, reduction of rehabilitation, the duration, and all that kind of stuff. Unfortunately, I haven't had the opportunity to do that simply because I'm not working in a teaching hospital, which has got a lot of restrictions, which normally prevents people from doing things like what I have just done here. Thank you very much. The guy on the right side is that little guy that you saw on the first slides. He just finished his orthopedic residency and just started his spine fellowship 2 weeks ago. Thank you very much. We're done. Thank you.
Hello, Dr. Usman, Can you hear us?
Yes.
Thank you. That was an excellent presentation. Any questions to Dr. Syed Usman, sir? We have the mic in the center.
Dr. Usman, with the BMP, since there's no cage after you do the annulotomy graft in, was there anything placed to stop leakage of either the BMP or bone graft back into the foramen?
That was, like I said, one of my fears, because what I did was to wrap the bone graft in a collagen carrier. The collagen carrier was soaked with BMP, and then I put the bone graft, allograft bone chips inside there, and then basically stitched it so that they don't leak. And I made sure I pushed it as far anteriorly as possible. So, but that was always my fear, that if for any reason the rod broke or got loose or whatever it is, then there's really nothing that will stop from collapsing. So I insisted on having LSO to kind of support the spine for at least 3 months while the healing was taking place. But yeah, no, I have not had any extrusions. Like I said, again, my fear was what would stop the osteogenesis to continue and even shut down the foramen, but it didn't happen.
Yeah, I mean, just as a note, for anybody who's doing it, if you're using porous cages or cages when you're putting in transforaminally and you're putting in a lot of bone graft, BMP, the last step that I do with the endoscopic dilator is put a piece of bone wax, and before I take out my cannula, put the bone wax and close off the annulotomy and the entrance to the cage. So this way you don't get any leakage and post-operative neuritis. People might be complaining about leg pain, you attribute it to retraction, but probably some irritation from all the bone graft.
Dr. Mahesh, yes, sir. When we have a severe degenerative listhesis with the more of central stenosis because of facetal arthritis and ligamentum flavum buckling, especially if you have a triangular canal, did you have to revise or decompress by interlaminar approach when you do a transcam infusion?
Well, when I started, that is precisely what led me to develop this image-based classification system. And my main concern was, okay, you can get indirect decompression by putting in a cage that is bigger than the disc space as you see it. But then still, you can't rely on that to overcome a stenosis that has taken place, particularly if the ligamentum flavum itself is either calcified or is very, very thick. So that's when then I said, okay, fine. If I have, say, grade 3 thickening of the ligamentum flavum, grade 3 facet hypertrophy, and combined with either listhesis or bulging disc, then I started by doing a combined approaches at the beginning. This is just minimal decompression to basically take away the ligamentum flavum and whatever hypertrophy that there is on the facet, close it, and then do the rest of the approach with endoscopic techniques. I also actually developed, after coming up with the classification system, basically what I called endoscopic laminoforaminoplasty, where basically I come interlaminar with slightly central or slightly paracentral portal, and then get into the disc, and then put a flexible wire and do basically decompression of the facet, sorry, the foramen, as well as debulking the ligamentum flavum, and then use the same portal to go to contralateral side, and then do the same thing to decompress the foramen and the central canal. That is a technique that I actually presented first in Chongqing in China in 2016.
Thank you, Dr. Professor. Dr. Bhupesh Patel here. Hello, Professor Osman. One question here. When there is an extreme collapse of the disc, and with putting opposite side pedicle screw, even you cannot get distracted the disc space adequately. So what is your advice on putting the transcambine cage? What are the precautions we need to take? Because with collapsed foramen, it is very difficult to even put the cannula also. So how we proceed for the fusion in this such case?
Well, what I have done so far, and like I said, the reason I went into the detail of describing the technique of foraminoplasty, endoscopic foraminoplasty, is where then I started actually by doing biportal approaches just to make sure I have taken out the hypertrophy superior articular process, inferior articular process, using various instruments, including curettes, shavers, burrs, and all that kind of stuff. When I came up with the idea, first people even laughed at the whole idea of me getting all the compression through the lateral approach. And like I said, then for central canal, if the disc is contributing to the central narrowing of the spinal canal, I could come more laterally and get into the disc space, try to save as much as posterior annulus as possible, while at the same time decompressing. And like I said, if the disc is not calcified, if the ligamentum flavum is not calcified as such, you can actually reduce the bulging of that one by having a cage in. And that's again where an expandable cage becomes important. Because if you say, let me put in a fixed sized cage to open up the disc space, that is when you may actually cause damage to the nerve root. But if you can have an expandable cage, then you go in small, get into the disc space, and then expand it. And like I said, again, if ligamentum flavum is a major component of the narrowing of the central canal, then going interlaminar and just decompressing it that way and then finishing the job through the foramen would be reasonable.
Thank you, Syed Osman sir. It was great to have you here virtually. We hope to have you physically sometime next year. Big round of applause to Dr. Syed Osman.
Thank you very much. Thank you very much. It is my prayer that we can get together physically and do better things than what we have done and carry on with the wonderful job that you guys are doing. I'm really very proud of you guys. Thanks.
Thank you, sir. Thank you.
Take care.
Dr. Usman, we've shared you the... We'll move on to the next talk with the master, Dr. Karthik Kaila, sir. I think the first surgery, the patient is getting ready. Whenever OT is ready, we'll go live. And Karthik Kaila, sir. Where is your talk? Which computer? You are given to him?
Yeah.
Yesterday you gave.
Yeah.
Okay. I'll call you because it here. That's Karthik. Abhinandan. హలో సార్ చేశారు
వచ్చిందా?
నో సార్ ఇక్కడ ఓటీలో ఇక్కడ వినట్లేదు ఓటీ నుంచి అన్న వచ్చి మైక్ కావాలి సార్ వాళ్ళు మాట్లాడుతున్నారు హలో
హలో మదన్ అన్న, అక్కడ నుంచి ఆడియో రావట్లేదు, చూడండి ఒకసారి. ఇచ్చారా? సాయి ఆడియో రావట్లేదు, చూడు. ఆడియో రావట్లేదు.
నాది ఇక్కడ మ్యూట్ చెక్.
Hello, hello. Can you hear me?
Hello, sir. We can hear you. Please go ahead.
Can you hear me, Naresh?
Yes, sir. Please go ahead.
Yeah, good morning, everyone. We are starting day 2, and after an excellent talk by Professor Said. Good morning, Said.
And then they'll
Usman sir, can you hear us? Maybe yes. Logged out. So good morning everyone. Today is endofusion day, the fusion day. So the first case we are operating today is a 54-year-old male where he has a predominant low back pain with bilateral radiculopathy predominant on the left side. So you can see here on the X-ray AP, very small bifid spine, L5 bifid spine is there, and there is a pars defect which is causing some instability on flexion extension. So on extension there is no instability, on flexion definitely there is some instability which is causing him lot of back pain. So MRI T2 weighted images here show the degenerative L5S1 disc with a small prolapse, but more than discogenic pain, this is more of instability pain, and he has radicular pain because of the small disc which has come out. So today plan is to do a fusion, either you do a open fusion, MIS fusion, the endoscopic fusion. Principles remain the same. You need to do a good interbody work, pack the graft, put a cage, then put a pedicle screws. How we are doing it in a least invasive way, that is all that matters. So today what we demonstrate different techniques today. One is we'll do a facetectomy going posterior, we'll do facetectomy. We remove the entire inferior facet, pars and a part of lamina as we do in open surgery. I remove this entire bone in one block. Then we have a good graft and also a part of superior articular facet, that is the tip of superior articular facet, and decompress the traversing and exiting nerve root there, and do end plate preparation. Everything done endoscopically initially. Then later we put a cage. I'll show you how we put it. There are again different ways of putting a cage there. Mahesha has devised one half sleeve which we can use that to go through the same opening as endoscopic sleeve. But I little bit do differently, where we can put the cage through the incision which we take for the pedicle screw. So still you are seeing with the endoscope, and we put a visualized cage insertion. So today we'll see all the techniques. You need to understand how we take the cage into the space. So that is all that matters. Then second thing also we'll show you the transcambian approach also today, which will be done by Mahesha, and pedicle screw in placement which he has his own technique. Then the third case will have a expandable cage which is we are introducing first in India today. So that also will be shown. So first case, patient now is prone, GA, general anesthesia. General anesthesia. So normal position for any spine surgery, we have patient prone. ऐसा करना table tendon bar reverse. So the idea is to land on the lamina and pars here. So the idea is to land on the lamina and pars. So first is I take a image, shoot. You take a without Ferguson view here, this shoot. This is the area which you will think you should enter. But here being a L5S1 shoot, lordosis shoot. So if you enter here, there is because of the lordosis, you might still be inferior. I want my dilator to be parallel to the disc space. So that's why I take a little bit Ferguson view. This entry is entirely different from what we do in what you say. Yesterday, what we saw interlaminar approaches, it is entirely different. This planning is different. We land more cranially, more laterally on the pars, and more on the lamina shoot. So this is a lateral level I come. So still I come little bit more lateral shoot. So this is where I will land here in this case as lateral as possible. This is a lateral shoot. So I mark, I'm using a 10 mm, 9 mm dilator which we used for stenosis yesterday. The same Spinoscope I'm using. So I'll enter laterally here. Just give some dermal local injection here.
Sukumar,
yeah.
I have a suggestion. Instead of taking in AP, what I do is I go directly lateral. Take in the lateral and save CM shots.
Yeah. So just AP is to just take the
because AP you can never be 100% sure.
Yes. But only why I take in AP is just to be sure that I am not too lateral. Only that is the reason. Otherwise, as you said, only lateral is good enough. So I'm just putting an incision on the fascia. Now I'm just landing there.
How far lateral is your incision to midline?
Midline. I'll just show you dissector. So I'm taking a midline shoot here. Shoot. This is a midline.
Okay.
Mark it. Scale. I'm just measuring here. It is 1.5 centimeter from midline.
Okay.
1.5 centimeter. Can you see the marking here?
Yes.
Shoot.
Dr. Sukumar, with the Ferguson, what's your end point for the Ferguson to see if you have enough Ferguson for the patient?
Yeah, so here L5S1, sometimes it is difficult to get a parallel this one. L4, L5 is easy, L5S1 is difficult. So I have taken just from the experience here. So L5S1 is very difficult.
Yeah. See, when you don't get a true Ferguson, what you have to do is you have to go more cranially.
Yeah. Shoot.
Then you will be bang on the target.
Can you see?
Yes.
Shoot. కొంచెం కిందికి వెళ్ళరా కరెక్ట్గా చేసుకోవాలి అది పెడికల్స్ బాగా ప్యారల్ కనబడి కిందికి వెళ్ళరా నన్న ఓకే
ఎస్
కొంచెం పెడికల్.
So Sukumar, you selected a case with the spina bifida so that you don't have to do anything on the medial side.
Yeah, you gave me this case yesterday. So Actually, Mahesha wanted to show good transforaminal. Then, so we swapped the cases yesterday. So this is okay. We'll go in and lock Chesko. So now I'll just go in there. Now, as Mahesha said, there is already a pars defect. So all we need to describe the. So all I want you to understand is, when you land cranially, how does the lamina look? How does the pars look? What are the limits of the pars? How does a pars fracture look? How to identify the entire inferior facet laterally and inferiorly. That is what we need to understand today. Then I'm just using a 10 mm stenosis scope. I think Can you see the endoscopic image now?
Yes.
So here, because we have already landed on the punch, all light off, Chira. So I'm using a punch. Yeah, तू इधर आ जा रे, उनको रहने दे इधर, तू मेरे पीछे आ जा. Let them stand there. आरे ये लंबा కొంచెం length है saline, right?
So you always put the cage first and then put the screws, or?
Yeah. Here, because we need, for the sake of time, first we'll put the cage, then Dr. Abhinandan, my colleague, will put the screws. Meantime, you can start the second case. So that because 3 cases has to be shown, so we can manage some time, because people want to see your case, your screw insertion also. So we have to show everything today. So you can see I am landing on the bone here. I'll just show you in a minute, removing the muscle here. So here we have landed on the lamina and the pars junction. So we need to understand the entire anatomy of the adjacent level also, that is the cranial level also. Otherwise we'll miss the level. So RF. Here little bit there will be bleeding because you are dissecting some muscle here laterally. So you need to coagulate the things beforehand so that you should not develop too much of bleeding. Orientation is very important. 3D anatomy understanding is very important for a good surgery. So this is a lamina which I am just going cranially. This is adjacent level. So this is adjacent level. You can see this is a lamina going cranially. So lamina going cranially. The lamina of L5. So
Sukumar, did you try monopolar any time?
No, Mahesha, I didn't have courage to do that. So we bought the Pro, but we have yet to start use it. Maybe I should.
But you have a courageous man beside you.
I know. Where is Abhinandan? So now you can just see there is a bone here, curate. So now I use this instrument, wonder instrument. So I just remove the tissue from the bone. So you can see I am just dissecting the tissue from the bone. So you can see the advantage is delineation of the bone is very important, because you need to drill and remove the entire bone here. I remove the entire bone in one go so that you have a good chunk of graft for this patient. We need not use a synthetic or artificial graft or allograft. So now this is the adjacent level, that is L4, L5 space. So I've gone cranially here. We are in a cranial level here to see the upper border of the L5 lamina. This is upper border of L5 lamina. Can you appreciate that? Hello?
Yes, yes.
Yeah, so this is upper border of the cranial border of the lamina. So
Okay.
now, once you reach the cranial border, just follow it laterally. So follow it laterally, the lamina.
So that you mean to say spinolaminar junction?
No,
above?
no. The,
Upper border of cranial lamina?
You want to see the spinolaminar junction, I'll show you.
Yeah. And just orient.
Yeah, I'll orient. Yeah. Sorry, I didn't orient yourself today. Just hurried up. Okay. So here we are standing on the left side, right? So when we are standing on the left side, 3 o'clock of your screen, that is right side of your screen is caudal. 9 o'clock side of your screen is cranial. So
Okay.
dissector, curate. So this is a bone. What you are seeing is the L5 lamina. So this is L5 lamina.
Okay.
This is a laminar edge. Can you see the laminar edge?
Yes.
So this is a laminar edge of then this space is L5S1 space.
Yeah.
You go medially, just go medially, can just go medially here. This is a spinolaminar junction.
Junction, yeah.
Medially.
Okay.
Okay.
Yeah.
So this is a spinolaminar junction. I'll just do the RF there.
If you don't have a midline break, what do you do?
I'll drill there and cut it.
Okay.
Use a chisel,
Okay.
again designed by you.
Yeah, you are using too many of my instruments
Yeah,
without my knowledge.
Too many devices designed by you. Yeah. So I'll show you the magic of those instruments today. So this is a interlaminar space. So because we are doing it a L5S1, the space is so big. That's why the laminar span is also big. So this, you can see such a big lamina here.
Yes.
So laminospinous junction, cranial, this lamina, as we just go cranially, this is the upper end of the lamina, which forms the L4, L5 space. So then now I come laterally. So what I do is entirely bare the capsule here to identify the inferior facet. Cutter. So we need to identify the pars and the facet margin here. So what I am doing, so just go there, just follow this face, bony landmark all around. So how to identify the pars again? Pars is a very compact structure. It is not a cancellous bone. It's a very compact structure. So it just follow this lamina laterally. You just take a model yourself and see, punch. You just follow the lamina laterally, you will see the pars. So this is a cranial end of the lamina. I am just following it laterally. Once you follow there, you will see the pars, and you should see the, if there is a pars defect, you should see the pars defect and lateral border of the pars. So that is what we are trying to see here. So just so Abhinandan is here now. So Mahesha was telling, why can't you use a monopolar here? Daring surgeon Abhinandan is there. Curate. So I'm just curating it out. So this is a pars.
So there will be a lot of fibrous tissue around them.
Yeah. Can you see the pars break here?
Yes.
I'll just show you in a minute. So I'll clearly differentiate, delineate the.
Only issue when you do this fusion first is when you are putting screws later on this side,
Yeah.
you have to be careful.
Yeah, Abhinandan is used to it now.
Yeah.
So, but yes, definitely better is there at least put a K-wires or a trajectory. You will be more
because
safer.
if you slip, you will directly hit the root.
Yeah. So, as a beginner, you should be careful. Always put a screw first. Can you see the pars defect there?
Yeah, yeah, it's very beautiful.
So that's a pars defect. Curate.
And also other thing why I put screws first is you get a much better reduction if you do screws first, because once you put the cage, sometimes you don't get complete reduction. Of course, for symptoms it doesn't matter. It's only radiologic.
Now identify the inferiormost part of the inferior facet.
Sukumar, the hall is full to see your surgery.
Huh?
The hall is full and nobody is sleeping.
Yeah.
And when you have a good opening batsman, the middle order's job becomes easy.
No, you need to just people to understand the scope of endoscope. It has increased over years. Previously only it was only limited to discectomy. Now understanding has become better, tools are becoming better. So we need to understand it's not the only disc we can do, you saw yesterday what all can be done. Stenosis is a big chunk of a patient subset who needs spine care, which can be done endoscopically. So definitely, and fusion again forms a bread and butter of a spine surgeon. Also, if needed, can be done. But again, people should not go overboard, cutter small, because always Dr. Gore sir used to tell, if you say endoscopic fusion, then people will start abusing this technique. Hey picha papa, medium size. Ile chinnadi.
True. That's why you should not do unnecessary fusion, especially in old people where we can manage with the endoscopic decompression.
So you can see I am just delineating the inferior facet.
Yes.
All around, and I am trying to see the joint. I am just here. Once I do this, then I will go medially. It is easy.
Do you release the flavum also from underneath?
No, I will not remove the flavum now.
No. Because flavum has attachment to the lamina.
That I will remove.
Yeah.
That I will remove. I will just show you. First is this attachment is the one which is little bit difficult. First I remove this. Cutter remove. I just want to show the clear anatomy, so that it is little bit difficult to understand sometimes. So just want to show the clear anatomy. I am just walking all along the facet. So I am just walking on the facet. Just want to show the clear anatomy of the entire facet before removing it.
This you can do much.
You can see already it is moving.
Yes, it is mobile.
Can you see the movement? It is already moving. It makes my job easy. So I will again show the anatomy here. Curate. Yeah, it is easy. So this is a lamina. I'll just remove the medial part. So I'll just remove the medial part which Mahesha was talking about. So I'll clear this tissue. Cutter. So I have cleared the tissue all around. There will be some deeper attachment of the flavum which we can remove it later once we are lifting the bone. So
in fact, maybe you can use the bevel of the cannula to lift it up.
Yeah.
so that you can dissect it off.
Yeah. No, I use a chisel now. First a drill, then the chisel. I'll just show you. I'm just removing this soft tissue to have a clear vision. So, Pancham, RF. So this is. Yeah, I'll show. So, Dr. Prasad's question was like, if there was no lysis and there was no bifida, where do you put where do you cut that? So, I'll just show you that also. A good question. So, this is your interlaminar space. So, you can see now that's the interlaminar space, curate. I'll show you the anatomy now. This is the interlaminar space. This is a laminar edge. Going medially is the spinolaminar junction. Coming cranially, this is a lamina surface sloping down cranially. Sloping down cranially, and you see the lamina here. Curate. You see the lamina cranially, there it ends the space, upper space. You can see the upper space, and this is a laminar edge. You follow the laminar edge. This is a pars defect. It's a pars defect. You can see the pars defect here. Come laterally, it's a facet. So we just detach the all soft tissue around the facet. Now, you want to see the facet joint, you can see this is a facet joint. Can you see the facet joint here?
Yes.
So that's a joint moving there. So now the question, answer to the Dr. Patkankar's question, see, go as medial as possible. We want a bone here. We want more graft. So what I do is I go as medial as possible. If bifida is there, not there, it doesn't matter. I go as medial as possible. So I cut here. I put a cut here. Then when you come laterally, when pars is intact, you just take a shoot over the pars. So I just keep my curate here, take a lateral shoot, because you don't want to go cranially and injure the pedicle. Shoot. Can you see there? It is flush to the pedicle. It means that we are our good exiting root decompression will be done. It's same like open surgery, flush to the. Can you see the X-ray there?
Yes.
X-ray image.
Yes, yes.
Yeah. So we are flush to the pedicle there. So cranially, then we'll remove the entire one. So what I have to do here is just have to drill only the medial part, because the pars part is over here. So what I'll do is I'll just drill the cranial part. Just put a drill and then use the chisel. So I'll mark with my drill, punch, drill, cutting bar petko. I'll mark here. I'm marking my chisel with a drill. So I'm using a regular or a drill used yesterday. Foot pedal ichchara. Foot pedal.
You can use osteotomy also.
Yes, yes. But what I just outer cortex I just, because here it is already bifid, it might wobble a bit. So that's why I just outer cortex I cut. It will be easy for me.
Actually, we are making a new chisel also, which will be better for these osteotomies.
Yeah.
Because osteotomy, the issue is it doesn't displace your bone.
Bone, yeah.
Once you use a chisel, it cuts and separates it.
So once I do this, so I've done you can see the entire thing is already, that's the inferior part of the lamina, cranial part of the lamina, curate. So that's a cranial part of the lamina. So here I now need not give the cut here. The only reason why I am doing all these things is to get a good graft. So if graft is not a issue, you can remove, you can drill, you can piecemeal, remove the by piecemeal. Again, removing piecemeal take lot of time, lot of hand pain. So now you can see an entire bone I can remove in one piece, the chisel.
Yeah.
Now I use the chisel, this chisel here, straight here. So you can zoom in on the chisel here. Can you zoom in on the chisel?
Zoom the camera.
Cameraman. ఇక్కడ దీని మీద జూమ్ చేయది ఇది దీని మీద. Can you see the?
Yes. Yes.
Can you see it?
Yeah. Yeah.
So what I am using is it's a straight. There are two types of. The one is a curved one. Curved ఏమా curved ఒకసారి చూపించు. ఇక్కడ పెట్టరా, ఇక్కడ పెట్టు, సైడ్కి పెట్టు. So you can see here this is a curved one. ఇట్లా పెట్టు. It's a curved one. This is a curved one. This is a straight one. So you want to use a curved, you can use curved. So I'm just using a straight one to first. You can see there. I'll just put my assistant is just tapping. He will just for the marking. We will not go through and through at one go. We'll just. So we'll just mark it so that later we can use force. That is the edge of the bone. Yeah, sir. So now I have gone through the cortex here, then I'll go deeper. Yeah. Get here. Yes. So you can see now.
Yeah.
It just broke there. So I'll just use for some more force. కొట్టాలి కొంచెం. పోవట్లేదు కరుడేమో. I'm using a curved one. So just
now it broke. Yeah.
Okay, so now it broke here. So what I use is, you can see here that's a fat.
Okay.
Can you see the epidural fat?
Yes. Yes. Yes.
It's a medial epidural fat. So I just lifted it off from there. Then now remaining bone I just lift it. Cure it. So now I'll just lift it off from the cranial side first. So I'm just lifting it off. So you can see that's a fat with the epidural fat with the vessels. So I coagulate that just below the pars. That is a. Mahisha, can you see this?
Yeah.
Hello.
Yes. Yes.
So this is a.
Yeah.
This is a tissue below the pars, so I'm just coagulating it. So I'm just, because I don't want to bleeding later, so I'll just coagulate that vessels before I strip it further. So now I lift it further from the joint. I'm lifting it from the joint now. The joint I'm lifting it. Can you see I've completely
Yes, it's very nice.
lifted now. So I'll just coagulate the vessels. I don't want my field to be RF. ఏమేం పాప ఈరోజు So that's a bone there. So I just go, can see that the pars defect just lifted there, cutter, yes, small. So now I'll lift the cutter inferiorly. So this is just because I'm showing that it's just little bit slow, otherwise could have lifted it faster. I want you people to understand what we are doing punch, so that I'm spending some time to show the anatomy there. So now I'll just go medially and inferiorly, lift it. So lift this now from the joint. So joint is lifted. You can see this is SAP here. This is superior articular facet.
Yes.
So now we have to go medially and detach the ligament. So this is medially. I am just pushing it so that I can detach the ligament. You can see the ligament there, which I
Yes.
will detach it from R with the curette. So once it is done, then our entire bone is bubbles ఎక్కువ వస్తున్నారా curette. So now I'll detach it from the medial line. So it is easy to lift it off and do it from this side. So I just lift it off. I just lifted the entire, this one to just to disconnect the ligament there attached to the bone. Cutter istam. First naku punch you. So I'll just lift it off. చిన్న పంచ్ కాదు, పెద్దది ఆరు. పెద్ద పంచ్ ఇస్తూ ఆరు. పంచ్. రే సలైన్ తగ్గించు. You can see the thecal sac there already because you have lifted the bone along with the yellow ligament.
Yes.
So now all we need to detach that yellow ligament little bit so that I can remove the entire bone once. So I just achieve some hemostasis. L5S1 there will be a lot of epidural fat than usual, so causes more trouble sometimes because of the bleeders in the fat are difficult to coagulate sometimes. So now the hemostasis is done. So we'll just try to cut it here. Cutter, medium size. No, sometimes the flavum remains. Here, in this case, flavum has come along with the bone. So, otherwise, you can leave the flavum here. There is no need to remove the flavum here. Punch. Because here we are only doing a pars fracture, not the stenosis. So, there is no need to remove the ligament, curate. So, here just when we lifted it up, it came along with the flavum. So,
Yeah.
so just now this is the edge of the bone. All we need to remove the last bit of yellow ligament and just cut it. Once we are done, then we'll remove the bone. So now I have entirely detached. Just last bit of it is there. Now I detached it. So
Yeah.
entire bone is floating now.
Yes.
Entire around graft will be around 3 centimeter now. So just remove this ligament also. Holding the bone becomes easy. You can see I am just stripping off the yellow ligament from the floating bone. Punch, mamul punch. Cutter. So very thick ligament there. So just I will not put pressure on my instruments here.
Dr. Sukumar, why
Yeah.
not just take out the whole thing together right now?
Yeah. What happens is holding the bone because of the ligament, the bone slips.
Oh, okay.
So I want to have a good hold when I am removing it from the incision. So that's why just removing the ligament so that I can hold it properly. So we are coming up with some instruments. Maybe Mahesha has to help us. So we can hold something like Cocker's or Alice forceps, where we can hold the bones and remove it easily. So now the entire bone is there. Babu put video person Ramanali. వీడియో వాళ్ళు ఎక్కడికి వెళ్ళిపోతున్నారా? ఇక్కడే ఉన్నావా? సో ఇక్కడ ఫోకస్ చేయాలి. ఇప్పుడు మెయిన్ మనము కావాలంటే టాప్ లైట్ వేసుకోండి. భాస్కర్ టాప్ లైట్ వేసుకో. సో నౌ ఐ విల్ రిమూవ్ ద ఎంటైర్ బోన్ నౌ. సీ ఇట్స్ అ ఫ్లోటింగ్ బోన్ నౌ. The entire bone is floating. So I'll just hold it and remove it. Then we'll see the anatomy. Pancham, bone punch. See, you can see there bone punch. పెద్దగా ఉండేది అన్నిటికన్నా పెద్దది. So this is a local custom made bone punch. So you can see I'm just removing it. I'm coming out here with the
cannula. You have to remove with the cannula. Yes.
Can you see?
Yes.
Can you see here, everyone?
Yes.
The big fragment, big bone, I removed it through the punch. Can you see it? It's how
Yes.
big it is. So
Yes.
it forms a good graft. The lamina pars. This is a pars defect, which you can see the pars defect. This is a lamina medial
Just you
border.
can put a scale.
Yeah.
And show them.
Yes. Now we'll అక్కడ కేసు ఇండ్యూస్ చేసేసుకోమన్నా. రే బాబు సలైన్ తగ్గించు. Ma'am, hanga edtilla patient. Yeah. So now we need to identify the anatomy, so which will do it now. Here we have removed the pars, which was the defective, the lamina. So definitely below the pars is the exiting route. So there is no need to see that, but because here it's a demonstrative surgery, we need to understand where will that exiting route come here. That I'll just show you.
But Dr. Sukumar, in lyticlistasis, they're saying it is a surgery of exiting nerve root. So we must see the exiting nerve root in lyticlistasis.
So I'll just show you, because we have removed the entire, the pars. So below that will be that scar tissue, that's the gills tissue, which have to be removed. I'll show you how that tissue looks like, and we'll remove the tissue also. So in a minute I'll show you that tissue also and remove that entirely. Once I'll just do some hemostasis.
Okay. So what is your RF setting right now?
20/20, Maisha.
20, okay.
So I just now the moment we remove the inferior articular facet,
okay, SAP will now.
You will see the superior articular facet. So this is.
Do you do osteotomize or you will do?
Yeah, we can either way do it. We'll see. So this is a superior articular facet.
Yes. Yeah.
So I'll show you anatomy one by one. So this is a venous lakes. In open surgery we see this venous lakes bleeds a lot. So just coagulate before you touch them.
Sukumar, when there are sometimes what happens, there is lot of
Can you be louder? I am not able to hear you.
Yeah, I am Dr. Ankit.
Ikkada sound penchmandra idu.
Can you hear me? Can you hear me?
Yeah, now we can hear
Dr. Ankit is here.
Yeah, Ankit
so I was asking, what happens, there is sometimes, there is lot of fibrosis at the pars defect.
Yes, we are going
to see which is compressing the exiting route.
Yes.
And if it is compressing both the sides, so what would be your plan? From one side, would you like to decompress it from the other side also?
Yeah, you can go over the top and decompress the tissue.
Okay.
Decompress the exiting route, right?
Yeah.
So it's very easy.
All right.
So now you can see the other end of the pars. I'll show you the other end of the pars. Someone was, you were asking that gills tissue. So you can see that this is the other end of the pars.
Yeah.
Can you see the other end of the pars? So this is a defective.
This tissue and bone has to go.
Yeah. So this is the other end of the pars. So just remove once. Left, remove that white tissue which you are seeing. That is a tissue which was there. So this is a. So this is the other end of the pars. So I'll just remove this soft tissue and we'll see what is there beneath. So just go with the upcut. I'll just go upcut, and if a pars projection is still there, we can even do that removal of that part also.
Yeah.
So I just remove this. It doesn't look so fibrous, or it's not a typical gills tissue.
Sure, yeah.
Yeah, so it's not a till. Here the patient
typically of instability patient.
Instability pain rather than the exiting route pain.
Yeah.
And the radiculopathy was probably because of the small disc prolapse.
Yeah. And when you remove that bone, I think exiting route will see this below that bone.
So I'll just remove this bone. Before that I'll take a X-ray shoot so that I need to see how close we are to the pedicle. So my upcut is going easily, so obviously it is not a pedicle shoot.
It's bone, yeah.
Okay?
Yeah, it is
so
bone.
Just I remove this small piece. You can see the exiting route below. I'll just show you once I remove this graft. Graft cheskomannu. I'll show you the exiting route in a minute. Can you see the exiting route?
Yes, yes, yeah. Still that bone can go.
So that's the exiting route. So the advantage here in this technique is you follow the exiting route, even it exits the foramen, beyond the foramen you can follow it. That's a big advantage. Without bleeding, any MIS technique or open technique, because of the muscle there, we cannot decompress the root laterally properly beyond the facet. Sometimes it becomes too tedious. So you can see here the entire root is free in there. And there's some tissue here, we can just remove it. Stop. On. So there is some yellow ligament and some fibrous tissue just sitting here. I'll just upcut them. So, sir. Yeah. Yeah, see, to be safer, you take more down, then you can confirm and do a upcut. So, anyways, with upcut, you get a bone graft also. So, the question asked by Dr. Ramesh sir was, what he was asking is, in a non-pars fracture case, should we take the cut always flush to the pedicle? No, because as a safety measure, you can take little bit inferiorly. Then, if necessary, you can do a kerison there.
Kerison, yeah, always use kerison.
So, you can see now, that's the exiting road, that's the traversing road, there's a big space
Axilla,
here.
yeah.
So, now I'll just clear that fat and I'll see whether to really we need to touch the superior articular facet, because here it is way down.
Yeah.
So, I'll just show you the superior articular facet.
You just need to cut deep and you will get good space.
Yeah, so I'll just, I'm taking, this is a superior articular facet.
Yeah.
So, curate. This is a superior articular facet. I'll just delineate the medial border. This is the medial border of the superior articular facet.
Yeah.
So, medial border.
Yeah, tip. Yeah.
So, this is a medial. Again, when you take a upcut here, always see how much down you are going. You should not drill or chisel out the pedicle, inferior pedicle. So, I just hold it, shoot. Can you see that?
Yes.
I am off pedicle, so I can just go till inferior, so no problem. Bone. So I am just to tell my sisters that I am giving the bone piece so that it not be discarded. So can use it for a graft. So just take a graft, more graft here. So once this is done, then we go have some own techniques. So I'll just show you the techniques, how to do it.
So sometimes I use ball tip probe to see the pedicle down.
Yeah.
How far so we can we don't end up removing too much.
Yes. What I am trying to make here is to make my 10 mm cannula go inside and sitting in that space.
Okay, great.
So that it was easy for the cage.
Yeah, and safe.
Yeah. And one more landmark is, as you come towards the pedicle, the ligament ends there.
Yeah.
So when ligament is ending, so be careful that you might injure the pedicle. So these are some pointers. So I have done a good space there. I have created the space. I'll just once I coagulate this. So I'll just remove this fat and see the disc surface. So I'm just coagulating this venous lakes, which is a cause of bleeding, hematoma, later date. Just cutter small. So
Sukumar sir,
yeah.
Rakshit here.
Yeah.
Till what grade of listhesis can you use this technique? For grade 2, grade 3, can you use it, or would you prefer to put in this?
Mahesha and Abhinandan always say the reduction is mainly with pedicle screw. The majority of the reduction is by the pedicle screw when you have a grade 2 or grade 3 listhesis.
So you would put the screws first?
Yeah, you put up screws first and try to reduce as much as possible. We have done till grade 3 with this technique. So been very successful. We have posted the case on base also. So most of the time it is possible if you have a good technique of reduction. So it is more to do with the reduction rather than the proper discectomy, annular release. That takes care of your 80% of your reduction. Next is the facet release. So even if that is not happening, you do a facetectomy unilateral and do a contralateral facetectomy from over the top.
Yeah.
Then most of the time you can reduce. So you can see you have gone there. Now I am trying to rotate it. I rotated it to see whether my case can go inside easily. You can see there is no bone. So when I come out and look at a panoramic view, there is no bone RF. So then I do some hemostasis. Then I start entering the disc here. So yeah. Yes, sir, because I made a big window, so we can do that. Big window. Okay, see this, and only the bevel is retracting. So the bevel is retracting the root. See, the bevel is retracting. There's a lot of space for the exiting root. You're not touching the exiting root. Now, chisel. What we do is, now I use a chisel here, chisel straight. So I'll just shoot. So I'm in the middle of the disc. So I'll go to the edge of the disc here. Just align pinchal, right? Yeah, end plate. RF. I'll just do some hemostasis so that you can see better. I can understand, but looking there on. We have a listhesis, or you have a mobility, more mobility, where no, most of the time anyways you're opening there, right? So shoot. So just for the sake of good, good this one, I just start entering there. I'll use it like a box. But so it your the work is, you can do any way you want. Here there is no rules. Just why I do this is I can do it cleanly.
You can use the annulotome here.
Yes, yes. Shoot. I'll show some my technique so that you can do it very neatly and easily.
Yes.
This is only to save your punch health remains better. So I'm just removing that entire thing as a box. So that cutter. Then I use a open shaver. So what we use in open surgery,
okay,
that can be used here. I use that. Punch. Once this is removed, then I use 8 mm and 9 mm shavers serially. So there is no root anyways coming in front of me, no neural element coming in front of me, there is no proper visualization is done. So then now I'll go in, use a shaver. So now, because I know that there is no neural element there, now I remove this. You can zoom in here. Zoom in, కొంచెం zoom చేసుకో. I remove the, ఇప్పుడు దీన్ని మెయిన్ ఇమేజ్ చేయమనరా రే. Make the hand image bigger. I am introducing, you can see this is a routine open surgery shavers, open T-leaf shavers. I am introducing the shavers here. Shoot. This is the advantage of going parallel to the end plate. Shoot. Can you see there? So I am just trying
Yes,
to. This is a 8 number. I am just shoot. The 8 number shaver I am using here. 8 number is rotating easily. Then I go with the 9 one. I am taking a 9 the shaver now. Shoot. This also gives us a rough idea of how much a big cage to be used. Shoot. 9 is rotating snugly there, so maybe 10 will also go easily. We can use either 9 or 10, 11 or 12 mm. Dr. Abhinandan is always of the habit of using a bigger cage punch. So I leave it to him the size, whatever he decides I put the cage. Now I am again putting a endoscope here. We can make the endoscope image bigger. ఏదైనా తీసుకోవచ్చు. No, if she is allergic for monocephs, she will be allergic for all cephalosporins. Anyways, you can give a test dose. Cutter. So now we will see the end plates and we will prepare the end plates.
Up to what size shaver can you place through this tube?
Here, because it's a 9 mm inner diameter cannula, we can place 9 mm. We can want a bigger shaver to be placed, then we can use a tubular, bigger tube for the sake of preparing the end plate. Patient disc being bulky here, I will show you easy ways of doing next level preparation. Chisel. Karuda. So I'll just show you gently. Cutter. So here the vision is important, otherwise these floaters will not allow you to see the tissues properly. So if vision is good, When you are using an endoscope, vision is the important thing. When not using endoscope, even these floaters are there, doesn't matter. So when you are using endoscope, make your field tidy, so that you know what you are cutting, what you are not be any injury. So here now, again the punch and the chisel. Just give me some time cleaning this area. I'll just show you. Once we are done with this, so we can chisel, carved. Punch. It's a bulky disc, and patient has some central disc prolapse also. And even with the shavers, this disc was not lifting up because it's very rubbery. So have to little bit hard. The important step only. ఇది ఒక ఇంపార్టెంట్ స్టెప్ అయినాక చేసాము చెప్తామని చెప్పు రామా chisel. What? Punch. So here we need to develop some instruments where we can do these things faster. So like some shavers which can expand so that it becomes faster. Curate is flexible. So first I am doing the inferior end plate here.
Yeah. So Kumar, the question here is, why don't you use shaver here?
Huh?
It will decrease your time. Shaver. Open wale.
That's what I use the 9 mm. 9
Okay.
mm is just rotating, it is not shaving that.
Okay.
The end plates are fibrous.
Okay.
So
Young and it's
so
or
I'm not able to shave off. That's why I'm doing a physical removal. Otherwise, usually it will come very easily.
Dr. Sukumar, the question is, what about a high-speed burr to burr off that edges?
High-speed burr to
burr off this edges so that you can start visualizing the end plates.
No, I'm already seeing the end plates.
No, to speed up the process, why not?
Yeah, you can do that. So what happens is the burr, which burr you want to, diamond burr?
No, the cutting one, the hooded cutting one.
No, we use some mechanical instruments initially under image, which makes the job much easier. So what I do is I put the cannula inside, that will distract the space. You use mechanical tools under image control and ream them, and then the next work becomes easier. You can do this way also visualized, but it takes little longer time.
Yeah. So just it's a matter of 5 more minutes. So punch. So all you have to just be more patient. So you just do a good job. Don't injure the end plate. So now you can see the end plate is visible there. Now we'll go down as anterior as possible. Huh? Chisel. So now I'll just use this chisel more so that I can work from this edge. So punch. One more, if you want, you can put where you want to insert the cage. Through that incision, sometimes I put the bigger shaver, 10 or 11, and you can shave it off to have a faster work. So and just done with the majority of inferior is done. So I'll just show you once this is done. Go to the. It takes 15 to 20 minutes. So just have to be patient there. Upcut. Where it is come upcut where it is. So now we go to the other side now. So punch the upper end plate. So normally the upper end plate, you can see in the X-ray there is a end plate is not parallel here, cutter. It is curved there. So we need to work according to that curve. చిన్నదమ్మ క్యూరేట్ మామూలు క్యూరేట్ యా సో ఆర్ okay, you can see that you see the end plate there.
Yes,
once you see the end plate, it is easy to work. Punch RF. So now I'll just use a increase the vision. These floaters always disturbs your vision, so just
shrink
them so that it will not come in your way in the vision. So just shrink them. Then I use a chisel here because the moment you see the end plate there, you can just use the chisel. You can see now I just rotate my scope, go inside, use a chisel. As we lifted this one yesterday, you can see I am just lifting the. Mahesha is there?
No, he is on the way.
Okay.
It's coming to you.
So you can see here.
Yes.
And just lifting the entire end plate in one go.
Very good. Chisel is good.
Punch. That's a cartilage, end plate cartilage. Just lifting it, that helps removing one piece. It's a very bulky disc.
Yeah, huge. Disc is very large here. So.
Yeah, so Mahesha gave me a job. This Mahesha was supposed to do, but I know the transforaminally you want to remove such a big disc, it is a huge task. So it
Again,
is better.
the iliac crest is very high, so need to.
No, removing the disc, which is a very bulky
yeah.
in transforaminal takes more time. Yeah. Interlaminar it is easy, faster. Cutter. So now slowly you can see the end plates. Now we'll just cutter. Create more space for the graft. I am using cutter just to cut and debulk rather than use a punch and pull it. So it's faster. So it's a disc just below annulus, central annulus, which has prolapsed. Just removing that. And the advantage is this interlaminar technique, you have a control, you can go as anterior as possible and remove the. What we have seen, our fusion rates have become much better with this technique because of the graft we are using is a patient's own graft
here.
And doing good anterior work. So to have a good fusion, you need to have a good anterior clearance. So now I curate on. Now you can see I'll just use a chisel and go as anterior as possible. Use a chisel here. Now go as anterior as possible. See?
Yeah, you can see.
There I'm going more anterior as possible. Removing this end plate cartilage. I'll take a shoot here. Shoot. Can you see there?
Yes.
Yeah. Can you see the MRI? Sorry, X-ray image?
Yeah. It is now almost near the apex of S1.
Yeah. So inferiorly we have done so I removed more towards that side also, so can just cutter. ఒక్క నిమిషం ఏం కాదు కొంచెం ఆగమని చెప్పు నరేష్ని మీటింగ్ తర్వాత చేద్దాం అంతే కదా Sometimes if graft is less, I mix the patient graft with allograft and use it. Allograft, we have a allograft now. There is a bone bank, we get allograft. which is more cheaper than synthetic one. All right. Curate, normal curate. So the inferior end plate distally, that's anteriorly is over. So you can just remove this chunk, punch. Still the anterior annulus is seen. I do it so that there is no more disc tissue there, so that more graft get packed anteriorly. So I am seeing the anterior annulus now. I'll show you once these things are clear. I can see the anterior annulus. Once I am done, so that's the anterior annulus. I'll just show you in a minute. Yeah. I'll just use this side, curate, the cutter, chisel. So use a chisel now, do it inferiorly. Instead of using a curate, flexible curate, getting more pain.
Chisel is good, yeah.
Chisel से अच्छा हो जाता है.
Or it's big and surface area is large, so and sturdy.
Yeah.
Yeah, now that's ALL, yeah.
That's the anterior. Punch. Patkam. So you can see now we have done adequate preparation. We have removed the disc material, which is more than open surgery here. Then check with anterior how much anterior we have gone, or still we need to go more anterior. We'll check with can you see the anterior fibers here?
Yeah.
I'll just show you once I remove this. You can see the anterior fibers better. On. So those are the anterior fibers.
Yes.
The glistening fibers. The anterior most fibers, annular fibers. So just check whether we have gone anteriorly or not. Stop. Shoot. Shoot. So almost we have reached anteriorly. So just remove this curate. So removing these things as anterior as possible gives you a good fusion anteriorly, so that your construct is good, failure rates are less.
Yeah. Nice preparation.
So you can see now anterior fibers. Can you see?
Yes, you can see. Yeah.
Those are the anterior fibers. Once. I'll just show you this, remove the floater. Yeah. Can you see the anterior fiber?
Yes, yes, we can.
That's the anterior fiber. You can see the end plate has gone flush to the annulus. Here also, again, flush to the annulus. So I'll just shrink RF. Now then I'll pack the graft. अभिनंदन बोलो अभिनंदन Abhinandan, curate flexible. We want to put a 13, 12 or 13, 13. So we'll use a 13 cage here, 13, 24. A standard cage, whichever, any 12 we use, okay. We want to use a 12 cage.
So you will not take trial first?
We can't take trial, so we are used to it now. We can't take trial, it's again waste of time. So I'll just show you how to again measure. So now you can see the end plates. Are you happy with the end plates now?
Yes, absolutely.
End plates are prepared well. Now what I'll do is I'll just push this 10 mm. See, this is a 10 mm cannula. 10 mm cannula has gone in easily. Shoot.
Yes.
The 10 mm cannula, I have pushed it inside. So 10 mm, so 12 mm should be okay. Okay?
Yeah.
So I just put a 12 mm cannula. Put the graft inside now. The pack, I will pack the graft anteriorly.
Okay.
Suction. Ikkada chupichali. Ikkada zoom in cheyamandra. You can see the graft here.
Yes, we can.
Can you see the graft?
Zoom it, yeah.
So I'll take some allograft also, so that I can have more.
Okay.
Okay?
Yeah.
So I'll suction. I'll put a కొంచెం జల్దీ తీసుకొని రావట్లేదమ్మా, వస్తుందా? సక్షన్ కొంచెం పెంచండి, సక్షన్ ప్రెషర్. Okay, ready, graft. Yeah, it's okay now. Suction is okay. Just suck out the saline. Just so I start packing the graft now. Yeah. Huh? Yeah, but you can induce that. Ravali. So I'll pack the graft now.
Yes. Yeah.
Papa. Forceps amma. Putting the graft, packing the graft now. Almost 8 to 10 cc I have taken now. So I'll just slowly pack as anterior as possible. Shoot. 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 forceps. Care should be taken that funnel should not plunge inside. Hold the funnel tightly. You can see I am going as anterior as possible and medially. Should. So almost 10 cc I am packing.
Yeah, that's a good amount.
Yeah, because the disc space is bigger. I packed 10 cc now. Normal Jayon peak cage. Normal MIS cage they have a peak cage. Any cage can be used. Here today I am using Jayon cage. Short. Ravali. Short. 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 You can see nice graft has come out of the space and has gone as anterior as possible. Short. Short. Yeah. So I am happy here. I packed the graft as anterior as possible. Now, mop. Mop. किंदे दो उन्होंने
केंद्र निकाल दिया
चेस्ट I don't like blood in my hands. So mop. Now you should see this technique what I do. You see the X-ray now, the entire bone is removed there.
Yeah, facet is nicely removed.
Facet is removed there. Punch. So what I do is where Abhinandan will enter the screw, that one mark I will take, shoot. So normally he takes a lateral entry, shoot. Is this okay, Abhinandan? Yeah. So just here same area where he takes a screw, that area I put a mark. Can you see the mark what I put?
Yes.
This is the opening. This is the mark which is a screw placement, the inferior screw. So there the same port I use it as a my cage placement. Yeah, so it would be according to him maybe superior screw entry. Vachesara. Mop ichese. Cause this. So now I just put a small 10 to 12 mm incision which we take for our screw entry. Give a nick in the fascia so that here the fascia is tough. So just give a small nick in the fascia. Fascia is tough. Lateral. Now here my insertion of cage is visualized. So it's entirely visualized insertion of the cage. So can see the endoscopic image now and also the image of the area of insertion. Both are important. So now just remove any floating particles are there. You can just saline for saline petali. can see nicely the graft is packed and there is some clot inside the space. That is good. When your clot is there, it is better. So you can see the clot there. It is there, sitting there. I don't want to disturb that clot. So this is a graft sitting inside as anteriorly as possible.
Yes.
Now, here what I do is, you can see what I am doing. I am just seeing the root,
Okay.
Exiting root is far away, nowhere near the
Yes, only traversing
RF.
route is here.
This is a muzzle RF. So you see what I do now. Nalladi amma. On. So this only advantage is blind placement sometimes might lacerate the root. We are not sure about. So that's why this technique will just offer you the extra advantage of seeing what we are doing. No, I am not rotating. I am just floating. My cannula is floating. Only my scope has gone inside. Shoot. I'll show you where is my cannula. Shoot. So my cannula is somewhere. My cannula is somewhere. Only scope has gone in. Now what I do is I pass a serial dilators. What we use for a pedicle screw. So shoot. Shoot.
Okay.
Okay?
Yes.
I'll just, this muzzle is there, I'll just, can you see this?
Yes, yes.
So I just put it there. The purpose of the serial dilators, purpose of the serial dilators is to just dilate muzzle so that when case goes inside, it has a memory. So I'll just put this one only to, can you see where just
no, we cannot see.
Shoot. Shoot. ఒక్క నిమిషం ఏదైనా డిసెక్ట్ చేయమ్మా షూట్రా This is just to give some memory to the muzzle. It keeps dilated, so the cage goes easily. After that, I remove that dilators, just to have a memory. So just serially dilated the track. Can you see? Remove the hand and show.
Yes.
Can you see the dilators that dilators are put?
Yeah, under Siam we can see.
Yeah. So it's just to dilate the tract. No, because the length of the handle is not.
Just zoom the patient image.
Patient image,
yeah.
You can see the dilators here.
Yeah.
So can remove that. Remove pieces. Now Abhinandan is removing. Abhinandan has washed now. He will help me. Now what important step, why the advantage of this entire exercise is I always protect the root. Muzzle baga fall avutundi. So this muzzle sometimes falls. This ఏమ్మా డిసెక్టర్ నాకు సార్ కేజీ ఇవ్వండి లైట్ వేయండి కొంచెం కనబడి చూస్తున్నావు కదా బాబు సో నౌ యూ షో ద కేజ్ నౌ అభినందన్ ఈస్ పుట్టింగ్ ఏ కేజ్ హియర్
Okay.
It's a 12 into 24 mm cage. You can see the small taper where it can enter easily.
Okay.
Normal bullet cage which we
normal
use for,
pick cage.
yes.
Yeah.
So So just this part where now, shoot, కొంచెం inferior. హ్యామర్తో కొట్టుకో ఈజీ కదా, హ్యామర్తో కొట్టుకో ఈజీ. షూట్ రాలేదు, చూడు షూట్ చేయరా, కొంచెం ఇన్ఫీరియర్ వెళ్ళాలి. రాలేదు, shoot inferior
little inferior,
yeah. So just he will adjust it, shoot vertic please adjust,
now yeah.
So now my job is to, so here
show
sometimes muzzle is very bulky, so this comes in your way. Sometimes you can cut that, so I don't want to cut here. Just see whether I can do without that small muzzle pieces, because it's just a sake of vision we have to cut it, punch. I'll just remove that small bit of muzzle. Normally because the cage has gone there, it's just vision is getting hindered. Small punch of just remove that. Now you can see the cage.
Yes, I can see.
Punch. So now what I do is I use a retractor. It's already placed nicely there. Without a retractor it will go, but still I use a dissector just to hold the root back. Okay? See now he is advancing. Oblique cheskora, lordotic chesko, lordotic chesko. Wire lettalama, kindiki ravali, inferior. Eniki vachesindi. Kindiki inferior end plate. Yeah. I'll just, root retractor. This is the important part where we can miss and injure the root. So I just retract the root. The moment it goes inside, can you see it is going inside?
Yes.
I'm protecting it. Shoot. X-ray. So now once it goes inside, I just remove everything. So only has to hit. Shoot. Can you see the X-ray?
Yes. Yeah.
Shoot. Shoot. Touching. Sir. Shoot.
Yeah.
One will take a AP. So that part where root should be protected. Otherwise we can, putting blindly most of the time we can be safe, but one case.
Yeah, great.
Can you see the X-ray?
Yes, great.
Yeah. So then again we can remove it easily, but still I will ask Abhinandan whether he is happy with the anterior placement. If he is happy, I will just non-jira. So now I will go in. Because that cage is there, the muzzle is fallen down because of the cage. So I'll just go in. Just what I wanted to show here is when he's removing, nothing happens. It's the design of that handle is such that it is very smooth. Punch, no? You can, you can just pull it out. Just floaters, yeah. So just wanted to show this step is unnecessary, but we can just, you can see there he's coming out. Can you see the coming out?
Yes, we can see.
Just coming out, so nothing to worry. And you can see now this edge of the root. You can see there is no contusion whatsoever.
Yeah.
There is no ecchymosis. There is no bleed on the root.
Smooth
the
retraction,
microvasculature are not disturbed. It means that you have not handled the root at all. And exiting root is far away somewhere sleeping here. So exiting root is nowhere here.
No, yeah.
In the scene. So our work was entirely here. You can see the cage placed anteriorly with a graft, good and scissor root. So here in this technique, the biggest advantages are graft placement. You get the patient graft, you are putting the case visualized, and same time there is a stenosis. We can decompress the stenosis ipsilateral, go over the top, do the contralateral easily. So everything can be done at one go. So now we'll come out. So it took us 1 hour 20 minutes. In 15 minutes, Abhinandan will put the case screws. So less than 2 hours our job is done. Thank you.
Yeah, wonderful.
Once we'll take a AP lateral.
Okay.
Shoot. So you can see there, can you see the lateral X-ray?
Yes, you can see. Make it zoom on the front screen.
Yeah, we'll show you the AP also. Atlepit. So can you see the both images?
Yes, we can see.
We can see the, I think you are happy with the cage position, Bhupesh?
Yes, sir, absolutely.
Yeah, thank you.
Yeah.
Thank
you, sir. Should we proceed with our lectures?
Yeah, just 10 minutes, after change lecture, Mahesh will start.
Okay, sure. So, Mr. Naresh?
Yeah.
With Dr. Kailas?
No, sir. We'll finish that Zoom call.
Okay.
Hello. Max, can you hear us?
Max.
Yeah, I can hear you. Can you hear me?
Hello, Max, can you hear us?
Yeah, I can hear you. Can you hear
Yes.
me?
You can share your screen. So, Dr. Max is a director of spine division at Taipai Medical University Hospital, and is also a director of Biomedical Innovation Center and Asian Spine and Taipai Medical University Hospital working closely. And one of his interests is in advancements in endoscopic lumbar fusion. So we thought, learn from his experiences and see how we can take this, our collaboration to next level. Max, over to you.
Yeah, thank you, Naresh. Hi, everyone. I believe everybody enjoyed Dr. SUKUMAR's surgery very well. And it's my honor to be here to share about this topic, advancement in endoscopic lumbar interbody fusion. I'm Max from Taipei Medical University Hospital. And previously I was trained in biodesign, so now I also lead the innovation center. So this is my disclosure. Here I will talk about three things. First, I think maybe you already know already about some of the history. So later I'm going to explain a little more on the steps too. And the second part will mention about the current advancement and also the evidence. And also the last topic will be about what's the new at present. So since everybody see a lot of modification for the current instrument, so you can see almost all kinds of spinal implant can be modified to use in endoscope. So similarly, you can see with a cage or even the intertestering, and they are now all come to endoscopic for providing less invasiveness. And so start from 1996, you can see with the first endoscopic lumbar interbody fusion, start from them. There's two approaches at present, most popular. One is modified from transforaminal approach, so now become a transcambing approach and process sparing. This approach has good advantage on can be done with less invasive and also less foam preparation, and also have a chance to do a awake surgery, and it's a longer history. And also the other way is interlaminar approach with the now frequently called posterolateral approach, which is facet sacrificing that Dr. SUKUMAR just performed. And of course, unipolar and bipolar now both can use both approach, and it's also because of the advancement of the tools, including the discectomy tools. So evolved from basic procedures So all kinds of tools now have been modified, including a better bipolar tool and a punch, and also the hand drill power tools and the radio frequency. And also for the transforming approach of everybody, I think familiar with all kinds of different tools for preparing the bony camping triangle. And so now you can see some modification of the trapping and also the rimmer. And also now there's some new vibration scalpel to remove the bone with the vibration. And also the laser, of course, the cost is still a bit higher, but also these are all now helping to improve that safety of that surgery of the endolip. Of course, for better cage insertion, now we have several types of retractor and also the bone grafting tools like what just Dr. SUKUMAR just performed, and also the implant preparation tool. So also some shaver hand tools and curette and also power tools now already been innovated, already been invented to help with the surgery, and which now become also important for implant preparation to speed up the procedure, because almost all the time that being used take up like 10 to 20 minutes for this procedure. And then, of course, the other thing is about the fusion and also cage insertion. So in the past, like previous just used a static cage, and of course, some cage was modified into a pulley shape, and also with the expansion mechanism, now there's some commercial cage can provide better disc heights, and also with the composite cage and the plasma spray, and also 3D printing technology, now it can have the chance to provide better bone fusion and earlier recovery. And of course, the advancement of the artificial bone or some growth factors, they are also very important for making this technology become a future practice. So let me briefly introduce that. I think from 2010, there's the first paper about transforaminal interbody fusion published by Dr. Rudolf Morgenstern from Spain. At that time, he used this transforaminal approach and enlarged the foraminal area and can successfully insert the cage. So at that time, we can see it's already the time of the end of the leaf is coming. And of course, now it has been modified, can use unipolar and bipolar. And now it's very popular to practice in many areas. So this, of course, is like I just mentioned, it can provide a faster surgery, less invasiveness, but like previous moderator just mentioned, it's not suitable for some cases with high crest. And of course, it has the difficulty to manage the more severe instability or severe central stenosis less than 100 millimeter square, and extended facet arthroplasty because of risk of lateral recess stenosis, residual stenosis, and so have to select in some cases. And sometimes also need indirect decompression for some cases. And so the surgical procedure now is very common. First start with the transforaminal outside approach, and then use the foraminoplasty tool to resect the SAP, and then do the partial pediculectomy and exectomy, and prepare the implant and put in the cage, whether it is a static cage or expandable cage. Now it's more commonly seen expandable cage because here we are still have a risk of extended injury. So now the modification of cage is quite popular. And so there is a series published in 2016 in by Michael Wang's group. They have performed over 200 awake and live cases, and what they do is use long-acting local anesthesia medication, and also put in the, which is not a cage, but it's a mesh that combined with the BMP, and that can help to reduce the bone resection area. So they found out with this technique, they can have adequate indirect decompression in over 95% of cases. And also they successfully saved the money compared to imatinib, or roughly 15%, which is over $3,000. So this is quite beneficial to the patient and also the insurance. And so with this procedure, now people getting to think about what's the inadequate part. Of course, it's about the residual stenosis or central stenosis. So what been proposed is 2017, this type of very similar to TLF posterolateral approach have been proposed. So now there's some paper already published describing this important point, like the junction of spinal lamina junction and also the pars area, the starting point of the facet resection now have been widely described. So this, of course, can enlarge the size, the space, and help with the contralateral decompression. So the procedure has been published also, both in uniportal and biportal. So this is a paper from Korea. Dr. Kim, he proposed this method in 2018, and they used a biportal technique. You can see the entry of the scope is just above the pedicle, and also the tool and the instrument portal is just below the disc space. And on the left side, it can be just using the center line of the disc, and 1 centimeter in between can set a portal for entry. And for the right side approach, they will need a little bit distal to the target. So the portal, the scope portal will be just on the pedicle of the lower lumbar, lower vertebra, and the instrument portal will be just at distal to the pedicle. So this will also very different from the uniportal approach, but they are very similar in the preparation, including the first putting in the guide wire for pedicle screws and do the facetotomy, what just done, and do the bilateral decompression based on the patient's pathology, and prepare the cage and space, and put in the bone graft and on the cage, and put in the pedicle screws and put in the drain. So this thing now seems quite standard. So compare these two type approach, you can see for transcamping, like I just mentioned, it just cut some of epistolateral SAP, and for posterolateral, it cut the SAP and the IAP, and also epistolateral lamina. So it can do contralateral decompression, and also it can both technique can do indirect decompression, and it can prepare it and play it on the visual endoscopic view, and can insert 1 or 2 cages in both technique, and the synovial injury for the transcamping approach will be a slightly higher, but can be avoided by some method like pin method. And this is now already well known. So like this case, it's a 69-year female with grade 1 L45 spondylosis and spinal stenosis. You can see there is some disc height loss of here, and also the severe stenosis at the MRI. And what we do also similar. I currently prefer biportal technique, so I use the portal that which is for the insertion of the pedicle screw. So I put in guide wire first, and then start to do the facetotomy from the point that I just mentioned, from the Wu's point and to Kim's point. And to spell a procedure, actually now being proposed to start with Kim point, which can speed up the bone resection work. And so you can see from Wu's point to Kim's point, or from Kim's point to Wu's point, we can create a space that with IAP resection and can do the EPC lateral decompression afterwards, and then shift to contralateral decompression and to complete the central stenosis decompression. And then we can see that this space easily because now the bony cabin triangle becomes quite enlarged, and so we can successfully insert the trial under direct visualization. And of course, putting the bone graft by the funnel is very important. After that, you can insert a cage, whether it is a static cage or expandable cage. And then usually I would put in a hemostat just to prevent post-operative epidural hematoma. So this now also being widely used. And the final, of course, input screw, insert screw, and putting the drain from the incision. So the other case is older and have multiple spinal stenosis. And you can see an 88-year-old female, L2, L5 spinal stenosis, and with sponding, and at L45, and the walking distance is very short. So we do very similar with the bipodal decompression for L2 to L5, and L45 we do an endoscopic TLIF, and the patient can stand on the right away the next day. And also for the revision surgery for very old patient, for this gentleman is an 88-year-old male. He suffered from the ruptured disc. So initially we do uniportal transforaminal discectomy. The patient recovered quite well, but unfortunately he have a recurrent facet pseudocyst. So we do the decompression from interlamina first, and the patient recovery right away, but because of the instability, so it recurred again. So for this, we do bipodal posterolateral endolift again. So even for revision surgery, I think this is possible to do endolift. So the current evidence, like in 2021, there's several meta-analysis already show with five studies show that this type of surgery, endolift, it have a better blood loss, less blood loss and immediate back pain relief, but they still have a longer operation time and need a difficult learning curve. So this still very challenging at present, but I think it will improve in the future. And the same year, there's the comparison study shows the better back pain relief and higher life quality and less muscle enzyme and CRP compared to MI TLIF by the Korean group. And also that in 2022, there is a paper compared the uniportal and bipodal approach for the endolift, where they both are sacrificing, and bipodal technique showed shorter operation time, higher fusion rate. The authors think maybe it's because the scope have a wider surgical field and better instrument flexibility and have a better cage orientation. So I think this is still in debate in the future. And of course, the other paper in 2023 is a meta-analysis include 42 papers, and it gives us a great insight that endolift have less blood loss and reduce the length of stay, and there is no increase of complication rates. So the endolift now showing many benefit, like for obese patient and on a higher level patient, higher level lesion and less invasive, can do a awake surgery and have better disc preparation. And of course, still the problem is the training and also the cost. And also it needs a larger multi-center trials to compare both techniques. And so now what we have for innovation, actually there's many new things coming up, like navigation. So Riva Spine and also Joymac, they now bringing the new technology with simple needle insertion. So I believe this thing can, this machine can help with the learning curve. And also now there's some new MRI and ultrasound fusion technology. They are showing reduced radiation and can show the MRI image under the ultrasound. So I think this can also help with the learning curve too. And also that use of augmented reality and mixed reality now also help with the endoscopic interbody fusion. So you can see now the surgeon can see under with the navigation with the scope. And also the AI computer vision now can help to recognize the tissue to prevent the tissue injury or nerve injury during a procedure, especially for the beginners. So this thing will come up to the clinical use soon. And also for now have some newer type of robots with a multi-arm. So this can be performed delicate procedure like suturing. So maybe in the future we can do some annual repair or maybe some small task or some modification of the connection of food or tissue or put in the some autograft or some regenerative graft inside. So I believe this can be our future in the future. So now what we already achieved is we can use in most of the case, and the near future, I think we can use in more extensive lesions, can do complex spine surgery, or even do more tumor cases. And in the future, maybe can do the deformity surgery, arthroplasty, or regenerative medicine. So I think this all thanks to the great minds and in this spine endoscopic field. And we are hoping to bring an idea about our new alliance called Spine Care Innovation Alliance. What we currently do is Narish and Dr. Narish and Dr. SUKUMAR. We are having an alliance for innovation based on biodesign methodology, which is need-driven innovation, aiming to provide better spine care medical innovation. Now we have 7 countries involved and work closely with Asian Spine Hospital and Taipei Medical University Hospital, and we are gonna do endoscopic spine innovation in the coming years. So we are hoping to invite you to join as well. So last, I would like to thank you for your kind attention, and it's my honor to share this topic here. Thank you so much.
Hello.
Thank you, Dr. Max. Any question from audience? Okay. Yeah. Thank you, Dr. Max, for your innovative ideas regarding endoscopic fusion technique. So what do you think the robot, how much he can help for endoscopic uniportal approach in the future?
Yeah, thank you so much. I think robots are present because like Mazor or like Rosa, they are mostly just for needle placing. So at present can reduce the time for needle placement, or can help with our bone resection in some selected cases. And but the problem still the cost is too high for patient, and also now only can use for some steps only. But maybe in the future with multifunctional robots, and like what I just showed, maybe that can perform multi-arm, multi-tools in one portal, then can reduce the time to change the tool, or also combine with navigation. It definitely will help a lot on reducing the surgical time, and also can provide less invasive if it's small, only one portal. And of course now there's still debate for 2 portal or 3 portal with single portal surgery. So, but I think for patient's recovery, maybe 1 or 2 photo now doesn't show much differences. But of course, with the help with the robots, this thing can also in the future can minimize the difference between these one or multi-portals.
Okay, yeah. Thank you, sir. Now we move on to the next lecture. Any news from OR? Case ready है क्या? So we directly move to the operation theater because Dr. Mahesha is ready with his transcambine approach.
Bhupesh?
Hello?
Bhupesh?
Yes?
This is Sukumar.
Yeah, sir.
This is a young patient.
Yeah, this is yesterday's MRI, just show them.
Yeah. So, yesterday Dr. Mahesha did that foraminoplasty, right?
Okay, yeah.
Just we want to show how much foramen has opened. If the delegates remember the yesterday's MRI,
yeah,
we just want to focus on the foramen.
Yeah, focus.
Focus on the foramen.
Okay, it's almost
Can you see
normal,
the foramen?
yeah.
Can you see the foramen
Yes,
here?
yes, wonderful.
So you can see the foramen.
Yeah.
And you can see the fragment which was there in the medial recess.
Yeah.
That fragment has come out.
Okay.
And you see the axial images. See the axial images. Can you see?
Yeah,
Zoom
that
in
SAP
here.
is, yeah,
Zoom
is
in on the
receptive.
facet. First
Okay.
ticket. You see the
pre-op and compare this.
I'll just send the pre-op తీసుకురా. I'll show you the patient pre-op.
And you see how widely you can see the root.
Yes.
So you can just see first here, come from the upper foramen, this is end plate.
Yeah.
See the foramen medially, it has opened up. When you come here, there was nothing seen here.
Yeah.
The disc was touching the facet, entirely opened up. The foramen is entirely free.
Yeah.
The root is gone. The root is completely free. And the fragment is removed.
And also see the facet is so much preserved. There is nothing.
Yes.
There is no violation of the facet, no loss of superior articular facet.
Yeah, articular part is almost,
wonderfully
yeah.
done. Thank you, Mahesha.
How is the patient post-operative?
Patient completely relieved of pain.
Okay.
And the patient has been discharged now.
Oh, great.
So,
put the next one.
The next case, Dr. Abhinandan Reddy will explain. The next case is a young patient, 27-year male.
Okay. 27?
Yeah.
Okay, it's too
so
young.
Intermittently, he used to have back pain. Recently, 6 weeks back, he was playing cricket and he fell down while playing the cricket. So,
increase the light in OR. It's too
hello.
dark. Yeah, now it's okay.
Hello.
Yes. Hello.
Can you hear me, Bhupesh?
Yes, now we can.
So this patient, X-ray. This patient, young patient, fell down 6 weeks back, and since then he has excruciating back pain. So, and radiating to lower limb occasionally, but it is a predominant severe back pain after this fall. Not able to sit, is a software professional, not able to sit or stand. So I'll just show the X-ray here.
It's too dark. Just increase.
I'll just show you the X-ray.
Sir, it's too dark. We can't see the X-ray.
Can you see the X-ray?
Yes, but it's too dark.
Too dark.
Yeah. Background light. Now it's okay.
It's okay?
Yeah.
There is more of instability.
Instability, yeah. More of instability.
So you can see the instability here.
Yeah.
And there is a pars fracture rather.
Yeah.
So there is a pars fracture. Now we don't know whether it is the congenital one which got aggravated or it's a recent fracture. So whatever the reason, the foramen is okay. There is no foraminal stenosis. There is no disc, too much of disc prolapse. Okay. So what Mahesha's plan is, go do a transcambian fusion in this patient. And Mahesha is creating a history here, is using the Globus intralip expandable cage for the first time in India.
Great,
So,
great.
So I am watching with him. So, but we'll do it as a expandable cage which goes through the cannula, and we can expand it. Yeah.
If you see the X-rays and the MRI, the disc height is well preserved.
Preserved, yeah, yeah.
So the
only
disc height
angulation
is
is increased on dynamic view. Yeah.
If you put a solid cage here, there may be some grazing of the root. So that's why we decided to put the expandable cage.
Okay, you need a larger cage if you put a solid cage.
So can you see the table?
No, no.
Focus here, yeah. So we have just marked the lines. So the plan is to put the cage first, so that because many delegates
just
are leaving.
Shows the line little zoom view.
Show this. Because the delegates are leaving, we are first showing the cage, and later percutaneous screws will be put by our Abhinandan. And we will be demonstrating reduction screws in the next case.
Yeah.
So we have just marked the disc in AP and lateral. Can you see the images?
Yes, yes. Now we can see.
So initially I had taken 10 centimeter, but it was vertical. So in that case, what you have to do is go.
Just AP lateral on line and
yeah. So this is the AP line and this is the lateral line.
Okay.
This is the AP line, this is the lateral line. So initially we took a 10 centimeter lateral entry point, but it was going more vertical. So in that case, what you have to do is, don't try to adjust anything there. Take 1 centimeter lateral more lateral entry. Then it will be fine. Our target point is center of the disc.
Okay.
We
can see in CM X-ray.
In both AP and lateral views. Is it clear?
Yes, yes.
So we have put the needle. Give me knife. So initially we make a small incision, stab incision. We don't make a big cut, because if you have to change, then it is a problem. So because we have made a small incision, so it is not a problem. So now I have made the incision bigger because I am sure about my entry point. So the steps are similar to any transforaminal surgery. Only thing is, here the entry point is more medial, because our target point is not the posterior annulus, it is the center of the disc.
Yes.
And that is all the difference, and we will be taking out the disc. So initially when we were trying to put bigger cannulas. But what happens is, if you keep the bigger cannulas in the disc space, retracting the root for a long time, it will invariably cause post-operative dysesthesia. Sure? So now what we do is, we use regular cannulas, nothing special. Sure? Huh?
So what we use in transforaminal
shooting. Go out. Those who are not wearing lead apron, hide behind, or
X-ray. Just change the image of X-ray. We can't see. We just see the needle only.
Yet.
Yeah, now we can see.
So the most important thing is always hit the facet and then go in. Sure?
Okay.
And take a lateral view. So hammer. So you can make only small adjustments about the angulation. So we can't make too much change in the direction or the angulation. That's why we have to be sure about in the initial guide wire itself.
Okay.
I mean initial needle itself. Sure. Can you make out that the disc space is so wide?
Yes, yes.
This is a 7 millimeter dilator, AP. We check again under AP. So the tip of the dilator should have reached the middle of the disc in AP view.
Okay.
Then our entry is correct. Okay?
Yes, yes. Yeah, in the
So
center.
I am using a normal
cannula.
8 millimeter cannula. Nothing fancy. Okay? Sure? Sure. Sure. So I have crossed the medial pedicle line. So we have some mechanical reamers. We will demonstrate different kind of things. We will start with the curette first. Give me the curette for the initial disc work. So, sure. Okay, so can you see the curette in
Yes,
the AP
yeah.
view?
Yes,
Now
we
we
can
take a lateral view. Most important thing is you should not breach the annulus.
Okay.
So you have to see both AP and lateral views.
Okay. Yeah.
So you can feel the end plate and do the curating. For this you don't require C-arm. Sure? Okay. Sister, hold this. Just pull it this way. Yeah. Sure? Okay?
Yes.
So by changing the angulation, I can target the upper or lower end plate.
Okay.
Oh. So, sure? So the cannula has moved.
Moved, yeah.
So, dilator.
Patient is under GA.
Patient is under GA.
Okay.
Sure? Sure? Okay. Sure? Okay. So the cannula is back in. Give me a grasper. This बड़ा grasper है ना? नहीं नहीं बड़ा grasper. नहीं नहीं बड़ा वाला नॉर्मल डिस्पोर्सिव्स नॉर्मल ना रोल ओपन का हाँ ये भी चलेगा ठीक है नहीं नॉर्मल डिस्पोर्सिव्स है ना वो श्योर ठीक this is a relatively healthy disc
Okay.
so it will take some time for the disc phase preparation. Sure? Give me the reamer. So we will try with the camera. Can you focus here? Okay. This is a expandable reamer from Globus.
Yeah, make that view zoom. Yeah.
So when we rotate, it will increase up to I think 15 mm and 14 mm, and you can see, and it has marking here. Exactly, it will tell you how much it has expanded. Okay.
Okay. Yeah.
So just rotate clockwise. It opens up. Sure. Sure. Okay. So sure. Sure. Just try to pull it out. Sure. Sure. Okay. So now we open up. Sure.
Okay.
Sure. Can you see it has opened up?
Yes.
Hello?
Yes, we can see. Yeah.
No, you are not seeing the X-ray image. दिखाओ होता है. You can see the images?
Yeah, both
okay.
we can see.
Sure.
So again, you are expanding.
Sure.
Okay.
So it has gone up to 13 mm, sure.
Okay.
So I
Moving
can
smoothly?
feel the grating.
Okay.
Sure. And I think it will go almost up to 14 mm, sure.
Okay.
So we have done that, and now we rotate anti-clockwise and take it out and clean the disc. Clean. आपके पास स्टिकर है कुछ स्टिकर some sticker to mark here हाँ sure हाँ थोड़ा कट कर दो short हाँ so these instruments have markings, so once you know the depth, you don't have to check every time. Curate. Clean. Curate. Curate. Shoot.
Yeah, now we can feel gritty. Hello.
Can you hear the grating
yes,
sound?
Yes, we can hear.
I don't know whether you can hear.
We can hear, yeah.
Hear there, clean. Yeah. Hi. Okay. They have curates? Sure. Okay. Sure. I'm using normal curate. We have expandable curates in the set. I mean flexible curates. So sure. Hello?
Yes,
Can you hear
sir.
us?
Yeah, we are with you.
There was temporary disconnection.
No, we are with you.
Okay. So this is another instrument.
Okay.
Plum globus.
Okay. Okay, just.
So I hope you can see this.
Yeah. Yeah, like flexible curate.
1 minute. Sure.
Hello.
Clean. Sure.
Sure. Mask local tape it. चले चलो.
Sure.
केस सर्जरी में है बोलो. Okay. So here now Mahesha is preparing with the
मेरा रिमर दे दो.
Curates, which are bendable curates.
So we will be using now our Indian-made reamer.
Okay.
So This is
zoom it little bit. Okay.
Another instrument which opens from 5 mm to 15 mm.
Okay.
When it is fully opened, it is 15 mm.
Shows the tip, yeah.
Okay. When you close, it is 5 mm.
Okay.
Sure. It is in. So we open it. Sure.
Yes.
So this is 9. This is 12. Sure. Sure.
So how much now? 13?
Yeah. This is almost 14 mm.
Okay. Show the continuous view, Siam.
Sure.
Sure. Fluoro, I will not.
Fluoro. For few seconds. Just to
I am
see.
not SUKUMAR. Sure. I will not entertain every request from you. Sure.
So here being a bigger space, almost it's a 14 mm. So.
But it prepares very well.
Yeah.
You can hear the grating sound.
Yeah, we can hear.
And edges are very sharp. Sure.
Akkada now we'll see the Abhinandan has completed the OT1 Siam, OT1 screw placement. Just we want to show you the
final fixation.
The Siam image end point of the morning first case.
Yeah.
Can someone show the first image?
Yeah, we can see.
Can you see the disc?
Epilateral.
Yeah.
Can you see the image?
Yes, yes, yes. It's good.
This is the final of the morning case.
You see?
Yeah.
So we have done.
Our
And,
better hai.
Yeah. Thank you.
Yeah. Thank
so
you.
now, Mahesha,
You see the amount of disc coming out after our reamer? Can you see here?
Yes.
Can you make Mahesh's screen central?
Yeah. Now.
Yeah.
Change.
Can you see the disc?
Make that patient view larger.
Yeah. You see, we can remove very good amount of disc because these reamer edges are very sharp and they remove more disc.
Yeah.
Yes, yes, yes.
Okay. So I am not checking Siam because I have made a marker here.
Okay.
एक बार curate, normal curate. I am afraid whether it will break. Normal curate बड़ा. नहीं हाँ.
Karan राले
Sure.
Ask him to call immediately. ಸ್ವಲ್ಪ ಕ್ಯಾನ್ಲ ಒಳಗೆ ಕಳಿಸಿ.
So I can hear the grating on both sides.
Yeah.
So, sure. Sure. So we will put the scope now. So final preparation will be using the endoscope, water. So थोड़ा पानी का प्रेशर बढ़ाओ.
Pressure बढ़ाना. Pressure बढ़ाओ.
Can you see the endoscopic?
Yeah, make it large here.
Give grass पर बढ़ाओ.
So because he has done a good end plate preparation.
नहीं बड़ा वाला.
लंबा वाला. Normal grass पर.
Normal grass. Endoscopy का. नहीं इधर है ना. हाँ ठीक है.
हाँ. ಫೋಕಸ್ ಆಗಿಲ್ಲ ಅನ್ಸುತ್ತೆ ಸ್ವಲ್ಪ.
Can you take one AP shot? just to see where we are. Okay, fine. Grasper. So you can see that when we put the scope, still there is lot of disc material inside. So only if you put the scope and prepare, your preparation will be complete.
Okay.
एक मिनट थोड़ा अंदर जाते हैं. हाँ, ग्रास्पर. Sure. Okay, grasper.
So ECG.
This being a young patient with a good disc height, there is lot of disc to be removed. Just come out.
So that's why I was telling in the morning, transforaminally, if disc height is preserved, so you need to, in transforaminal approach, you will have a lot of time, it takes lot of time to clear the material.
Yeah. So I am using a curette to free this disc up and take it out.
So here if you have some mechanical tools, it will be more faster. So because the endofusion, both transcambian and interlaminar approaches, posterior approaches and posterolateral approaches are becoming more popular now. So definitely more tools will come in future where you can do these things faster to avoid the punch time, the time can be saved removing this disc material, and if you can remove it mechanically, it becomes more faster. So 10-15 minutes you can complete the entire disc preparation. So definitely things are going to be better in future.
Correct.
But you need to keep lot of patience. So here it takes little bit time. Need to understand the angles here. So it is what AP lateral needle placement he has done is entirely different from what we do for the disc. Yesterday he took 16 centimeter for the disc. Today he has taken 10 centimeter. So the entire the angles change when you are doing a fusion. As Dr. Lokande was telling yesterday, the first wave when Dr. Anthony Young was describing as a way of doing the disc earlier, early 1990s and 2000. So it was to land in the center of the disc and debulk it. So that is again becoming popular now to do a disc removal and place a graft and a cage. So the entirely the concepts change, evolve, again re-emerge, re-evolve. So we need to adapt and develop more innovation will add. So people like Naresh will help growing this field further. So that more innovation is needed, more partnership with engineers is needed, where collectively we can do things better. So I am fortunate that we have Naresh with us.
Curate? Grasper?
So what is, because the patient is young, so the disc is very rubbery. That's the problem. It's not a degenerated disc. If a disc is degenerated, it is easy to remove. If disc is not degenerated, it's very difficult. So
Yeah, even when you do a normal discectomy, in a young patient it takes time.
Yeah.
Because it won't come out easily because it's not degenerated. Curate. What you can see is the lower end plate is getting cleared, and we follow that.
So now you can see the end plate is prepared. The floating things, if we shrink the floating things, you can see the end plate was already seen there. So started visualizing the shrink
RF.
end plate ಕಾಣಿಸುತ್ತೆ. So here because of the shaving already done, so you can see the end plate. Can you see the end plate?
Yes, sir. Yes.
Okay.
You can see the end plate nicely there. It's prepared nicely.
Stop. Grasper. So that is the lower end plate what you see. Because the space is so big, it took almost 14 mm reamer. So a lot of disc material, and this cannula is also floating inside the disc.
We have to
curate.
We have to put a 14 mm.
Yeah. No, that it expands to
30.
Can you show one cm? Oh, it is. I have to come out a bit.
8.
Okay. Sure.
Expands to 40.
Sure. Sure. Okay. Curate. Grasper. Clean.
ಇದು ಕೇಸ್ ಆಗೋ ಟೈಮ್ಗೆ ಅದರಲ್ಲಿ ಇಂಡ್ಯೂಸ್ ಮಾಡಿಸಿ
ಓಕೆ ದಿಸ್ ಗೆಟಿಂಗ್ ಬೆಟರ್ ಆಗುತ್ತೆ ಹೆಲ್ದಿ ಡಿಸ್ಕ್ ಸೊ
ಅಲ್ಲ ನಾವು ಕೇಜ್ ಹಾಕಿದ ನಂತರ ಅಭಿನಂದನ್ ಹಾಕ್ತಿರ್ತಾರೆ ಅಷ್ಟೊತ್ತಿಗೆ ನಾವು
ಎನಿ ಕ್ವೆಶ್ಚನ್ಸ್
ಹಲೋ ಭೂಪೇಶ್
Yes, sir.
Anybody there?
No, we are seeing the surgery, sir.
Yeah.
Okay.
No, there's so much silence there. So
No. Everybody is carefully
we
watching.
can even use this cannula multiple times as a curate. Bevel of the cannula itself can be used.
Mahesh and
Yeah.
Suku, can I ask a question?
Yes, sir.
I had one rare occurrence of a contralateral foot drop happening following an MIS T-lift. Have you had any episodes like that?
Contralateral?
Foot drop.
We never had, sir.
With the endolift?
No, sir. No, we don't see the root first. We will see it in the end. Curate. Curate.
Naresh,
sir,
if Globus guys are there, please send them early. They are not here in the theatre.
Anyway, it doesn't matter. We know how to put it. We have already seen it. If they come late, they will not be there, that's all.
No, we told them that it's a third case, so gone. Gone for the lunch.
Then could
You
Praveen
can
also
see
is
some
here.
end plate bleeding.
Yeah.
Clean.
So we did one case with Dr. Praveen day before yesterday. Case went very well, and patient is discharged today. So thanks to Praveen, and today we are doing live, and ask him to come.
So the Globus people are here.
So now the upper end plate is started. It's a visualization now. You can see the upper end plate.
Curate?
Okay.
There is curate.
मुझे दे दे रही.
There is some bleeder.
Tension मत ले, वो आ गया.
So let me see.
नहीं ठीक है तो. So here the curate plays a crucial role.
Grasper.
The articulating curate. Articulating curate plays a crucial role, so that end plates, visualized end plate preparation is much better in transforaminal.
Earlier, all our curates used to break.
The biggest advantage of transforaminal, the transcambian fusion, what I have seen over years, is the cage never comes out. There is no pullback of the cage because of the obliquity we place. So that's a big advantage of transcambian, what I have seen.
I think the cage placement is best with the
transcambian.
Curate.
Mahesha sir, this is Dr. Puneet Rana here.
Yeah.
Sir, can I ask you a question, sir?
Yeah, very much.
Sir, we have seen both the varieties of the fixation, endofixation, the transcambian as well as the interiliac, the medial approach. Sir, will there be still some patients in which still the place for MIS TLIF will be alive? For example, in the L5S1, in which the disc space is very less, or they are fused with each other.
Correct. No, in L5S1 we can do interlaminar easily. Dr. SUKUMAR has demonstrated.
Sir, if the disc space is very less, I mean, we have seen that the canalize...
Whatever may be the disc space doesn't matter.
Sir, in that case, what will be doing?
Because dilator will distract it.
Dilator, right?
Yeah,
thank you, sir. Thank you.
Because even 2 mm disc space can be increased to 8 mm.
Thank you, sir. Thank you very much.
Once the dilator goes in, it will expand the disc space. Grasper.
Hello, sir. Sukumar, sir, there's a question for you.
Those things are not required. Once the moment needle goes in, put a dilator and just hit it. It easily expands very nicely. Most of the time, without injuring the end plate. You should be parallel to the end plates. The dilator goes in. The tip of the dilator goes in.
Here, because we are putting a expandable cage, there is no need to do too much medializing anelotomy. But if you are putting a normal solid bullet cage, what we do is we medialize the anelotomy so that stretch on the root becomes less.
Sukumar, sir, there is a question for you.
Hello.
Hello.
Yeah.
Sir, if the reason for this pars fracture is acute traumatic versus congenital, will
no,
the treatment
this is not
be same?
a acute traumatic pars fracture, because if you see the MRI, there is no change in the posterior structures. If there is a traumatic pars fracture, you expect some changes like edema, fluid collection. All these things are not there. What trauma would have done was it would have injured the disc more.
Will the
And
treatment
cause
be
these
same?
symptoms.
Refreshen the pars.
Will the treatment be the same?
Lysis was there before itself.
Probably.
Maybe it would have moved the listhesis little more, curate.
Yeah.
And that causes back pain, because if you follow up these listhesis patients, when there is little more movement of listhesis, they come with back pain, and then it stabilizes.
Had it been a traumatic fracture, will the treatment be the same?
Yeah. So we have published last November. We have published in JMIS. So traumatic pars fracture also can be done the similar way. It works very well. Either you do interlaminar or transforaminal. It is up to you, but endofusion works very well in traumatic fracture also.
What about the adjacent segment disease in future, sir, at the young
Adjacent
age
segment
fusion?
disease, what in our experience, Mahesh has done around 100, I have done around 100 plus cases. Till now, that adjacent level disease is not seen in our 200 cases experience at least. So
it can come because it is a little early.
Yeah.
Because
So
it comes after maybe 3-4 years, and other thing is the more levels you fuse, there is more chance. Because we are fusing only 1 or 2 levels, maybe we don't see that much.
And higher the level, more the chances of adjacent segment.
So maybe we are not violating the too much of interspinous area. We are not violating the facets. So maybe the recurrence rate is less. Especially facet sparing transcambian approach, where you are not violating any facet here. That's why maybe the adjacent level disease is relatively less.
Okay, sir. Thank you.
We don't know. We have to wait and see. Because I am doing this since 2018. Mahesh is doing, I think, from 2017. Mahesh?
No, we 18 only. We
18,
are
yeah.
18 only. We
So both are doing since 2018. So we need to see the follow-ups. Till now, we have not got any recurrence or adjacent level. We should see. I don't know about others. I think Varun sitting there also has some experience in. He should also, if he's there, he can comment on his work, his experience.
Yes, sir. With the transcambian, like you rightly said, cage back out I have not seen till yet, and the fusion is excellent. I use G-bone along with the
Varun
graft.
can speak loudly.
Yeah. So I use some other graft material also along with the bone graft. I use G-bone from Surgiware.
Yeah.
So that expands the graft.
Yeah, G-bone also works well.
But then I always put some bone graft also, not just rely on that. Bone graft and some bone marrow.
Correct.
Disease problem we're talking about is typically.
So I take iliac crest bone graft from the PSIS.
Rasper. Octavant. Few more minutes, we'll be ready.
Main bulk has come out.
It was like doing a double level discectomy because this is a 14-15 mm disc space.
Yeah. We can see your
and
struggle.
that too in a young patient. So we had all the tools. Still it took some time because we are doing a visualized disc space preparation.
Also, we should remember that Dr. Prasad was asking a question. Did you see the exiting route before entering the disc space? So there are two techniques again. One is go inside as we go for any disc and start preparing, and while coming out you see. The second thing, preoperatively, if you think a foramen is narrow, then do a facetotomy or facet drilling. As Dr. Praveen from USA sitting there always does some facet drilling before going inside. He does a facet drilling, he lands in the foramen, drills the facet, make the foramen bigger. Once the foramen is bigger, the traction on the root is less, and the case sits more vertical if facet is big. So that is one way of doing it. It's the safety of the surgery increases further. It might take half an hour more, but doing that will increase the safety. As a beginner, better you be more safer. Once you are experienced, you know that you are not violating any area, then it is okay. So for a beginner, if you feel that you might injure the root, better is land in the foramen, drill the facet. So that what happens when you are putting a bigger cage,
graft ready,
bigger cage, so
graft.
The stress or the traction on the exiting root is less.
And can you see the exiting root?
That's the exiting root.
Hello?
Hello?
Yes, we can see it.
Yeah, we can see it.
So you can see the fat and everything on that, it is not violated.
Okay, that's the exiting root.
Yeah. So
earlier, somebody asked about the disc space collapse at L5S1. It becomes critical to do the foraminotomy if the disc space is collapsed and you want to use the dilators to increase your disc space. You have to do a foraminotomy to create the space so that you can
so you have to always
on the disc
stratify
space.
your plan according to the patient. You need not have a same plan for every patient. So just according to the patient MRI findings, you can change your plan.
Graspar.
So I just want to add something on the adjacent segment degeneration. I think it's too short a period to comment on ASD at this point of time.
Yes.
I think a typical ASD, we're talking about 7-10 year period of time, and I think we have to wait, especially when you're dealing with younger individuals. When you're talking about the biomechanics, will definitely play a major role in terms of increased load, and therefore we definitely have to keep in mind that this could be there, but then you have to do what has to be done for that particular process and there.
Even with the collapsed disc space, you manage to get your needle inside the disc space and over the guide wire. As the dilator goes in and distracts the disc space, the exiting root tends to move away, move upwards and away from the side.
Yeah, immediate, correct.
That helps to protect that.
Bone marrow taken.
Give me curate.
ये हमको चाहिए, कहाँ पे मिलता है पूछो.
Some bleeder is troubling there. Okay. So there was a bleeder from the end plate. Gaspar. So you need to have a lot of patience for spine endoscopy. If you had seen yesterday's case, even today's case. So generally orthopedic surgeons are not that patient, and some of the neurosurgeons are also like orthopedicians. But I was lucky to be trained by a neurosurgeon. So 2.5 years I was trained by a neurosurgeon. So I have had the best of both sides.
And you are with us now.
And when I started endoscopies, SUKUMAR joined me, and our partnership is continuing for last 10 years. Accurate? ಸ್ವಲ್ಪ ಇಲ್ಲಿದೆ. Because it is a young disc, it will take some time.
So again, if we had gone interlaminar approach, the disc preparation would have not taken so much time. But again,
it would have taken some time because it is a young disc.
But
Maybe it would have
Again, young
little
patient.
faster.
Again, it will take time for exposure to reach the disc. So I
Yes.
think.
Yes, definitely.
That's
And
what-
the second thing, this patient being a young patient, we don't want to lose his facets, and better is not to touch his facets. There is no foramen
Correct.
stenosis.
Yeah.
There is no interlaminar stenosis here. So that's why plan was to go for a transforaminal transcambial
That's
Yeah.
right.
approach here.
Now we can see the end plates
Yeah,
are
now
Yeah.
superior we
seen
can
well.
see very well.
So little more clearance, we will be done. Correct.
So here also you can go from anterior, opposite anterior, that is diagonally opposite to the posterior most end of the. Again, the best part of the
That's right.
transcambion is if you have a foramen stenosis, you can address the foramen stenosis as well, same time.
Simultaneous, yeah.
And definitely it is less invasive than a interlaminar approach.
Yeah.
Yeah, definitely.
Because you are not violating any of the posterior structures.
Chance of injuring the root also is not there because
Cutter.
सर थोड़ा RF यूज करके थोड़ा विजन
Yeah.
इम्प्रूव किया जाए क्या?
Okay, we will use
this
it.
part is little irritating. You need, I
Yeah.
use sometimes flexible instruments here because that doesn't get held with your instrument. So sometimes I use a flexible cutter here.
Yeah, that is a good option.
So he is debulking the annulus just below
Correct.
the midline, so that the graft can accommodate well there, and the disc can remodel that falls down with a dural pulsation. So
Grasper. Clean.
ఇది ఎక్కడ కేజ్ ఒకసారి చూపిద్దాము.
Clean. Curate. There's some tissue in the lower end plate.
So
Once we
before,
take it out, it will be fine.
Before is Mahesha, as
Yeah.
he is doing the
You can show the cage and how it expands.
cage.
Just focus there.
మను ఈ పక్కన
Give me grasper.
గ్రాస్పర్ అక్కడే ఉంది పాప. I will show the cage, the globus cage which expands the sheath. Sheath, last sheath. So
Curate again.
అది ఎక్కడ పోతుంది? ఇక్కడ ఇక్కడ చూపించు ఇక్కడ. Can you show the hand image bigger here? Can you see the hand image, the video
Yes,
image?
yes, we can see.
Yeah, so this is a globus sheath. After Mahesha is done with the disc, then we'll put this sheath. This is 8.5 mm inner diameter.
Okay.
Is a sleeve of 8.5 diameter.
Inner diameter 8.5, so outer is
or outer would be around 9.
9. Okay.
So the distal sleeve is rectangular.
Okay.
The distal sleeve is rectangular so that it will sit in the slot of the disc space. And this is a cage. You can see the cage here. Already it is loaded in the handle. Can you see the cage?
Yes, yes, we can see.
Yeah, so this is a 8 mm cage which expands till 14 mm.
Okay.
So this goes into the sleeve. We can pass it into the sleeve.
Okay.
So the advantage is that you are not violating or damaging the exiting route. Once it goes inside, we can just expand. Karan idi kada. Just put a expanding this the instrument inside and start expanding. You can see it will expand now I'm
Yeah.
expanding, opening the, can you see the?
Yes, yes.
It is expanding.
Yeah.
I'm just expanding, zoom ikkada. It can expand up to 14 mm. So I'm just rotating it. So the final would be the expansion would be 14 mm. Can you see the
Yes, yes. You
expansion here?
Yeah, yeah.
That's a 14 mm cage which will sit in the slot here like this.
Okay.
So the advantage is we are using a 26 mm length, so that should be adequate here. Now I just again unscrew it. The big advantage of this is we can unscrew it, make it again normal. If your angle, you are not happy with the angle, we can just again unwind it, make it into a previous size, come out and again change the direction and go in again. So that's a big advantage of this case. So this is now made by Globus. Praveen has done, the Praveen from USA has done more than 300 cases now with this technology.
Okay.
We are doing it for the first time here in India. So
there is no provision of bone grafting with cage. So we have to put cage bone graft anterior only.
Yeah, yeah, all around. You can't.
Yeah, it's you can put bone graft anterior, or you can expand it fully to 14 millimeters, and then I usually put an extra small BMP, or if you have bone graft and a collagen, you can sneak it in the cage and then reclose it back to 7 millimeters. And then actually there's holes on the end. You can pull it through the end plates, so it's sitting on the end plates. The collagen is going to sit on the end plates.
So once he is done with the preparation, we'll put a serial dilators. There are small dilators starting from 3 dilators, so that 2 or 3 dilators. Then we can put the cannula and put the cage. So first is the graft placement. Graft we are using today, we are using the allograft with bone marrow.
Want some bone marrow? Curate?
Yeah.
Curate?
So once we are done here, then Dr. Abhinandan,
saline,
our expert, will place the screws. So
press.
So that's the edge of the annulus is working now. That's the edge of the annulus. You want to do some traversing root decompression, you can definitely do it here.
But this case it is not required.
Not necessary,
so
we need not do it. So he has done a very good preparation here. You can see the upper and lower end plates bleeding nicely. It's gone till the opposite end here.
Stop.
Yeah.
Can you take one CM shot?
Shoot.
Shoot.
You can see here is almost gone to the opposite side. That's where we intend to keep the cage. Go to the.
So give me a cutter.
Yeah.
Cutter.
Just debulking further the opposite diagonal annulus till the annulus. Can see the already I can see the annular fibers there opposite side.
Grasper.
So the next case Mahesha will demonstrate his technique of putting a normal reduction screws in the next case. It's a degenerative disc disease with a.
It's a lysis or?
Just degenerative disease.
Okay.
Case transforaminal ಹಾಕ್ತೀರಾ ಅಲ್ಲಿ?
We will see if correct.
Interlaminar ಹಾಕ್ಬೋದು ಅನ್ಸುತ್ತೆ.
Okay.
L5S1.
No, if transformer goes, we'll put transformer.
You can see the shiny opposite fibers there. So probably the opposite end annulus. The transcambian
Yes,
approach
we
is
can.
like a shot of olive, where it's retro-psoas here, it's there it's anterior psoas. So here the obliquity is very good because we are coming away 10 centimeter away. So entry is more lateral. So that's why we can use longer bullets here. If you are using a bullet case, we can use as long as 35 to 40 mm also.
So I think preparation is all right.
I think okay.
So
bone marrow needle.
So one thing I want to show here is, can you see the endoscopic view? So this is my lordosis.
Yes.
So the flat of my T-handle cannula, this is my lordosis. So it is not going flat. So it is about 10 degrees of lordosis here. So when I put the next sleeve, I have to put it in 10 degrees lordosis, otherwise cage will go oblique.
Yeah.
Okay. So we take out this and we put the graft now. Give me a knife. We'll take a bone marrow and get the graft ready. Needle.
ಎಲ್ಲಿಂದ ತಗೊಂತಿದ್ರ?
Iliac crest.
ಶೂಟ್ ಮಾಡ್ತೀರಾ?
No, shoot ಬೇಡ. It's here. So we take some graft from the iliac crest, bone marrow. So just show them the graft. You can see the
this is allograft almost we have prepared here. You can see the allograft here. Can you see the allograft? Make this image bigger.
Yes, yes, we can see.
So
We can see, yeah.
Allograft mixed with the bone marrow now, nicely.
Yeah.
Graft
now
punch
we'll
है, graft punch और
place this graft.
suction है आपके पास? नहीं, dilator दे दो, पानी. Dilator. Okay.
Suction.
So which allograft you are using?
Huh?
Which allograft you are using right now?
Allograft. This
is from Bangalore Medical Trust.
Okay.
Bangalore Medical Bone Bank is there in Bangalore, registered bone bank.
Okay.
We are using that.
Let's hold this. The graft punch. So you can use whatever is available for you. You can use Cronus, you can use G-bone, you can use allograft.
Initially we were using Kronos.
But this works out
this is more
cheaper and better. Because
it's called Bangalore Medical Services Trust.
Okay.
So they using and process these bone grafts. So we have.
So these are basically the bone grafts which we take during orthopedic surgeries, like total knee replacement or hip replacement.
Make this hand image bigger.
It's bigger, sir.
Sterilized.
Yeah, it's already we are seeing.
And dried. So there is no organic material.
Yeah, no
so it can be stored in room temperature up to 2-3 years.
Okay.
So it doesn't require any specialized
So now is
storage.
using an impactor which
Sure.
should
So this will easily take 8 cc to 10 cc of graft. So because it is a very wide disk space.
And one more advantage is the graft goes oblique and more anterior. So that's a big advantage. The graft also doesn't come out.
Yes.
Yeah. Or also targeted exactly with cannula.
So 8 to 10 cc of graft will cost you around 3 to 4,000 rupees.
Sure.
Okay. Sure. Okay. Sure. Okay.
Now almost he has packed 5 cc. Now furthermore he is packing. So around 8 cc is packing today. So I think that is more than enough.
This case there is no way you can put a solid cage here because putting a 14 mm cage is very risky.
In transforaminal. So if it gets
Up
too
to
much
10, 11, maybe 12,
Yeah.
you can put solid cage. But otherwise you have to go interlaminar.
Yeah.
If you are putting a bigger cage, it is safer.
Graft socket.
So in
Sure.
in impactor also you marked or you just directly?
Huh?
In impactor you need to mark because you are not seeing lateral. So you
No,
can
the thing is we have a
rough idea
of
initially-
how much lateral it is.
Okay.
So we don't use any marker.
We
There
can
is
use
marker.
use a lateral image for one time lateral.
Yeah, just so
No,
that
we,
also
we,
that-
we,
sake of
we finish and then take a lateral.
He's in hurry.
Anyway, it is not anterior, so I am very sure about that. Sure. Okay, so sure. Okay, we take a lateral now.
Yeah.
Lordosis ether either.
What is inner diameter estimate?
8 mm, 7 mm. We have to change the sleeve. We put a dilator and change the
Serial
sleeve.
dilators are there.
Yeah, sure. So we
You
are
can
not.
see the
you
graph
see?
there.
Yeah, we can see.
Nicely
Yeah.
see the
We
graph
can
there.
see also.
Just back anterior.
Sure.
Yeah.
Okay.
Yes, yes, yes.
So that's it. So we have to
dilators తీసుకురండి.
put the dilator and sleeve.
అన్ని తీసుకురండి.
So
తగదు బిడి.
Okay.
Next is the You remove that first.
No, we put this and then take it out.
Yeah.
Sure. Okay, so we are putting the dilator.
Okay, you are removing the
for
cannula
the
now.
globus sleeve.
Sleeve. Okay.
Okay, so when you put this sleeve, you know there is a 10-degree lordosis. Can you focus here? So this is if there is no lordosis.
Okay.
So I tilt 10 degrees.
Okay.
So that I am parallel to the
end plate. Okay.
End plates. Sure. Okay.
Yes.
So if you don't follow this step, it will be a problem.
Yeah, end plate can
Okay.
package.
Hammer. Sure.
ಸ್ವಲ್ಪ
ಸ್ವಲ್ಪ ಹೋಗ್ಬೇಕು.
ಇದು ಒಳಗೆ ತೆಗೆದು ಬಿಡಿ.
No, it has
smaller one you can
You have any sleeve?
Yeah, it is there.
Punching sleeve? Yeah. Sure. Still it has to go. You have some hammer?
Hey.
Sure. And it has a mark here to shows the orientation. Just give me mop, it is rotated a bit. Okay. Sure. So I'm just entering this space. Okay, sure.
Yeah, now it is gone. Yeah.
So now it has gone
Now
inside.
it's gone.
Sure.
Yeah.
Okay, the sleeve is inside.
Okay.
I will just pull it out a bit.
Little bit, yeah.
In this case, the space is wide, so it will not break.
Sure.
Sure. Okay, sure. Yeah, that is fine.
So now we can just go
Yeah.
like this.
So this is the orientation. So again, I have to.
Dr. Mahesha.
Yeah.
With that one, you want to turn it a little bit so that you see like a solid lines. It's going to open a little bit obliquely. If you go to the lateral.
No, I can't hear you.
If you go to the lateral on your cannula.
Huh.
AP, take AP.
You want AP?
I got your message, Praveen.
Yeah, it just needs to be
because
oriented
on
on
AP,
the end plates.
This has to come out.
Okay,
that is
okay.
better
Yeah,
seen
yeah,
in
I know.
AP.
Yeah,
then
okay,
we can
okay.
take
Yeah,
lateral.
yeah, yeah.
So
Okay.
that's what he meant. So,
Okay.
shoot. Okay, now
Okay.
you pass it, and it has a sleeve, rectangle sleeve.
yeah,
So,
so
it will go that way only.
yeah.
Whichever way you place the cannula, it will go. Shoot. Shoot.
So
there is something inside.
Yeah.
Graft
Maybe
or-
there is some
graft
graft
or
there.
something. Shoot. You can
Okay.
impact it.
Hammer?
It can happen.
Sleeve may have to be.
No, there's some
okay.
small graft.
Yeah.
Shoot. Yeah, you can
Okay.
hit it. Shoot. That entire thing has to.
Yeah, it has
You are
come
okay,
out.
Praveen?
Yeah, it looks good. You want to check on the
You can
lateral?
go impact.
Some more, or is it okay?
No, no.
Okay,
Check
because
on the
more,
lateral. And once
Okay.
you're through all the mechanisms, so you can expand.
Yeah, now you can
Yeah.
take a lateral now.
Yeah.
And one more point Mahesha Praveen made out. When you are dilating, expanding, it little bit comes
Yeah, I
out.
know.
So
yeah.
you need to be more
Yeah,
anterior.
correct.
So you can little. So now can it's almost anterior now.
Yeah.
Just I'll hold it, help him, and he's expanding it.
Sure.
It's expanding now. Can you see it's expanding?
Yeah, it's
Make the X-ray bigger, X-ray image bigger. Shoot.
Bigger only, sir.
Sure.
Can you see the expansion there?
Yes, we can see it.
Yeah. Shoot.
Yeah.
It's opening up well now. And there is a mark here how much we have opened up.
Sure.
So shoot. Can take one AP also.
And it will torque out. If it
Sure.
Shoot. Yeah. AP. ಒಂದು ನಿಮಿಷ.
Okay. ಸ್ವಲ್ಪ tilt ಇದೆಯಾ?
Yeah, tilt ಇದೆ.
Yeah.
Because it's almost.
May have to rotate a bit.
See, it's
Okay.
almost.
Just lateral?
Lateral.
We need to maybe tilt a bit.
ಇಲ್ಲ ಇದು ಕರೆಕ್ಟ್ ಇದೆ ಮಹೇಶ್. ಇದು ಕರೆಕ್ಟ್ ಇದೆ.
Lateral.
Lateral, this we need to adjust little bit. I'll just do. Shoot. ಇದು ಕೊಂಚ ಲೂಸ್ ಸೇರ.
We'll try to take a true lateral.
Shoot. Okay.
Not very happy.
Shoot. ಒಂದು ನಿಮಿಷ. Come down.
No, it is not true lateral.
Yeah, I know. Shoot. Okay.
Yeah, but
you can expand it.
No.
ಕೆಳಗಡೆ end plate parallel ಇದೆ ಮಹೇಶ್.
No, I feel it is not.
Because you are seeing what yesterday Praveen was telling, the upper line and lower line are the thick line.
Yeah, perfectly parallel.
Okay.
That looks good. Yeah.
It's
okay, no?
It's a parallel.
Yeah.
So it's
Sure.
parallel.
That's what.
It's the end plate.
Sure.
It's end plate which is curved.
Yeah.
Short. Yeah.
Okay, I think
it's
it is
perfect.
Yeah,
good
that's
enough.
sitting on the end plates very well. Yeah.
Okay.
So now just unlock it.
Yeah.
Unscrew.
Unscrew. Okay.
And rock it. full unscrew fully and just unrock. Just rock up and down.
Yeah. Okay.
Shoot.
Sure.
And remove the cannula.
Okay, give me a dilator, normal dilator.
You can put a
Or
scope
you could put the
there
camera
inside,
through
Mahesh.
there.
There is a scope.
No, we will put the scope. We don't want to take chance in this.
Huh?
Okay.
Take the video. On the instrument.
You give some
Give
instrument.
instrument.
Yeah. Okay. So we have exchanged to a dilator and a regular cannula just to see the situation inside. Show. Okay. Show an AP also. No, I was worried.
Acha.
Scope. Light power, saline on, please. Show 1 AP. So the cage position is very good. Can you see the AP? It is in the center.
So here what we are trying to see is the cage position there.
Yeah,
Can you
it's
see the
perfect
cage?
in AP unilateral, in the center.
The cage endoscopic image, can you see the endoscopic
Yes,
image?
we also can see.
Yeah, saline coach increase. That's a cage there.
So the cage orientation is all right. It is
All
sitting
right, what he wants to see is
flush with the end plate. Can you see?
plates, yeah.
Yeah, perfectly.
Okay, so that was the lordosis which we targeted, and the exiting route, there is nothing, no pressure on that, because this is an expandable cage. So you want to put steroid or not required?
No,
So we will not be using steroid also.
Cage is there.
Now
So you can see the epidural pulsations at the
so
top, and this is the exiting route here.
Yeah, this is
So
wonderful.
Naresh,
Yeah.
Sir.
By the time Abhinandan is doing a pedicle screw placement, you can complete the talk.
One or two talks,
Yeah.
and we will,
We'll just proceed with the talk.
Talk
Thank
so
you, Mahesh and Dr.
Yeah.
Sukumar,
So
for your
that
wonderful
we'll,
demonstration.
We'll induce the next case.
Okay.
And our team has created, we have started this expandable case, intraleaf. Thanks to Globus.
Thanks to Praveen for coming here and getting these things.
Thank you, Praveen.
Cost जानना चाह रहे लोग.
Cost we don't talk.
It's like a woman age, asking a woman's age, so we can't tell it. We can't reveal the cost.
Hello, yeah.
So we will proceed with Dr. K.T. Chen's talk on endofusion. I mean, he's an orthopedic spine surgeon in New Taipei City. And also one reason we wanted him to be here is a commissioner of education with Taiwan Society of Endoscopic Spine Surgery. Very much interested to standardize the endoscopic spine training program in Taiwan, and we are also trying to learn from that society how we can standardize in India. So there's a lot of exchange on training programs we are discussing right now, and he was interested to share some of those ideas and also his experience. And one good thing about K.T. Chen is he was being recognized one of the young achiever in PESMIS recent in July 2023 for his work in endoscopic spine surgery. Thank you. Thank you.
Thanks, my friend Naresh and Dr. Sukumar's invitation. It's my honor to be here to sharing. I'm Kai-Ting Chen from Mackay Memorial Hospital, Taipei, Taiwan, and it's honor to sharing some experience about biportal and single portal posterior lateral approach to transcamping approach. And now I do some modified transcamping now. And I also have a topic about posterior decompression on cervical spine and foveal non-rhinectomy, but there's no time. But I hope I could share with you in the future. There's 45 years history in endoscopic spine surgery. Hachikata and Kemping is the pioneer and the creator of this field. And Leuenhauser and do the endofusion in 1996. It's pretty cool. It's the device is external fixator of TPS. So you should place this device outside your body. And there's right side is the endoscope, and right side is the working channels. It's different. It's just like a biportal concept. And nowadays there's a biportal endofusion, a uniportal endofusion. Biportal endofusion is just like the misty leaf. The approach is quite similar. It's a postlateral approach. If you are familiar with the postlateral approach, it will be the learning curve will be very short in biportal endoscope. And the uniportal endoscope, there's two trajectories. One is transcamping and a postlateral approach, just like the demonstration live surgery this morning. First, I want to talk about my experience in bipolar endolip. The approach is similar to the misty leaf approaches. So if you and there's no special instrument needed, so you can use the traditional instrument like the open surgery instrument. And the emperor prepare just like other endoleaf. You can have a great emperor prepare under the scope. You can see it. You can see and cut it down, and you can reserve the autograft. So this is a step of the biportal endoleaf. Okay, the cauda incision is the most important because the distance between the emperor and the incision could not be too far, because if the incision is too caudal, it's hard to place the cage in this trajectory. So the incision is between the emperor and the pedicle school hole, and so it's make more easier to do these two things. And then you can create a triangle because your left hand is the endoscope, and right hand is the instrument, and you use the arthroscope to create a cavity between this instrument and create a cavity between the muscle and the bone, and then burning the edge of the lamina and make your punch more easier to use. And this is a little bit faster. Although the demonstration in the morning you use a chisel as well, but in the biportal you can use a traditional one. So it's much bigger and make your osteotome use faster, and cut it down and cut down the SAP as well. And there's a lot of epidural vein near the surface of the disc, so you can use the arthrocare to hemostasis, and then open the cranial end of the ligamentum flavum, and then do the opposite side decompression and the opposite side lateral recess decompression. This is a point that bleeding the most, so you can use the hook type of arthrocare to coagulate the epidural vein, or you can use the push rod master. You can push a jewel from inside and put the bone wax outside, and then do a discectomy. Okay, so this is about 3 years ago. The first case I do the biportal endofusion. So you can know that this is my first case. So the learning curve is really short. After I go to the Korea to see Dr. Kim to demonstrate, and then I come back to do this first surgery the next week. And then you can see that the decompression is quite well, and you can start to do the discectomy. And the best is that you can see the embryo under your scope. You insert your scope and see the embryo prepare. Okay, so, and then you can see the cage insertion. This is the cord restrictor and see the cage insertion. Somebody will say that full endoscopic endofusion cannot see the cage insertion. You just under the C-arm sometimes. But the bipolar fusion, the benefit of bipolar fusion is that you can see the cage insertion. Okay. So after that, we can see the post-operated X-ray. Okay. And then I shipped to Uniportal maybe 2 years ago. There is a transcambient and postlateral approach, and both have pros and cons. I think the most different is that in the traditional discectomy, your instrument is free, so you can change your angle freely. But in the single portal fusion, you only can go through the small hole, so it's restricted by where you incise. So if you incise to medial, so the discectomy will be more ipsilateral. So I think the transcambient approach will be more appropriate for larger disc repair. So left side is transcambient, right side is postlateral, or the bipolar approach. Okay, the pros of the postlateral approach is that you can do the bony decompression adequately, just like PSLD. But you just can do ipsilateral discectomy. But transcambient you can do larger discectomy. But it just can do the indirect decompression. You cannot, you just use a cage or something to enlarge the foramen and tension the paraspinal ligament. Okay, but the bipolar have a larger disc forceps, so you can see that there's a bonus area that you can remove. So I think bipolar is a little bit, can do a little bit larger than postlateral or the single portal endofusion. So this is a patient I do 1 segment bipolar and 1 segment posterolateral uniportal. So you can see that the postoperative CT and the area of grafting is quite different. Bipolar is larger. Okay, and the grips of traditional disc forceps and the single portal disc forceps is the grip strength is quite different. So when you disc repair or gripping something, I think a traditional one will be much faster. So in bipolar endofusion, yeah. So this will restrict by the nerve and where you incise. Okay. This is posterior incision. This is where transcambient you remove the SAP. So this the pros and cons. I talk yeah. That's this prepare is better in transcambient, and decompression is better in postlateral. Okay, so I use a modified transcambient now. It's transcambient master, but I can do some decompression of the lamina under the trajectory or camping approach. So the most important of all endoscopic surgery, I think hemostasis, breathing is the most big problem for a beginner. In my experience, I think the control of the systolic pressure is critical, because sometimes if you can control under the 110 pressure, yeah, maybe the breathing will decrease. But depends on the patient. If the patient have a chronic hypertension, maybe you will get in risk in a stroke when you get down the blood pressure. And insert 1 milligram of epinephrine into each normal saline bag. This will help you control some small bleeding. And we use the fusion. I use 2 scopes during fusion. One is fusion scope, and one is HIBD scope, which is regular PLD scope. Why we do this? Because I decompress the bony part by the fusion scope, and I insert my scope into the disc and curate the end plate by the sheath by the HIBD scope. And this the final tunnel. I insert the bone graft, the autograft, and the right side is the Harrison guide. It's a is a Korean create protector for the cage insertion. Okay. So the insertion is not as far as the traditional PETD. It's about 8 centimeters, 7 to 8 centimeters from the spinal process. But depends on the patient's shape. Is the patient's fat, maybe the incision will be laterally, and if it's thinner, it will be more medial. You can print it on the MRI. Okay. So this is the my position, hand position during doing the opposite decompression in transcameral approach. So you can see that I rotate the scope 90 degrees to make me see the lateral recess of opposite side more clearly. So you can see that we can decompress the opposite side adequately. And the C-arm can show that we can approach to the far lateral of the opposite side. And use the smaller one sheaths to do the end-plate shaving. So this is maybe it's the surgery 2 years ago. We start from the SAP from lateral and use a burr, use a chisel, or use a Kearson punch. So everything you have to remove the lateral side of the bone. And then you keep going to the central. And then you can see the IAP, and then you keep remove the lamina and the ligamentum flavum. So I saw Dr. Sukumar like to end-brow resection, but I just remove it piece by piece. And if you go to the opposite side, this is the opposite side lateral recess. You can decompress by the Kearson punch. Okay, this is, and now to disc prepare. And I use the sheath to shave the cartilage. I think it's much easier for me to prepare and faster. And you can see the end-plate prepare is quite well. And that is a Harrison guide to protect the cage insertion. Okay. Okay, this is the equipment I have in the endofusion. And this is the animation I draw, and let's use a larger one and go from lateral to the opposite side and change the Kearson punch and change a small one of scope and do the discectomy and end-plate preparation by the sheath, and then use the Harrison guide to grafting and the cage insertion. Okay, this is the outcome about half years after surgery. And you can see post-operative CT, the grafting area is enough, and the decompression area is go to the opposite side. And the post-operative outcome is acceptable, is reliable. So I published this kind of method in the European Spine Journal last month. Yeah, it's talk about this kind of transcameral intrapetal fluid endoscopic lumbar interbody fusion. And nowadays, if you want to do the cage fusion, endoscopic cage fusion, maybe you need some special design retractor to protect your cage insertion if you don't have the expandable cage. Or you can use the pin method to protect the cage insertion. You can insert a pin and protect the root. So there's a lot of expandable cage, or vertical one, or horizontal one, horizontal expandable, or door expandable cage, and there's mesh cage. Okay. Or it's a round shape cage. Yeah, it's more easier for endoscope. The fusion rate in endoscope, I think there's no different from traditional one, or traditional open surgery. The hospital stay is a little bit shorter than the mid-TLIF. And post-operative pain is less than the conventional PLIF and TLIF. But in the long-term outcome, I think there's no difference. in my experience that by portal endofusion, maybe the length of stay is a little bit longer, but the surgical duration is faster than I do in single portal. So there's pros and cons on both kind of technique. Bipolar is faster, learning curve is short, but if you have enough special equipment, maybe endolib is possible and it's easy to use. This is my learning curve, my career. I do the open surgery initially and then shift to misdilative and do the discectomy under scope and do the decompression and go to the endoscope fusion. A lot of young surgeons say that if I can do the endofusion in the beginning, I cannot tell because my career is all of the orientation and concepts is come from the open surgery. Maybe I do a lot of open surgery and I can tell what's going on during you doing the endoscope fusion. So biportal is fast and learning curve is short. It's like a misdilative, but uniportal, if you can find a comfortable way for you to do this, I think is possible and reliable. Thank you. I'm Katie Chun from Taiwan.
Hello.
Bhupesh.
Yeah. Thank you, Dr. Ketiwan, for your wonderful demonstration and lecture on endoscopic fusion. So, anyone in audience have any question for him? So, for your KT method for endoscopic fusion, so you initially try to dock on the facet joint, or initially you dock on the disc directly?
Landing on the SAP first.
SAP first, then you remove the whole inferior and superior facet.
I think in every endoscopic surgery, I think bony part is more safe. If you can find a bony part, the orientation will be more better and make you more safe.
How far you go from midline?
From lateral?
Yeah. How far? Yeah.
About 8 centimeter.
8 cm. Normally, what we do in transcamin fusion, around 8 to 10 centimeter.
How far lateral?
Laterally, from the final process to the incision is about 8 centimeter.
8 centimeter.
It depends on the body shape.
Yeah.
It's a more fat, you will be laterally.
Okay, okay. So, and anyone, that's it.
What is the instrument you use to protect the nerve for your torpedo method?
HS scheme instrument.
Oh, this is a Hessian cage grinder.
Does it expand?
Yeah. It's not solid, it's expandable.
It has a slot on both sides, so when you pass the cage, it just accommodates the cage.
Okay. It will slightly open when you insert the cage. Yeah.
Do you have a video of it?
I don't have, sorry. It's designed by the Korean doctor.
Yeah, HS scheme. Yeah, thank you, Dr. King. So our OR team is ready, or we move to one more lecture? Thank you.
Hello. Now we'll move to next lecture. Actually, the talk was supposed to be first and then expandable cage. But since everybody want to say expandable cage case from Globus, so Dr. Praveen, by now you know everybody about him, and I'll share his experience on. They've coined the term relief robotic endoscopic lumbar interbody fusion. And he has got largest experience in US with this robotic and endoscopic interbody fusion. Over to you, Praveen. Thank you.
Yeah, I just want. Hi guys, can you hear me? I just wanted to go through, the endoscopic fusion, how I've kind of transitioned from doing discectomies, the decompressions, and now we're doing a lot of lumbar fusions, and we started incorporating the robot, not just in the instrumentation for the screws, but also the cage, and made it into one unified procedure. So I just wanted to walk you guys through the procedure and how I do it so that you can incorporate it into your practice. So what are we talking about? Just starting with some generals, what's minimally invasive surgery? It's really, whether you use a tube or the scope, you just really want to preserve as much muscle as you can. Some people talk about it just multifidus preserving surgery. As long as you're not taking off the multifidus from the spinous process, I think you're going to end up having better results. Less pain, less blood loss, all the stuff that we always talk about. And, by this point, everybody here is familiar with Camden's triangle. We're trying to use that for the discectomies. And really now for the endoscopic fusions, I do, all my endoscopic fusions transforaminally. I haven't had the chance to do them interlaminar. So I'm biased because I'm not familiar with the technique. But I think it works. I've done it from L2 to L5S1. I would say, 30–40% of my cases are L5S1, and it works very well. You can get a central cage at L5S1 if you take down enough facet. I also cheat because I can use the robot to show me how much facet I need to take down to get midline at L5S1. But it's doable. Even before we had the robot, it's very doable, just planning it based on x-rays and MRIs. So the typical advantages of endoscopic surgery, we do this under local anesthesia. We do a lot under Versed fentanyl at an outpatient center. You could, same day, they return back to work. And, one thing that we have a lot in New Jersey and New York is high BMI patients. And doing a lot of open microdiscs and tubular microdiscs on somebody who's 300–400 pounds takes a lot of stress. But now, doing with the scope, a 300-pound or 400-pound patient doesn't really bother me. It doesn't stress me out anymore. Whereas with the tubular, once I started getting above 80, 90, and the largest tube I had to use for an L5S1 microdisc was an actual XLIF retractor because it needed to be 140 millimeters. And since that day, I've been doing 100% endoscopic discectomies. So we're going from discectomies to MIS T-lifts to endoscopic T-lifts. Why go there? So some of the results from this article by Dr. Ho, it's a meta-analysis of over 480 patients going through endoscopic T-lift. Similar complication rates, reoperations, fusion rates, and disability index. But what you really see is less intraoperative blood loss, shorter hospital stay, and better long-term functional outcomes. And in terms of hospital stay, 95% to 100 of my endoscopic T-lifts are now same-day surgery. They usually go home about 3–4 hours afterwards. So what are some considerations when you're taking, when you want to start doing endoscopic T-lifts? I prefer grade 1 or 2. You can do this with lumbar instability. You could do this with central stenosis, discogenic pain, or recurrent lumbar disc herniation is probably my biggest indication, and patient with high BMI. A high BMI patient is a great patient to do endoscopic TLIF versus an MIS TLIF. In terms of time, blood loss, and instrument placement, it tends to be much easier and much better for a very high BMI patient. What are some contraindications? I think Dr. SUKUMAR said he does grade 2 and 3. For me, I do grade 1, or if you have severe spinal stenosis, I think you should do interlaminar instead of the transforaminal. Severe osteoporosis, I tend not to do T-lifts. And if you need a significant deformity correction, I feel like lateral cages are still better for deformity correction. So one difference is today, a lot of the doctors are doing AP lateral. The technique that I always use for targeting is an oblique-based view. So I usually go to an AP, get the Ferguson view to line up the superior end plate of the inferior level. If I'm doing an L5S1, I want to be in line with the superior end plate of S1, and then oblique about 30–35 degrees. And what you see here on the needle, placement, I like to stay right on the lateral border of the SAP. That's where I want my cannula, and that's where I want the trajectory of the cage to be. This gives me the highest chance to do a good foraminotomy, take down enough SAP. You can also start You can also start at the anterior border of the vertebral body if you want to go to a facet sparing technique. But if you want to do a foraminotomy, I would hug the needle very close to the SAP, and it tends to also avoid a lot of muscle removal as you land on the bone, and you can immediately gain access to the pedicle. Typically tends to be about 8 to 10 centimeters from the midline, as we talked about. And, and then, in a standard way, I want to advance that needle to the medial border of the pedicle, and I want to check that I'm at the posterior border of the disc. And what do we do next? Then I go with my dilator. I leave a wire there through the needle, and then we go through the dilator. And once you put the dilator, I do the endoscopic work first. I'm not going to bore you with that. We go in with the scope, do a foraminotomy, disc, and we're able to introduce the needles. So you've seen some of these instruments that Dr. Sukumar, the first is the #1 dilator. That's a round dilator, and that's what you can use if you have an L5S1 disc or an L4-5 that's collapsed. That has a very tapered end, and you could mallet that in to open the disc. And if you're not able to open the disc, I usually go back to the facet, do a little bit more fascectomy, go into the joint, and then you can try to go in. And the second dilator is flat end. So once that's inside the disc space, this one also, it's not so clear on the picture, also has a tapered end that will make its way into the disc space and really distract the disc space, and it will stay flat against the end plates. And then you can go in with your third dilator, and that's where a majority of your shavers, all of the working channel is done through the third dilator. And each one of them has their own impactors, so you're not advancing them, and you're able to back these up as needed. And if you don't want to do it with the scope and a foraminotomy, you can go, Globus does provide if you want to do a completely facet sparing approach, instead of going 8 millimeters and staying on top of the facet, you can go 10, 12, up to about 14 centimeters, and you can use this probe to make sure you're not on the nerve before you advance the needle. You can hook this up to neuromonitoring probe. I don't recommend doing this at L5S1. L5S1, even if you don't think you need to take down the facet, I always like to visualize the exiting nerve root. I think a lot of the times the exiting nerve root is very inferior at L5S1, and you should always visualize it. So what do? We can introduce the first cannula, like we said, and the second one goes in line with the disc space, and the third one is your working channel. And you can see two sleeves. Both of them should be inside, past the foramen, and once both of them are past the foramen and at the medial border, I know I can start working. So now we're at the disc. You have a couple of different options. First, you have this reamer that you can attach. If you have a very thick annulus or a patient like today, a young patient that's going to have very sturdy disc, you can open that up. And the other instrument that you see right there is called a disc auger. A lot of times when you're doing an endoscopic TLIF, you get a channel and you're working within that channel. The advantage of the auger is that it can take disc anterior, and then you can actually take it out, flip it, and do take disc inferior to it, so you get a complete discectomy. Then it's a very typical instruments. You can have the shavers, the curettes, you have the disc auger, and you already saw the expandable shaver demonstrated, and that you can dial it up to 14 millimeters. I like to go with a couple of different passes with the expandable shaver instead of going all the way to your desired height. I usually start with a 7 or 8, take more disc out, come out, and then shave again, 2 or 3 passes through until you get to your disc height, and I feel like that gives you the most amount of disc removal. Give the disc a chance to fall back into the middle, grab it out, and then re-expand. And you can also go in with disc brushes. that are provided. And that this tends to really get the cartilage out of the disc and give you a good particular bone. And then you can use your curettes. And once you're done, even you can actually check the end plates. You can go back with the 8.5 millimeter channel from Globus. You can also go with the scope, and you can do visualized end plate prep and disc removal as you need. It tends to show the end plates. You can actually get very good bleeding end plates. You can do further disc removal, as Dr. SUKUMAR said, for bone graft, and you can place it anteriorly. And oops, sorry. And what do we do next? Once the end plate's prepped, you realize it's bleeding, then you can do a trial. You can introduce this trial. It has markers for 26, 30, 34. Typically, you can get 30 or 34 at L4-5 and above. And L5-S1 tends to be either 26 or 30, depending on your angle. And we already had a chance to see the cage insertion. It goes in 7 millimeters and expands to 14. It's an 8 millimeter width, and the sizes are anywhere from 22 to 34, but typically it tends to be either 26 or 30 millimeters. So once the cage is done, one thing that we do is you can put bone graft inside the cage. You can put a collagen-based bone graft that you can sneak in between the openings of the cage, and then recollapse it. So what are the advantages of doing it this way? As we talked about, less blood loss, outpatient surgery, reduced postoperative time, return back to normal activity, and the biggest advantage for me is easier to handle revision surgery. So I see a lot of post-laminectomy patients, and now they need a fusion. I hate, digging around scar, so this is easy. Now you go transforaminal, you'll barely see any scar tissue from the previous laminectomy, and you're able to do a fusion without having a high rates of the dural tears, revision issues. And patient weight. It's a big issue for me. I'm not sure how big of an issue it is in India, but when you have somebody, 300 pounds plus, doing an endoscopic TLIF does not tire you out, whereas doing an MIS TLIF on somebody who's 350 pounds can add at least an hour and a half, and it just tends to be significantly more stressful for the surgeon. And less facet removal. So I think one of the biggest advantages of the endoscopic TLIF is you don't have to do a complete fascectomy, because we're trying to do a fusion for stability, and to me, if we can destabilize the patient less and then add screws and cages for stability, you're going to have a better result than trying to overcome the instability that you created from a full fascectomy. So I feel like that's a big advantage and gives better fusion rates, better functional outcomes. I think comes from the fact that they're so stable. You didn't violate any of their natural stability, and now you've added some mechanical stability. Better visualization of the disc prep, and less radiation. So what next? We put the cage in. We have to go to the posterior instrumentation. There's a lot of different options, more options. You can do open, freehand. You can do navigation. Navigation, as you guys all know, it's a real-time visualization that provides information for us to make decisions. Then the next level is robotic guidance. Involves the placement of instruments and through the pre-planned trajectory that's set by the robot. But if you're in India, you have a lot more options. You can have Dr. Abhinandan Reddy come in for the screws. So, we can do them freehand, we can do them percutaneously using navigation, you can using robot and Dr. Reddy. So why do we choose robotic screws? So if you look at this study from Spine Journal in 2021, you know, safety and accuracy of robot-assisted placement of pedicle screws. It's a big study, 1,525 patients, over 7,000 screws, 69% reduction in complication rates, 92% reduction in proximal joint violation, and decreased radiation exposure. And for me, you know, of course, you want to reduce 69% reduced complication rate and 92% reduction in proximal joint violation. For me, I'm a big believer that this is what causes adjacent segment disease. You're doing percutaneous screws, you don't get proper trajectory, you've poked 4 different holes in the L4-5 facet joint, it has to affect the patient. Same thing with ACDFs. I'm a big believer that standalone cages decreases adjacent segment disease. You know, you're trying to put a plate, you expose a little bit above, a little bit below, you bovie the disc unintentionally, and I think that causes a lot of adjacent segment disease. One of the reasons I changed over to a standalone is the less exposure that you do, the less risk to the adjacent segment. So how do we do robotic surgery? The most important thing for robotic surgery is the day before. The patient has a CAT scan, 1 millimeter slices. It gets imported into the Excelsius robot, and you can plan for the screws based on the patient's CT scan. We're able to adjust the screws, place them exactly where you want them, and it's gotten to a point now, before I walk in, the CT scan is uploaded, and the rep is placing the screws where it needs to be, and then we're going in and checking and just changing a few angles. So how do we set this up? I always like to go for the scope on the side of the patient's symptoms. Put the patient in a sling, especially at L5-S1. This tends to save a lot of time in doing a facetectomy, and also tends to give better alignment. And the robot and the fluoroscopy should be on the opposite side. And then at the foot of the bed should be the robot registration and wire place. And so then throughout the procedure, the first step for robotic surgery is once you have all the information, you made your plan, the next step would be the reference frame. You want to make a small 1 millimeter incision on top of the PSIS. You put the reference frame, and you're able to register the reference frame to the previous CAT scan. And one of the advantages of the Excelsius GPS is that it gives you a score based on how well it incorporated the CT images and the patient's x-rays. And once you have the reference frame, the robot, based on the instrumentation, it's able to go without any manipulation. Here, I have a time lapse of me doing an SI joint fusion. I used to hate doing SI joint fusion, so I'm always down here banging on your back. And now I'm using my foot pedal. It's a time lapse, but SI joint fusion, once we register the patient, it tends to be an under 20-minute procedure now because it will, once I press S1, it tends to move the target, and now the only factor that you're really controlling is the depth. Everything else, the robot is fixed to the floor. It drops about 1,000 pounds to the floor so that you cannot manipulate the arm. So how do we do the workflow? So screws first. In cases where there's instability or a slip, I would typically like to put the screws first, put the rod in, fix the distal end, leave the top end loose, and typically place wires before the cage insertion, and then move on to the scope part. You can angle the screws so that you can use the same incision. I prefer one small incision rather than stab incisions. Stab incisions look great for the patient in x-rays, but I feel like for pain control, a small incision where there's no fascia in between tends to get much better pain relief than 2 stab incisions where sometimes the fascia is stuck between the rod, and that tends to be a generator of pain and discomfort. And then you can always plan for rod placement. You can make sure the screws are lined up so that the rod can go in much easily. And this is a big believer in this, is avoid proximal facet joint, especially the cephalad screw. I tend to place the tulip head a little bit more laterally and a little bit inferior so that my screw is not touching the superior facet joint, and also taking into consideration that the tulip head is wider, and sometimes that tends to impinge on the facet joint, and if you just keep it far enough away. And it tends to, this is a time lapse. We were doing L45 and L5S1 bilateral screws for a T-lift, and it's about 9 minutes. The original long video is about 9 minutes, and all I'm doing is I'm standing on the same side because really I'm not. And as soon as we need it for the other screw, I'm putting a foot pedal, and it moves to the next screw. The steps are a knife, a burr, and then go in with the screw. And I'm just watching the monitor in the back for the CT scan. So the key points are needle placement is a key to cage placement. It all starts with the original needle placement. If you want the cage to be in line, properly aligned, not digging into the end plates, the needle has to come in line with the disc. It needs to start at the inferior point of the disc. If the needle is coming from cephalad to caudal, that's the way the cage is going to go, and that's going to cause a lot of end plate digging. So you just have to realize that you're committed to the angle of the cage when you put your needle in for the scope. And must visualize and retract the exiting nerve root before insertion of the dilator. Discectomy and disc prep are similar to the MIS T-lift. End plate prep can be visualized, or it could be done through the 8mm retractor. And I think you should attempt at least 10 to 15 transforaminal endoscopic discectomies and mostly endoscopic foraminotomies before considering the intralift. And it's very much ideal for high BMI patients. So it's a little promotional video. I won't, I'll play it, why not? Yeah, it's called, one of the things that we trademark, it's called a relief surgery. It's called robotic, is there a volume? Yeah. Huh? Yeah. Or feel free to use this for any of your patients so that you can explain endoscopic T-lift. So this way you could save at least another 10-15 minutes on consults.
Precision and is carried out using the latest robotic navigation platform with manipulator arm. Before surgery, the CT images of lumbar spine are loaded to the robotic system. The system will calculate the size of screws and
Sorry. I don't know. It's not going.
rods needed for spinal fusion. During the surgery, the robot arm moves to the calculated position and, with the help of the guide tube, provides accurate guidance to the target. Screw are inserted through the small stab skin incision exactly to the spine targets. At the direction of the surgeon, the robot aims at the next point. Typically, 4 screws by a surgeon takes up to 1 hour. With our robotic system, it takes 10 minutes, and is more precise than the surgeon, with less X-ray use. The connecting rods are delivered to the screws and secured with locking nuts. The pedicle screw system stabilizes the vertebrae, and the implant maintains the spacing of the vertebrae while the fusion takes place. After the fusion is completed, a solid bone mass forms and 2 vertebrae are joined together. Compared to traditional spinal fusion procedures, the relief is a less invasive surgical approach. Patients are treated more effectively without long recovery times. Atlantic Spine Center, less invasive, better results. Atlantic.
So post-op, I mentioned about the discharge. This is, I think it's very minimal disruption to the patient's muscle, and they can be going home the same day. Another part of, I think, endoscopic fusions is the post-operative care. On top of the anesthetics that you use is we do a block right after the surgery. We do an ultrasound-guided erector spinae block. And it's been shown to lower opioid consumption 6 hours throughout the entire postoperative course. There's a higher satisfaction rate, and these blocks tend to stay for 48 hours, and sometimes patients want to come back and they want another refill and then go back, so they're not on any. I've had patients, we do 1-2 level T-lift, they have the block in place, and they're not getting their narcotics for at least 10 days after surgery, 12 days after surgery, and at that point it's minimal use. This has really cut down on the amount of prescriptions that we're giving for pain, so for pain medications and also for spasms. And this is a typical patient. This is a patient, I'll show you guys the x-rays later. Patient comes 4 hours late, 4 hours later, he's in the PACU. This patient's able to walk around, and they get discharged the same day. And this patient just had a single block. He's not going home with the catheter. Some patients don't want the catheter, and then in that case, we'll just do a long-acting block that tends to last for about 48 hours. It's another option for patients who are uncomfortable with having wires. Typical cases that we do this on is a 28-year-old female, left side microdiscectomy, had a fall with new onset right leg pain, bigger patient, had previous abdominal surgery, so an ALIF would be contraindicated. She's unable to tolerate PT, failed epidural injections, and she had right side radiculopathy, L5S1, with foot 4 out of 5. We're able to do this robotically. In this case, we put the screws in first. As you can see, then we're putting in the wire, coming in with our dilators and docking the cannula. We're able to do our entire discectomy, put the cage, and this is done as an outpatient. Patient's able to go home the same day. One other thing that you'll note is we do get excellent distraction across the disc space. Another case, 59-year-old male with right leg pain and weakness. MRI shows L2-3 and 3-4 disc space narrowing. Of note, he's had a previous laminectomy at L2-3 and 3-4, and now is coming in here with the radiculopathy on the right side. He's had nerve root blocks at L2-3 and 3-4 to confirm that he's had it. This is a case that you could choose an X-lift or an O-lift or just a typical posterior. But given the fact that he just needs disc space height and back pain relief, endoscopic fusion was an option for him. So typical, as I showed you guys before, the inner and outer opening, try to make both inside the disc space. We're able to prep the disc space with curettes, shavers, insert the cage. Something we can do 2-level, and we're able to do that as an outpatient. And this is the patient that we just saw walking 4 hours after. He's had a 2-level surgery, T-lift. He's going to be going home the same exact day. Hold it, yeah. This is early on. where I want to, sometimes you want things to look nice and do stab incisions, but, as I do more and more, I just think people do a lot better with the connected incision, take down the fascia, and just, I don't over suture the fascia, 2 or 3 stitches. There's no reason for it to be waterproof. And patients get much better pain relief with that. All right, thank you guys.
Or
no, I've been able to do transforaminal. I try to find the path between the, just like for a transforaminal approach, and it just requires a little bit more facetectomy. That a more SAP needs to be removed.
Okay, so you just dock on the facet.
Yeah, I just work more on the facet. Yeah.
Thank you, Praveen. Now we'll break for lunch. The plan after is we have 3 talks quickly, and then Dr. Mahesha sir demonstrate entire case, including interlaminar fusion from skin to skin, including the cage insertion and screw insertion percutaneous. So we all will be back in the hall in half an hour, because most of them have finished lunch. Thank you.
Yeah. Okay. Okay. Yeah.
So 2 cases have been done now. The next case, the L5S1 degenerative disc disease, the predominant pain. So plan is to do a fusion. Mahesha will demonstrate the usage of non-cannulated simple reduction screws. How to place with a single incision, he places 2 screws. So he will just demonstrate the technique. If time permits, he has to leave to airport. So case insertion, maybe I will do it.
Okay.
So if
I think because we don't have so much time now, so maybe I can fix the screws and you can put the cage.
You can start, I think.
Yeah.
Yeah. Can start.
Good afternoon. This is a small talk on what all we have done in the process and in the journey of our endoscopic surgery in the last 10 years. Of course, this talk is very brief and will not cover many things. Just like the curate, we saw how SUKUMAR has used it. A master can use such a simple instrument in such a nice way to do almost the entire bone removal was done with that one instrument. Of course, there is no mention of that instrument in this talk. So it covers a few items, few instruments which we have developed. So I started as a very aggressive open surgeon. There is no other word, it is a barbaric surgery. I used to do anterior approaches for the spine, thoracotomies, anterior retroperitoneal approaches. Of course, cervical, it is still used. Because I am trained by neurosurgeon, I have experience in doing craniotomies, transnasal pituitaries, tumors in the brain, tumors in the spine. So I have a lot of experience in neurosurgery also. Of course, I would have forgotten unwanted things. But then I moved to the art of spine endoscopy because the patients are not happy. If you carefully follow your patients and listen to them, you know that your patients are not happy. I am a very good open surgeon. I can do open discectomy, micro discectomy in 10-15 minutes. But I shifted to spine endoscopy because you get much better results with the endoscopic procedure. And we faced a lot of problems while doing endoscopy, so that's why we need to innovate. And necessity is the mother of innovation. And either I had to stop doing spine endoscopy or I had to do something to continue my love and passion for spine endoscopy. That's why we innovated so many things. And my goal is to make spine endoscopy affordable for everyone, including the patient and the surgeon. And I am a very strong nationalist, and I don't want any of our country's foreign exchange going outside. So only the endoscope is not manufactured here. Rest everything is available in our country. So we started Make in India since 2012, much before our present Prime Minister came to power. So he is Dr. Srinivasan, my teacher. He is a gentleman, he is a neurosurgeon who is working currently in Chennai, who taught me so many good things in spine surgery as well as in life. And the other person is Dr. Satish Chandra Gore, who is our mentor, who inspired us to take this path of spine endoscopy. Of course, I have not gone for any training in endoscopic surgery, but this is not possible for everyone. So I am, I was overconfident, and I had that guts to do it without doing any formal training. But I don't advise you to follow it. Parviz Camin, who started all this, and Anthony Young is the pioneer who invented the first generation endoscope, and Dr. Syed Usman, we saw his talk in the morning, and we learned the art of spine fusion from him. Myself and SUKUMAR were fortunate to visit him and learn this technique. This is where it all started in 2011 for me, and Karthik sir is, you can see here, there are many people you can see in this photo, Dr. Sunil Nadkarni, Dr. Gore, Dr. Datar, Shiva Sabhapati, Nambudri. So many people are here. If I miss out, you can point out. So we started, once I attended this meeting in Pune, that is in 2011, I bought this book and this set from stores. And I studied the book and started my endoscopic journey. And this was my first patient, which I did in May 2012. And this was alpha S1 disc. And I did this surgery. Of course, initially you don't know what you're doing, but still patient got good result because the fragment came out, and till date he is fine. So, but we had a lot of issues with the instruments, partly because initially we did not know how to take care of them, because this is a completely different set of instruments. It's not like open surgery where you operate and leave the instruments and go and come back next day or some other day for next surgery. If you do like that, you will not have any instruments left behind, because these are all cannulated instruments. These are gentle instruments, delicate instruments. You cannot treat them like you treat with your open surgery instrument. They require special care, special attention, special handling, because they are different. So endoscopy itself is completely different from open surgery. So that you have to keep in mind. And we had issues with the scopes, but currently we have very good scopes, much better scopes. A lot of our patients had pain during procedure because we are doing local anesthesia. Now we have moved away from local anesthesia, but beginners should continue and start with local anesthesia, especially for transforaminal surgery. Whereas intraluminal surgery, it's a different ball game. And initially we had a problem in getting the fragment out. That's why all our patients, we used to do post-op MRI. Even my first patient itself, I did post-op MRI. So that helped us a lot. So it is all self-learning. So you identify your mistake and treat it. Today, if I do a surgery, I can predict how exactly the post-op MRI will look like. You saw yesterday's case, you saw the post-op MRI. This I can predict before surgery, that I will do this and my MRI will be like this. So we had a lot of breakages of these instruments. So I looked for local manufacturing, because if you buy instruments from a foreign company, it takes time, because they have to send it they have to get it repaired and then get it back. There is issue of customs. There is a lot of cost involved. So we don't blame any of the multinationals, but there are limitations because they don't do any manufacturing here. So the only way to treat or tackle this problem is to have local manufacturing here. And then I looked for my open surgery manufacturer, that is Hepson's. Of course, I don't take any royalty, commission, money from any of my companies. It is all the benefit is transmitted to the customers. For me, there is nothing. I don't even expect my name to be there. So initially we developed these graspers, 2.5 mm instruments, which were welded in a traditional way. But today we have all this laser welding, which is much better and much stronger and much better instruments. We developed some hooks, dilators, cannula. So these instruments also used to break. Every 4th, 5th case it used to break, but I can get it repaired. So I can continue my journey. And just to show how innovation can benefit, so this is a hook or grasper, whatever you see the one extra piece of metal here. So all our hooks and curettes used to break. Just change the tip design like this. And none of our hooks or curettes break nowadays. Otherwise, earlier what used to happen was, once you rotate the hook to manipulate something, the tip used to open up and you cannot use the hook. This is just very small innovation which helps to save your instrument. We also, initially there was no instrument available for bone work. So we developed these long burrs, gouges and osteotomes, which helped in our transfemoral surgery. You saw the yesterday's transfemoral surgery. It required a lot of bone work to get good decompression. So we developed this. So initially we developed this 3.5 mm long burr, which we connect with any orthopedic drill, and we did many surgeries, decompressions with good results. And initially the laser welding itself costed us $100 US just for laser welding. Today we have a very good laser welding facility in India, so it is much cheaper. And in 2018, from 2012 to 2018, we did exclusive transfemoral work, which made us masters of transfemoral surgery. I can do almost anything with transfemoral surgery, except maybe stenosis. And any kind of disc herniation can be tackled with transfemoral surgery. So, but because interlaminar approach offers much more wider scope, and it gives tremendous expansion of application of endoscopy, we shifted more to interlaminar endoscopy in 2018. We had a meeting in Hyderabad with SUKUMAR, where Lokande sir and other faculty showed us how to do interlaminar procedure. And again I started interlaminar endoscopy on my own. Initial 3-4 cases I failed, and I converted to open, and I learned from my mistakes. And today I can do any interlaminar procedure, including cervical, thoracic, lumbar, decompressions, fusions, you name it, we can do it. And it required a special burrs, because you cannot use any orthopedic drills for interlaminar work, because your shoulder will get affected. So that's why you need to have a dedicated burr system. And when we looked at a striker system, which is basically the arthroscopic shaver, which requires a modification of the burr. So we did this striker attachment burrs. These attachments are lifelong because they are metal. Only if the tip breaks, you can just change it. That is the advantage of this burr. And striker burrs are very durable, easily available. It is the only burr system which is used for underwater usage. Even if water goes in anywhere, nothing happens. And it gives good torque and RPM. And the one beauty is it has a hand control. Whereas most of the systems currently available, you have to search for the foot switch. Sometimes you press the wrong switch and your RF will burn. Whereas this, it is very beautiful. You can control with the hand, and it is cost effective. Other thing, when we are doing interlaminar work, you will spend lot of time in preparing the initial soft tissue work. You need to clean the soft tissue area to define the anatomy, which takes more time when you are doing RF, using RF. So I use a simple monopolar probe. This is from laparoscopy. So this is a 3.5 mm pediatric laparoscopy L hook, which works with normal monopolar cautery, except maybe some top end monopolar cautery it may not work, but normal cauteries it works very well. I do most of my initial preparation with this. With this you can control bone bleeding also, except once the canal is opened, we don't use it. So you should not use it over the dural sac. It is only for the superficial work, not for the deeper work, and it saves a lot of money. This probe will come to 100-200 cases, and it costs less than 6,000 to 7,000 rupees. So my philosophy is be simple. Don't take your procedure should not take too much cost. Today we have developed alternative birth system where we have made attachment to any of these micromotors, whether it is NSK, Marathon, Worlded. We have made attachment like this. So the one end it is fixing the micromotor, and other end I can fix the striker burr. So this is a very good alternative which we will come out very shortly. So if somebody cannot afford a costly burr system, this can be done. Same year we had been to Dr. Syed Usman in US, that is Sky Spine Center, where we learnt art of spine fusion. This is Professor Magdi Gamal, where he's from Cairo, Egypt, and I visit him once in few months. He's a very good friend of us, and he would have been here if he had time. And he keeps me feeding all very difficult cases. And once you do difficult cases, you will reach the next level. You can tackle any pathology with endoscope, because if you give me any case, I can tackle with endoscopy, because I have so much skill level improves so much, and the confidence also improves. So this is what we use for endofusion with reduction screws. Of course, percutaneous system is a very good system, but it costs more. So what we do is we use normal reduction screws, which comes with normal any set, and we operate with regular instrument, nothing special. This is a standard owl, and only this pedicle probe we have put a ring at 40 or 45 just to get the length of the screw, that's all. And this is a rod holder, and this is the expandable reamer which you have seen today for preparing the disc, and it opens up to 15 mm. From 5 mm it is opening up to 15 mm. Currently we are yet to finalize this design and get patent, that's why it is not out. And this is the root retractor. When you are doing interlaminar fusion, I use this semicircle cannula to retract the root and put the cage, because we are truly uniportal. What SUKUMAR did today was biportal, but I am a true uniportal man, so that's why we put even whatever I do, it is uniportal. And these are the cages which we developed. Initial cage was not like this, then SUKUMAR and myself changed the design. This is a very good cage. It has stood the test of time. We have been doing it for the last 5 years. I think we would have done more than 200 cases with excellent results. This is a cage. You see the design, the tip is smooth so that the root is not stretched, and only the backside 50% has serrations, and it comes in 35, 30 and 25 mm, and diameter from 8 to 12 mm. Today's case you saw, it was a difficult case because the disc height was well maintained. It was a 14 mm cage, and we have not designed these bigger cages because we don't want someone to put a bigger cage and injure the nerve. So that's why we have not designed more than 12 mm. 12 mm is maybe the maximum size you can put by transforaminal approach. So if the size is more, you have to use either expandable cage or go interlaminar and put a traditional PLIF cage. And this is the expandable cage we developed with Jayon. In 2018 itself we have developed this, not now. But we are not using it because of a couple of reasons. One is it is costly, very costly. And second thing is there is no long-term data. I mean, I am talking about 10 years, not 5 years. So there is not long-term data on the safety of this device. And the third thing is, if the patient requires a bigger cage, we can anyway go interlaminar and put a bigger cage. So that's why we are not doing much of these expandable cages. But today we wanted to show you how an expandable cage is put. So we wanted to demonstrate, and that's why we did that case. And this is my technique. I can put 2 screws with 1 incision. The normal percutaneous screw will take 4 incisions, whereas I can put with 2 incisions. And this is the standard transforaminal technique of endofusion. And this is the best cosmetic result you can get out of endofusion. This is one of the last, this spine biopsy set, or you can do vertebroplasty as well as stick biopsy. Especially if you have a soft tissue component, you cannot get it through a normal biopsy needle. So here we have this small forceps, 18 centimeter long, which will go through your gemshidi, and you can catch soft tissue, and you will get 100% biopsy result. There will not be failures of biopsy. And if you want to inject cement, you can inject cement through this attachment. Of course, this is not everything what I have done, but if I helped some of the surgeons in some way, it is good enough for me. I don't expect anything. Thank you.
Thank you, Mahisha. It is well summarized, your journey. So yesterday I was telling in the evening, so the affordability of endoscopy in India is the only one reason why endoscopy couldn't progress as the way it progressed in Korea and Germany, because everything here, the cost is the main factor. We have the human power, human resources, can spend time learning, but the cost is the one which is more important factor in our setup. One punch breaks. The stores system was the one which was first introduced in India by Dr. Gore, sir. So when you want to, one punch, for example, at that time in 2011-12, the black punch and the cutter, they were 80,000 that time, 60 to 80,000. One punch breaks, no hospital buys it again. You cannot buy it in yourself. So you tell your hospital, then it takes 6 months to 1 year to buy a new punch. You give it for repair, it will come only after 2 years. Such was the time that time. So the one set is bought and you start a case, after 3 months it breaks and you stop, because you don't have tools to operate. So only then Mahesha started designing and creating the Hepson contributed a lot. Then multiple companies came, and now things are better. And now as we grow, do more cases, we learn how not to break our instruments. The local one or any good instrument that doesn't break in your hands after say 50 cases. So you also learn how to not to break it. So these are the few things, and adding These tools, Mahesh has contributed a lot, immensely. Thank you, Mahesha, for all the contribution. Thank you.
Thank you.
Laptop is here? USB Hello. Next we'll have Dr. Karthik Kaila sir. Because the next case Dr. Mahesha sir will do on the percutaneous screw. So Karthik Kaila sir and Abhinandan will talk about the screw concepts and techniques and reduction techniques. So these two talks, then we'll be ready for your. No, you'll talk. Both complications are there, like stenosis and fusion. Dr. Zakri will be there. Praveen.
MIS, what is that? MIS medical suit technique. That's the one. Yeah. Good afternoon, everybody, and I think this is going to be a run through from all of us here, because we have seen all this again and again over the last 2 days. So essentially, for the younger crowd here, it's basically we have to treat the spine as a flexible beam. It's the most important thing, and understanding of the beam mechanics is important. When loading happens, stresses go across, and then a combination of compressive and tensile stresses work on this to producing additive loads. So in the normal biomechanics, you find the anterior spine is subject to greater stress and a normal everyday loads, and this is an important thing for us with our instrumentation. So going on to what is MIS, basically it's just a correct terminology, is minimal access spine surgery and nothing special. Surgical technique is very similar, only the surgical approach of the working channel, what they've differed, and it's been heavily instrument dependent so far, but it's all changing with different people like Mahesha and all of us who are doing modified approaches. Trauma was the biggest indicator for us. Now I think anything and everything in spine can be done by MIS. So I'm just going to briefly give you a run through a technique with the video played if there's any time. Positioning of the patient is like everything else, on a McKay frame, or you could put on a Wilson's frame, it's not padding, adequate padding to protect these things. The most important thing is use of SIAM. For people who don't have navigation, I think SIAM is the workhorse for us, and it's important to identify the disease level accurately. The spatial relationship should be understood, and this is very important for us to minimize errors in instrumentation. So the first thing to do is have an AP image. So make sure that you want to see the appropriate level. If your L2 is fractured and you want your screw at L1, align yourself to L1, identify, make sure the parallel end plates are parallel and very clearly seen as thin lines. Make sure the pedicles are in the upper half and orient the spinous process to be equidistant between the vertebral body and the pedicles. That's a key thing. So here you see across the end plates a single line, and you find the pedicles in the upper half, as compared to this picture where you see the end plates are seen as biconvex pictures, as well as you find that the pedicle is pushed lower down. So imaging becomes a very important point, especially if for all of us who are starting our journey into percutaneous pedicle screws. So it's again very important here to avoid rotational errors. Rotational errors can be catastrophic if you do not understand them, and therefore make sure the pedicle and the spinous process are equidistant and in the middle. The other thing which is also important here in this is, should you rotate the table or should you rotate the C-arm? Oftentimes I find that it's better to rotate the patient rather than the C-arm, and it gives better results as compared to rotating the C-arm all the time. So going on to lateral image, the bulk of the procedure is done on the AP view, and then you go on to the lateral image. What do you see here? Again, the same principle holds good. You have to identify single level, make sure the end plates are seen as one, orient the C-arm to, most importantly, superimpose both pedicles. So here you can see a correct picture where you see the end plate as a single line, as opposed to the picture down below where you can see a biconvex picture. The oval appearance indicates that the image is not a true lateral, and therefore keep working to get the true lateral. Other positioning is what's called as an end phase image or the coaxial oblique view. The coaxial oblique view is a 20-degree oblique view where you align the C-arm towards 20 degrees of the patient to get directly in line with the pedicle. This is a very important view because it shows you a right downline view into the pedicle itself and gives you a direct view into the canal to the pedicle. So next step, what we do is once you have done that, you identify a pedicle localization with your skin incision. So you can either mark with the Jamshedi needle or with the scalpel or with the artery forceps. Usually it's marked about 1.5 centimeters lateral to the lateral margin of the pedicle. And using a Jamshedi needle, you go ahead and engage into the pedicle. For starters, we always look at going at either 10 o'clock or 2 o'clock position, depending on which side of the patient are you going to be in. And once you're in, you verify the trajectory to ensure proper positioning. Be aware of the superior and inferior end plates and the pedicle margins so that you don't violate any of them. When the needle is a posterior vertebral body margin, on the lateral view, make sure that you're going to see the needle is not past the medial wall of the pedicle, and on the lateral view, it should not be past the posterior vertebral body line. That's very important. Now understand the three-dimensional correlation like you see in an axial view on an MRI, and you make sure that the pedicle contents the needle is well within the pedicle canal and into the content. So just brief, quick video, I'll run through it. I think we've all seen enough of the instrumentation technique, so I'm just going to briefly run through it to show what's the So you mark your point 1.5 centimeters, and then once it's done, you can drive the Jamshedi needle in, and make sure, as I said, don't go past the medial wall of the pedicle. So once it's done, pass the guide wire in. There are now newer instruments available where you don't need to use a guide wire. You can use it directly, or you could modify the technique as what Mahesh has done, as we also do the same in terms of not using guide wires. But for a start, I think this is the most recommended one. So once the sheath is removed, you begin sequential dilation with your dilators to avoid muscle being caught in. And once that is done, you then go ahead, tap the pedicle, and then go in with your screw, depending with the extenders in. In this case, I'm using a longitude set. One of the things in this is make sure the guide wire doesn't back out by using an artery forceps or holding it across. Like in orthopedics, we don't want the IM nail, when doing the IM nailing, the guide wire to back out. The same philosophy holds here. One of the problems with the guide wire migrations are known to be problematic and leading to complications. I'm sure Dr. Bhupesh will talk about that at a later point of time. So once your screws are in, with the extenders, most of these sets have got now the persuaders or the reduction devices available, so a lot of modifications are there. So it's important to look at whatever set is comfortable to you in terms of it. Sets like some of the other sets do also have extended tabs, so you don't need reduction devices much on them. Now lastly, we go on to rod reduction here. Again, some of the open-ended systems have got the ability to put the rods in through the same incision. Sometimes, like in the Medtronic kit, you do have to use alternative stab incisions for you to get your rod in. So compression and distraction can be adequately done with this following the reduction. So what are the advantages? You have, as everybody mentioned before, soft tissue disruption is less, blood loss is less, infection supposedly less, and reduced operating time. It took a lot in the initial, but nowadays it's very, very quick. To put 4 screws, it takes about 20 minutes. Advantages in polytrauma. Of course, you also have complications like screw backouts as well as pullouts if things are not right. High exposure to radiation, implant and instrument related problems are known. Now, some of the things for the juniors, when you do it, reduce radiation. You work as a team. We work bilaterally so that you reduce the radiation load for everybody and you reduce the working time. So one of the tips is land on the transverse process, the first thing. Feel it, use your tactile sense rather than imaging it all the time. So once you land there, feel for the mount, just as you see a finger there. You land on the TP and then go on onto the facet, hit the facet and you feel it. And once you hit the facet, then you enter and then you shoot, so that you reduce the number of images you do it. Keep a marker at a 20 millimeter mark on the instrument so that you know that's the pedicular body junction, and that helps you. I avoid tapping now because most of the screws are self-tapping screws, and always pre-measure the screw lengths so that you don't have to keep reshooting again. Take home, MIS pedicle screws, the instrumentation is there to stay, it's doable. And with Indian implants, it's definitely affordable now. Of course, if you can afford navigation, please go ahead and get it because it makes life easier and you don't suffer. And keep innovating and think out of the box for us to proceed to the next stage. Thank you and hope to see all of you in Bangalore for the MISAPCon.
Hello. Thank you, Dr. Karthikelas, for your wonderful presentation on MIS screw. So now, any question? Anyone have a question for MIS percutaneous screw?
They can't have any questions after watching Abhinandan.
Yeah. So now moving on to the next lecture on Master Surgeon video case, Endofusion, My Journey by Dr. Suresh Ramaswamy. Is there?
Good afternoon. There's a slight change in my presentation. I'm supposed to talk on my journey from open spine surgeon to basics to advanced level endoscopy. This one here. How do I make it full screen? Make full screen.
Hello. Sorry, I was out. I want to tell you one thing about Dr. Suresh. Actually, we met him in 2019 in World Congress. He just attended 3 days conference in Hyderabad. And then now in 4 years became an advanced endoscopic spine surgery. So I think that's an inspiration that the young surgeons can carry. And of course, he's an experienced spine surgeon, and recently his center got recognized as a center of excellence for full endoscopic spine surgery from Eloquence USA, and the first center in Southeast Asia. And we're very proud and been very supportive to Asian Spine Hospital also. Dr. SUKUMAR, and is a big brother for us. Over to you. Thank you.
Thank you, Naresh, and thank you, Dr. SUKUMAR, and the organizing committee for having me on this platform to share my experience, how I started my endoscopic journey. So, I'm Dr. Suresh Ramasamy. I come from Malaysia, and as I said, this is my journey. So I come from a town in Malaysia called Alustar, up north of Malaysia. I work in a 120-bedded multidisciplinary hospital. So initially my thoughts and belief, I've been an open spine surgeon for the last 20 years. So I've never done any MIS spine surgeries before. So I used to do instrumentation, scoliosis and all that. So I was very happy with my work and I didn't want to change until in 2019, that was the first time I attended the endoscopic conference in Hyderabad here. So what made me to change was, as that time I was a very junior surgeon, so I was same like you all sitting here, and I was watching the surgeries by the masters. So I was doing all these surgeries with a big incision, and when I saw these guys were doing with a small incision such a big operation, so that changed my mind. So I returned to Malaysia. So this was when I was in first time with the Malaysian group. With that was Syed Osman sir, with SUKUMAR sir. And the first hands-on experience I had was in 2019, where I invited Dr. SUKUMAR, came over to my place, and I did about 5 cases in 2 days, all transforaminal. So I learned some tips and tricks from him. And following that, I started my first case of transforaminal procedure. So I was not good, still was not good at the procedure, and and at the time I don't know what to do. Then discussing with Dr. SUKUMAR, he asked me to attend more courses and workshops and cadaveric workshops and all that. But unfortunately, the pandemic came in, and I did not pursue with whatever the suggestion was given. So the only choice I had was to upgrade myself with self-learning. So what I did was, I sat down and watched a lot of surgical videos in YouTube and other social medias by all the masters. And we had a WhatsApp chat group where I used to share cases with Dr. SUKUMAR, and had been very helpful in bringing me up to the level I am today. And also, so I started off with transforaminal cases. I didn't want to confuse myself, doing everything at one go. So I did about 50 cases transforaminal. I got mastered in the technique. Then I went on to do interlaminar, simple disectomies. Following that, to stenosis decompression, to thoracic, to endofusion, and to cervical now. And in the beginning of my journey, the only learning tool was I always made a point to do a post-op MRI. So for the first 100 cases, for every case I did post-op MRI. From there I learned where I did less or I did more. And after looking at the post-op MRI, I went back, looked at all my surgical videos. And I learned from that and I improvised myself. Okay, where am I today? So I've done almost about 200 cases of transforaminal, stenosis about 100, interlaminar about 250, thoracic about 15, cervical about 30, endofusion about 30 cases. And in 2022 June, I came here and got my fellowship from Asian Spine Hospital. And this was, now I share with you all my cases that started from beginning until today. So this was my first transforaminal case. It was a 26-year-old male, presented with right leg radicular pain. So it's L5 S1 disc. So I did transforaminal procedure. And he was only pain-free for about 3 months, and he returned again with radicular pain. So I gave him a transforaminal injection. Then after that, he was better. And so these are my transforaminal cases in the initial stages. This is a 29-year-old male under 20 kilos. So did transforaminal, this pre and post-op MRIs. This is a short video on the procedure. And this is the other case, pre and post-op MRI. Another case, also this one I did under local anesthesia. Another case of recurrence. This patient is a 34-year-old male, L4-5 disectomy done twice in 2009 and 2017. Then he had a third recurrence and presented with left lower limb radicular pain. Failed conservative treatment, then went in and did a transforaminal decompression. But unfortunately, he came back again and with a fourth recurrence after about 2 weeks after he lifting something heavy. And this was the MRI. And I thought the third recurrence, I did a good decompression, but you see, even after the 3 times of procedure, he still had such a huge disc inside. So I went in again and did a transforaminal decompression. And recovered well. Then from then I proceeded with interlaminar. These are the first few cases of interlaminar procedures, pre and post-op. It's another case of L5 S1. This is a pre and post-op. It's a short video on that. And this another patient, 2 procedures. One is transforaminal, the other one interlaminar. He had 2-level problem. This is another pre and post-op, interlaminar as well. Okay, from then on, I moved on to doing more advanced endoscopy. So this is my stenosis cases I've done. This is a 53-year-old female, had a L2 S1 posterior decompression and fusion done about 10 years ago. presented with bilateral, done 10 years ago for bilateral leg pain. She was symptom-free for about 2 years, then presented again with bilateral lower limb claudication, which was worse for 1 year. So this is the pre-op MRI. And this patient, actually, this was done somewhere else, but she came in, consulted few surgeons and they advised for proximal extension of the fusion. Then somebody referred to me, then she didn't want any further instrumentation, so I advised her for just foraminal stenosis decompression. So this is the pre and post-op. So a short video after the stenosis decompression. This is another patient, 75-year-old male. Had a L3 to S1 bilateral laminectomy done in 2016. He was only better for 2 years. Then presented with bilateral lower limb claudication. So he had L2-3 and L3-4 spinal stenosis. These are pre and post-op MRIs. And this is a 63-year-old female, L3-4, L5, S1 fusion done 10 years ago, now presented with a bilateral lower limb claudication. So now the current problem is adjacent level, this L3-4 stenosis. So that's the post-op stenosis decompression, pre and post-op. It's a short video on that. And this is a 65-year-old male, bilateral lower limb claudication at a 2-level stenosis, L4, 5, L5, S1. So those are the pre and post-op. You can see the X-ray after the the decompression, the interlaminar space has widened up. And these are my endo T-leaf cases. So this is my first endo T-leaf that I did for L5 S1. So I did, this patient actually had a stenosis as well. So I did a stenosis decompression followed by transforaminal endofusion. This is another patient, 53-year-old male, predominantly lower back pain and also with right lower limb radicular pain. So she had L3-4 right transforaminal foraminoplasty and L4-5 did the endo T-leaf. This is another case, 53-year-old male, predominantly lower back pain and also radicular pain. So he had L4-5 endo T-leaf done. And this is a 2-level endo T-leaf that I did. It's a 70-year-old female, lower back pain with right leg pain. So this is a 2-level endo T-leaf. So for the transforaminal approach, the cage insertion is just one portal, but I managed to do 2-level cage insertion through the one portal, single portal. And this is the other patient, 54-year-old female, male, L5S1, grade 2 listhesis. So this I just recently did about 2 months ago. So did it transforaminally. This is the pre and post-op pictures. You can see the cage insert, well prepared end plate and cage insertion. And this is another patient, L4-5, grade 1 listhesis with spinal stenosis. So for this patient, I did interlaminar stenosis decompression followed by transforaminal fusion. Okay, then these are my thoracic cases. So this is a 51-year-old male, presented with bilateral lower limb claudication and numbness, left more than right. So problem was T10, T11, T11, T12, ossified yellow ligament with final stenosis. So I did 2-level stenosis decompression. So these are the pre and post-op pictures. This is another case, also a T11, T12 ossified yellow ligament. Pre and post-op and stenosis decompression. This is another case, also ossified yellow ligament at T9, T11, T10 level. Patient presented with bilateral lower limb weakness. So those are the pre and post-op and short video as well. And this is a PID at T9, T10 level. This patient presented with severe mid-thoracic pain radiating to the anterior chest wall. So done transforaminally. And these are my cervical cases. This is my first cervical posterior laminoforaminotomy and discectomy for 45-year-old female presented with right arm radicular pain. So problem C5, C6. This is another case, 58-year-old male, right arm pain, PID C3, C4, same, did posterior foraminolaminotomy and discectomy. There's another patient, 45-year-old female, left arm pain, PID C4, C5, same procedure.
Hello, Mahesha. Hello, Naresh. Naresh. Yeah, we are ready with the Naresh. We are ready with the theatre.
Yeah, yes, sir.
Mahesha has watched here for a case of L5S1 degenerative listhesis. So patient is prone. So Mahesha is ready. Over to Mahesha. Mahesha.
Sir, just Dr. Suresh conclusion slide.
Okay, no problem.
Just a second.
Okay.
Instrument ready.
Okay, this is another patient, 2-level PID. So I did 2-level laminoforaminotomy and also a fragmentectomy. So this is my last slide. And my achievement now. So in the last 4 years, this is why I've come to. So recently I've got a Center of Excellence from Eloquence USA. And also I'm one of the workshop trainer in for cadaver workshop in Bangkok. And now I offer, they have appointed me to offer a short-term fellowship 1 week to 2 weeks. And my first batch of 2 Australian surgeons will be here in end of this month to be with me for 1 week. That's my journey to where I am today. Thank you.
Thank you, Dr. Suresh. So, I mean, maybe his long open surgery experience has helped me to translate in 5 years, less than 5 years, brother. But thank you for sharing your journey and the process. So, Sukumar sir.
Yeah, you can
Mahesha
explain the
sir.
case. Yeah, we are here.
Hello.
Go ahead, start, sir.
Yeah.
Just before Mahesha starts, I just want to show the X-ray here. The patient has a severe low backache, not relieving with conservative measures. Multiple time pain management has been done. Patient has a collapsed disc and with a small disc prolapse. So here plan is to do a fusion. Mahesha is demonstrating his technique, how he does percutaneously placing the
Reduction screws.
Reduction screws
With,
open. Reduction screws open in open surgery. So over to Mahesha.
Yeah, so basically first we have to mark the lateral pedicle line in AP view, and in the lateral view we mark the inclination of the pedicle. So just focus the C-arm picture.
Can you show the C-arm image?
So
make C-arm image bigger.
see our pictures?
Yes, sir.
You see the lateral view. We can see the needles. So upper needle is for the L5 pedicle, the lower needle is for the S1 pedicle. Here it is just a, there is no listhesis as such, so there is no reduction involved. So we just fix the screws, fix with screws. So I take the incision between the two needles. Can you show here? I take a single incision between the two needles, so that upper part I will address the upper pedicle, lower part I will go for the lower pedicle. Is it clear?
Okay.
Can you see the mark, my incision?
Hello.
Hello? Hello?
Anybody there in the hall? Naresh?
Gilpy hai? Mujhe
Sir,
Abhinandan.
yeah, sir, there was a mic issue. Sorry.
Okay. Thought everyone is sleeping.
No, everybody is
Okay.
very active to
Okay.
see the magic of Mahesh, sir.
So just
Dr. Abhinandan and Dr. Hussain are moderating the surgery.
Yeah.
Okay.
Okay.
So all the aggressive surgeons are moderating,
yeah, actually,
aggressive
in fact,
surgeons are operating.
me and Praveen both are wearing the dress of Abhinandan, so that energy comes here.
Hello?
Yeah.
I mean, after this, that's why that energy will continue with Abhinandan's talk. How to reduce the listhesis. The techniques will be demonstrated by Abhinandan. But
So we make the incision just starting from the lateral pedicle line. So we make about 2.5 to 3 centimeter incision. Can you have any Gilpy? Gilpy hai? So I'm just waiting for some instruments to come. So you can either use cautery or the knife to cut the fascia. Because if you don't cut the fascia properly, then it becomes difficult. Okay, put, yeah. Okay, fine.
Suction?
Yeah, no, it's okay, no problem. The Gilpy has the advantage that it occupies very less space. So, because this will occupy some space. Okay, you have the owl? One. You have a owl? Okay. Any other thing? This may slip. They must be having a normal owl. Normal owl, triangular one. No, इसमें रहेगा. Reduction screws are there, no? Yeah. That must be the cage instruments. Below that. No. Take out reduction screws 40, 45. Okay. The instruments are ready?
They are getting in
okay.
2 minutes.
No problem.
So
we will start with some owl now. Okay. No, I need a little wider one so that, okay, I will try with this. So basically you have to feel the lateral edge, don't shoot, height up, lateral edge of the pedicle, lateral edge of the pedicle so that you can enter there. We need something sharp so that we don't take radiation on our hands. So Gilpy is much better. I need something sharp. नहीं आपके पास this is not sharp. Owl है आपके पास बड़ा वाला. एक owl था ना, long one. Long owl था. एक owl देखो.
महेश है सर.
Mahesh sir, are you able to
Yeah,
hear me?
yeah, I can hear you.
Sir, the skin markings and the incision go the same with the obese patient also?
No, can you speak louder? I can't hear you.
The skin markings and the incision size and everything goes the same with the obese patient?
Yeah, it doesn't change. It doesn't change.
Okay.
But recently I had a 140 kg patient, and I could not put reduction screws because from skin to the spine the distance was 14 centimeters. So the percutaneous screws acted like reduction screws for me. So we need some sharp instrument to enter the pedicle, otherwise we will miss it because we can't tap it later, because you are not using guide wire. एक आउल था ना इधर, आउल नहीं है. Nothing is sharp. You have some owl, bone owl. Some owl. कंपनी में क्या है? नीचे कुछ है. Just give us 2 minutes to get the instruments, because without a sharp owl I cannot start the procedure. Because if it slips then it becomes a problem. Huh. Instruments are ready. Just give us 1 minute to open and start this.
Maisha, can I ask a question? Do you plan before the surgery, do you measure anything, the size of the pedicles, or do you...
Okay, so the instruments have come, we are ready. Okay, it may be little hot. Okay, just keep it. और एक और owl है ना. So basically these are the two instruments. Can you see? Because we are not using guide wire, we need some sharp instrument to enter the pedicle. So we start now. This has a marker that is 40 mm. So without any measuring device I know the length depending on this. So I feel the lateral border and then go in. Show. So it's high. Can you tilt this way? Sure. Okay. Can you see the image, Hammer?
The CM image can be made bigger. Yes, we can see it now.
Sure. 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 So we have reached the medial pedicle line. Take a lateral. Tap 5.5 tap चाहिए. Okay, are you happy?
The CM image should be made larger. Yes.
Sure. Okay. AP. So the length of the screw is about 40 mm. Other thing I do is I check the length here. So even my instrument has markers. So don't shoot. So it is coming to 80 mm. So give me the tap.
Hand image in the central.
And give me a small sticker. Any questions?
Not as of yet. Probably
Okay.
once you are done with the screws, they might have many doubts.
Once screws are done, I am not here. SUKUMAR will take the questions. So, can you see my tap? So, I marked it 80. Okay? Can you increase the height? Yeah, this is 4.5 or 5.5?
5.5, sir.
Okay. See?
5.5 mm.
Okay. ठीक है. See, I have not used guide wire. I have not used anything. I have used navigation in my brain. Shoot. Can you see?
Yeah.
Okay. Sure. Sure. So if you want, take one lateral also. If you, of course, this case doesn't require too much of force on the screws, so you don't have to angulate it too much medially. So I am happy with this. If you want, you can still angulate with the tap itself. Okay, it is fine. So you just take it out. AP. Owl. Height ऊपर करो. Height बढ़ाओ. Height. So now we go for the S1 pedicle. Okay. Can you tilt a little more? Okay, should. Okay, I have to go down. So you stretch the incision, sure, to get proper entry. This is too down, so I'll just go a little more cranial, sure. Sure. To go a little more down and should be okay. Sure. 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 Huh? Sure, yeah. To go a little down. Sure. Because we are not having a true AP view, it may look a little superior, but I think in lateral view it should be okay. Sure. That is superior. Sure. That is too medial. Sure. Little more lateral. Sure. Okay, just take a lateral. Because we are not having a true AP, we will confirm in lateral whether it's okay. I am at the lateral border of the pedicle. If the lateral inclination is fine, I will go through this. Yeah, I think it is okay. Can you see?
Can you enlarge the CM image?
Sure. AP? Or just take lateral itself. Okay, shoot AP. No problem. AP, yeah. Height. Yeah, it's okay. Take lateral. So, can you see it is all right?
Yes.
So, sure. So, in this case, we don't have to do a bicortical purchase because there is no force of reduction required here. AP. So, unicortical purchase is good enough. AP and tap. Right. Height, increase the height. Okay. Give me the tap. So you need to remember where increase height, where you have entered. Okay. And if there is doubt, always confirm. Sure. Okay. Sure. So this way I don't feel the need for guide wire. Okay. So can you give the screw 6.540? So we will finish the screws here and then go to the other side. First I will put the L5 screw, upper screw, and then the lower screw. Can you give me that feeler, pedicle feeler? So this is a standard technique. You can feel the pedicle with the pedicle probe. You see, this is L5, sure. So all walls are intact, and this is S1. Okay. So this is L5. So you remember the track in your brain, increase the height, and there is a hole waiting for you. Sure. Okay. 40 hai na? Okay. Give one more screw. So what I do is I park the screw here and then go to the lower level. Sure. Take a lateral just to confirm. Lateral. So very easy, no? No hassle of guide wire.
Appears to be easy.
And it is with the same incision you will require 4 if you want to put a percutaneous screw. This I can manage with 2. Okay. So give one more screw, AP. So see that your screw head is oriented for rod. Okay. Sukumar is here. Outside.
Hello.
Sometimes.
Hello, Mahesha.
Hi, where are you?
I'm here.
Okay.
Appa.
Do you want me to fix the screws, or you want to do any maneuvers like distraction compression later? Shoot. Shoot.
No, you can put, I'll just go transformer.
Yes. He's going into laminar.
Let's see what is
Sure.
can go transforaminal and drill the facet, but put the cage. Could we move?
Sure.
Yeah. You have a set. No, not the your case or routine case. Yeah.
Sure. Give me a feeler once. My upper screw is coming in the way, so, but anyway, I can go. Sure. Okay. Sure. You have to tighten it fully. Sure. Can you tilt that? Sorry, one second. Sure. Sure. Okay. 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 I'll keep the tops for you if you. Yeah. Sure. Screw. Sure. Give me some instrument. The top screw is coming in my way, so I will just move it away and then go. Okay. Sometimes if you tighten the top screw too much, it will not move and it will obstruct you. So I just moved it away and I'm getting this next screw in. Okay. Sure. Fine. So it is gone in. Can you take a lateral? I'll just confirm with lateral and then fix the rods. Okay. Suction on, please. Okay. So, is it okay? Can you see?
Yes.
Okay. Can you give a AP? 5.5 50 mm rod? And with some lordosis. Okay, you are giving that? Chalega. Okay. This is 40. 50, give 50. Illa. 50 hakbadona. 50 hakbadona. Because so we can either put a normal rod. We have a rod holder for that. So this is a miss rod. So can you see? This is from Jayan Implants.
Can you enlarge the image on the patient?
Hello?
Yes.
So our screw heads are here. Can you give the nut?
So here we are using the normal MIS rod for the open reduction.
Yeah, but we can use a regular rod also.
Okay.
Here that luxury is there, so we can use. But I have a holder for this regular rod also, so I can use with that also. Not a problem. Final tightener. Take. Careful. give some.
Would you like to check the position of the rod as of now before removing the rod holder?
नहीं नहीं osteotome चाहिए just to slip it out.
Mahesha sir? Would you like to check the position of the rod as of now?
No.
Before removing?
Before?
Removing the rod holder?
Give me osteotome, I will slip it out. You can check, but it is. I can see it under vision.
Okay.
So that's why I am not checking. Okay.
Okay.
So I know where it is. Now give me the next rod, next nut, top nut. Shoot. It is bit. Rod appears to be bit long. You can check. We will change it to 40. No problem. Give me the nut. No. Just hold this. So we will put a 40 rod. Okay.
Are we going to distract the 5S1 space here?
Not much.
Not much.
No, even if you want to distract, there is enough space there.
Yes.
So give me a artery just to take out the rod. Give the 40 rod. So removing, putting, it's not very difficult. So 40 rod. So we will be putting 40 rod. Okay. So one Gelpi will do assistant's job. Nut. So back home when I operate, I don't have Abhinandan or somebody. Only my nurse will be there. So, but we have a many years of experience of working together. So show. Can you? Okay, 1 minute. It is coming in the way. So give me osteotome again. Osteotome. So sometimes these holders, once you tighten the nut, it won't come out. So what you have to do is you have to use some osteotome to just move it away. You see, you learn. So I will teach the company person. Shoot. No, AP only. Okay, this looks much better.
Yes.
So Praveen, you want some distraction or?
No, leave the top screw loose, that's it.
Okay, fine. Give me the final tightener.
Yeah, we have enough rod for the
And give me the other nut also. Move the CM out. Give me the next nut. And so you can, what we do is we work at one screw at a time with the same incision. So other screw is parked and we work like this. If you want to do this distraction, you can do a distraction here.
Okay.
Anyway, there is no need for any distraction as such. Give me the final tightener. Yeah. So what I will do is I will break off the lower one and I will keep the top one. Okay. Breaker. So give me the artery. Take.
If you do the distraction from
So I have broken the lower one. Now give me the detorque and tightener.
Hello,
Detorque.
can you hear me?
Okay, give me the. So everything goes through one incision.
Mahesha sir?
Yeah.
Dr. Hussain has a question for you.
Yeah. Yeah.
If you do the distraction from this side, how does it affect the contralateral side?
No, we are not going to distract, but if you want to distract, you can distract. It depends on the case. So we have finished with this side. We will go to the other side. Gelpi or artery? Artery. We have not used any cautery. Okay? No cautery was used. Knife. So we make one clean cut with the knife for 2 screws and easy rod insertion. Sharp point, yeah, probe. Can CM come? The steps remain the same, nothing changes. Okay, AP. Beda. Tilt a little bit. Tilt. No. Say true. What happened? Not 0. Should come inside a bit. Okay, fine. So it is fine. So I will go little cranial. Sure. Hammer. Height. Increase the height. And little more cranial I will go. Shoot. Yeah, that's better. Increase height. Can you increase height? Okay, fine, no problem. Shoot. Shoot. Okay, lateral. ಇಲ್ಲ ಬೆಂಡಾಗಿಲ್ಲ. Rod is 40, same screws. Okay, looks all right. Little oblique will help you only. Sure. It is not a true. No, you have to get a true AP. Okay. Okay, looks good. Yeah. Sure. Okay, so you get a parallel view. AP. Tap. Height बढ़ा दो. 5.5 tap. Sure. Sure. Tilt. Sure. Okay. So everything is clear? Feeler?
Yes, sir.
Feeler? Yeah. So you do the normal steps of pedicle screw fixation here. This is the only technique where you can actually feel the pedicle. No, बाद में. So main thing is we don't put the screws. Screws are put in the end. Okay. This S1 facet is so big, so you don't feel the edge. Sure. To go more cranial and sure. Yeah, I think it looks okay. Little more medial. So this instrument has to be really sharp. Otherwise we cannot do this. Sure. No, that is not all right. ಸ್ವಲ್ಪ ಕೆಳಗೆ. Yeah. Sure. Little more down. Sure. Yeah, I think that's okay. Sure. Yeah, can you get a lateral? So we are at the right point at the superolateral corner of S1 pedicle. Because you are not getting a true AP, this is quite acceptable. Okay? Sure. Can you tilt little that side? No, no, that side, that side, that side, that side. Okay, sure. Yeah, it's fine. Sure. Alpine inferior, L direct. Sure. 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 Okay, AP. Yeah, give the tap. Okay, sure. Huh? Yeah. Yes.
So can you show us a true AP for the sake of audience to
Can you take
understand?
the true AP? This is not the true AP. 1 second. It looks okay. Sure. Yeah, it's okay. Sure. Sure. So I am getting a good purchase there. Feeler. Sure. Okay. So give the 40 screw. So this is the L5 screw. Sure. Okay. Take. Height ऊपर होता है. Can you increase the height? Okay, sure. Okay. So give one more 40 screw.
In which patients do you prefer bicortical purchase for S1?
No, if I have to do a grade 2 listhesis, then definitely I will put a bicortical screw. But in this case, it is not required. Here no force is used on the screw, so we don't have to get a bicortical feeler. Give me one screw, one more. Only thing is, if you tighten the screw, it will come in the way of the next screw. Okay, give me the next screw. So I retract it and then put the next screw. Sure? Yes. Sure. Take a lateral. So yeah. Sure. Sure. Okay. The upper screws are fine. The lower one will get in. Sure. But these screws are almost bicortical. Sure. They have become almost bicortical. Okay. Rod 40? Yeah. Give me the nut. Siam निकाल दो एक बार. Siam out, please. Siam out. Siam out, please. Give me the final tightener. Okay. Okay, one AP please. Come. Tilt this way, height increase. Tilt this way. Come, one AP. So we have finished with the screws. We just have to break it and okay, sure. Come out, out.
So audience, anybody has any questions to Dr. Mahesha?
Okay. Out. Give me the osteotomy.
So Mahesha sir?
Yeah.
One of the audience has a question for you.
Yeah.
So the
Yeah, tell me.
The gel P, where you are keeping, sir? Under the skin or fascia you are retracting?
Huh?
With gel P,
Huh?
you are retracting the skin only or fascia also?
Only
sir?
the skin. Only the skin. Next nut. Give me. See I'm out, please.
So
See I'm out. 1 second.
incision in
I'll
the
just
fascia
get
is
this
vertical.
screw in and
Just splits and
give me the breaker. So take.
In high grade listhesis, do you prefer
Artery?
to go to sacrum or
Yeah.
S2
Now
or
take the
iliac
true AP.
screws or iliac screws?
Take the true AP. Yeah. So I'll take this out. I have to tighten the upper nut. No, I'm not done. You have to do it later.
So
Yeah,
Mahesha
sure.
sir?
No, it is not loose. If you want, you can just loosen it. So we are finished with the screws. Can you see the incision?
Yes.
Hello?
Yes, we can see
So
this
any
incision.
questions?
So Dr. Hussain has a question for you.
Yeah.
In high grade of listhesis, do you go to iliac or S2 or iliac screws for additional support from posterior?
No, I didn't get the question.
In high grade slips, do you go to S2?
No. I don't go to S2. I go a little more purchase from S1 itself, bicortical purchase. Couple of threads in front of S1 anterior cortex.
Okay.
So you start. Yeah.
Let me get the cap. Can you see the top?
See I'm out. I'll just loosen it. See I'm out, please. Yeah, 1 or 2 nuts. Out. So it is loose. It is loose anyway. Yeah. Okay. Yeah, thank you. So I will leave. We'll keep in touch. Thank you. Yeah,
Thank you, sir.
Yeah.
Mahesha sir, one question.
Yeah.
Thank you, sir. Sir, your system is available with Habar? This system?
Yeah, this system is available with Habar. This is implants are from Jayon. Instruments are from Habar.
Okay. Thank you, sir.
Yeah. So thank you all. We will meet some other time.
Thank you, sir. Thank you
Yeah.
for demonstrating
The
your
cage
technique.
insertion will be demonstrated by Dr. Praveen and Dr. Sukumar. Probably we will be doing a transforaminal discectomy and cage insertion. Okay.
Okay.
Thank you. See you all.
Sir, Sukumar sir. Dr. Abhinandan, maybe you can give your lecture in the meantime.
Super, sir.
Ma, Papa, Nako Gaunu, Sarko Gaunu. photo tiyali. Hello.
Sir.
Naresh.
Sir.
You do one thing, mute us.
Yes.
And let Abhinandan give the talk.
Perfect, sir. Okay.
Any important step, we'll just let you know.
అక్కడ చెప్పండి సార్ మ్యూట్ పెట్టమని వాళ్ళు చిన్న స్క్రీన్ ఇక్కడ ఉండాలి ఓటీది చిన్న స్క్రీన్ మిడిల్ స్క్రీన్ సార్ ప్రెజెంటేషన్
ఇక్కడ నుంచి మ్యూట్ పెట్టము
నెక్స్ట్ కేటీ చేయండి ఒక్క నిమిషం hello
so good evening everybody so now I'm going to present a small case in which we use our routine technique so this is not a generalized technique this is what we do it works well for us and we have been doing over a period of time now for all the minimal invasive spondylolisthesis techniques so we'll just show you a case how we do it regularly in our center hopefully it will be useful for you guys too so the same technique we use in open surgery the same principles we are using for the MIS surgery as Dr. Karthik Kaila sir has already presented his talk on how to put a pedicle screws so we will move on forward from that so this is a 54-year-old female as you can see there is a grade 2 to grade 3 kind of slip in L5S1 almost collapsed disc space so these are the dynamic x-rays so on extension there is some kind of movement but still it's not reduced and the disc space is totally collapsed the patient has got a severe back pain along with claudication pain as we generally expect with these kind of instabilities so on flexion there is also a kyphotic element at the L5S1 so these are the MRI pictures where you can see a collapsed disc space with the spondylolisthesis and a disc bulge causing nerve root indentation and patient having the claudication signs. So how do we do this? So this is the picture what we have when the patient is on the OT table. So as for the general endoscopic procedures where we break the table to have the interlaminar space open, so for Dr. Sukumar, I generally don't break the table here. I keep the patient hyperextended. So this helps me under general anesthesia probably all the muscles are relaxed. So a bit of extension at the hips probably helps at least 5 to 10% of reduction in the slip. So this is the picture we have on the OT table. So when compared to this, when patient is standing, this when patient is lying supine for the MRI, and this is the picture when the patient is slightly extended on the OT table under general anesthesia. So you can appreciate there is some amount of movement and already the patient is under the GA, under the position on the table, there is some amount of decrease in the slip. So now our aim is to completely reduce it if possible and also decompress by distraction and providing the adequate disc space for the nerves. So this is how I mark for myself. So I mark the lateral border of the pedicles where I want to put on the L5S1 and the inferior border of the pedicles. So this orientation helps me not to go inferior, not to go medial. So like Dr. Mahesha was saying, this is my navigation in my brain. So the same works for everybody. We all have been doing for long. I guess everybody does nearly more or less the same. So these are the markings. So these are the markings. The vertical lines depict the lateral borders. The horizontal lines depict the inferior borders of the pedicle. So depending on the obesity or the thickness of the muscle and skin tissue, I usually take around 1 centimeter lateral to the vertical lines which I have drawn, that is to the lateral border of the pedicle, 1 centimeter lateral to as a starting point so that I can provide adequate amount of medialization for my screws. And mind you, this the orientation for the inferior vertebra is always an orthogonal view for that vertebra. So I tilt the CM as much as possible to take a true AP for that particular pedicles. So though in AP everything seems near, but when you take a true AP, the distance between the pedicles is almost nearly the same as other pedicle to pedicle. So the procedure goes like this. You are inserting your Jamshidis, you are putting your K wires, you are fixing your screws. So whenever it is a listhesis and I am trying to reduce as much as possible, I would like to have my screws as medial as possible, because it provides me to have the longest possible screw, and more angulated the screw, the more the pull out strength of the screw. I can put enough strength on the reduction and distraction when we do it for completely reducing the listhesis. So this is how the patient was when I had put my screws. As you can appreciate, that screw head of the L5 screw is much deeper than the screw head of the S1 screw. So this is the amount of difference we have to get back the L5 onto S1, as you can appreciate on the position of the screw heads. So the incision, as you can see my knife on the other side, which helps me to take an entry so that I can medialize my screws. So the tip of the screw in lateral is at the tip of the vertebra, anterior border, and on AP it's almost touching the midline. So this helps me to be confident in putting enough pressure on my screws. So obviously every surgeon, when he is putting his own screws, he understands how much the bone quality is, the torque strength when he is putting the screw in. So he can ably justify how much he can put the effort on distraction or pulling up the screws or tightening the screws. So this is the amount of medialization, as you can see. So when you see it from the above, it appears to be almost like more than 30 to 40 degrees of medialization. So this is the angle which I put the screws in, but they are still not crossing the midline. It appears to be like 50 degrees, but it's not. When you go to the screw in the vertebra, it's just the normal angulation what we generally do for all the L4, L5, S1 screws. It's just the 25 to 30 degrees of angulation. But yes, depending on the starting point, depending on the thickness of the patient you have, the appearance of putting the screw is very, very oblique. But you're always safe when you stick to your principles, when your medial border of the pedicle and the entry point on the lateral view just touching the posterior vertebral border is there all the time. So the same patient, when we have put the screws, see, this is the amount of listhesis we need to correct. So this is not always the true picture, because the lumbar spine is always in a we have a lumbar curve. So along the radius of that curvature, when you take it, it's nearly more or less like 1 to 1.5 centimeters, which you can see, appreciate on the both sides when we put both the screws. So for all the listhesis cases, we usually put the screws first, try to reduce them, provide enough disc space for Dr. SUKUMAR to work in for the endoscopic part of the procedure. So as you can see on the image, so the amount of listhesis. So that screw head has to sit on the near the facet and pedicle junction, facet and transfer process junction. So you have to be quite sure where your screw head is if you want to reduce. So this is the final picture after putting all the screws. Still there is some amount of listhesis and some amount of disc space we need to reduce. So this is a 50 rod. So as you have seen in the earlier surgeries, so for 50 rod was big enough. They have changed to 40 rod. But this is a 50 size rod. As you can see on the image, it appears to be big. But yes, when you are planning to reduce and when you are planning to distract, the 50 rods is, for this case, seems to be appropriate. So what I do here is, I fix my distal vertebra first, and I have my rod to have minimal lordosis at the most possible, but never straight, because lordosis helps me to gain additional reduction for the listhesis. So I fix my distal vertebra, then slowly I move on to fix my topmost vertebra, and at the same time I use my long pronged distractor helping me. So simultaneously I am distracting as well as simultaneously I am tightening the topmost screw. So it's a two-way action. So as you can see on the image, the distraction and reduction forces are acting simultaneously, resulting in a rotatory motion of the vertebra. So it is almost correcting the kyphosis also, and also giving you the reduction, and it is never a single directional translational force. It is a rotatory motion of the vertebra. It slowly reduces, and also there is little pressure on the screws when you are using these forces simultaneously. So the resultant rotatory force on the upper vertebra helps you reduce to the maximum possible extent. So as you can see, the slip and the rod which has been already been fixed on the distal vertebra, and the rod which is at a distant place from the screw head in the upper vertebra. So I am just distracting. You can see the prongs of the distractor, as well as I am tightening the innie simultaneously. So here, as the rod is going down, you can appreciate some amount of listhesis reduction as well as increase in the disc space. You see, as the innie is going down, the amount of reduction is almost, we are near to correction of the listhesis. So we have put one rod. If the listhesis is rigid or more, you can as well do this after bilateral facetectomy or bilateral rods to correct the listhesis, so that you don't want to put enough force on only one side of the screws, which may loosen them up. So you can use simultaneously bilateral rods. One of your assistants can help you with the same distraction and tightening the innie simultaneously. So ultimately, once the slip is completely reduced, the screw heads, the prongs coming out of the skin more or less lie in the same arc. This is another typical case, but it's a post-menopausal female, more than 60 years. We tried our luck here with the percutaneous system, and I forced Dr. SUKUMAR, let's do endoscopic procedure here. He was reluctant to do, but I suggested, let's go, we'll see. We always have a chance to open, but we might do something better if we can do with an endoscopic procedure. As you can see, the degenerative listhesis here at grade 2 to grade 3. So this is what we achieved on the initial screws. But female post-menopausal, the screw hold, though medial, though longer screws, as you can appreciate, the moment I started to reduce, there was screw pull out. So we had no option either to convert it to open and do the procedure again, or get satisfied with the amount of reduction you have, just move on. So this was the amount of listhesis which needs to be reduced there. So what we did next was, we removed the screws, put in some cement, we put the same screws in. We tried this for the first time here, and we put a cemented screws, and we used the same technique as reducing the listhesis as I have showed in the previous slides. And we were able to distract, and we were also able to achieve good amount of listhesis correction here. So this is the ultimate final picture. You can see the disc size, disc space increased, and also the amount of reduction. Thank you. Any questions, please? Yes. Generally, what we do is, once we place the patient on the bolsters, automatically the hips go into flexion. So what we do is keep 1 or 2 pillows below the knees. So automatically the hips become extended. So it will help you. If still that is not helping you out, you always have your table where you can increase your angle of the table at the head and slowly extend it. So it might also help sometimes. Jay.
Any more questions? Whenever OT is ready, adugu valani. Thank you, Dr. Abhinandan. Next, we have the talk from yesterday. We couldn't face Dr. K.T. Chain, maybe. With small note that whenever OT is ready, they might go live. Okay, please. Dr. Chen, go ahead.
Okay. Thank you, Naresh. And it's my honor to be here again. And I have the chance to talk about the cervical posterior decompression in this meeting. And the topic is innovation in endoscopic spine surgery. I'm Kai-Ting Chen from Mackay Memorial Hospital, Taipei, Taiwan. Endoscopic spine surgery history is from Kambin and Hachikata 45 years ago. And nowadays, it's not only solving the problem about the herniation discs, but also you can do a lot of decompression or fusion surgery like the meeting mentioned these 2 days. So there's many generations of endoscopic spine surgery, and now we are in the fusion generation. Maybe it's the 4th generation. So I prepare a lot of topics, but I choose the most interesting one. One is PSCD is kind of a posterior decompression of cervical spine. And another one is endo-A-lip. It's kind of direct decompression through the A-lip. And the final one is the endofusion that I talk in the afternoon. Yeah. So the first one is full endoscopic unilateral laminoforaminal bilateral decompression. Laminoforaminectomy bilateral decompression. Okay. So I choose the case really rare. So I only have less than 10 patients to do this kind of surgery because the indication is limited. You can see that in this patient, he have bilateral foraminal stenosis with spur formation. So you can see the deformity of the foramen because the spur. But the lateral view, you can see the sagittal alignment is okay, so the K line is positive. So this kind of patient is rare because nowadays we use a lot of cell phones, so we always lay down your head. So sometimes you cannot find a beautiful lordosis patient with so severe foraminal stenosis patient. Okay, so in the MRI, you can say that there's C3 to C6 bilateral foraminal stenosis with central stenosis. Okay. So how to do it? How to solve this problem? Patient have myelopathy. He has unstable gait and also have bilateral arm pain and numbness. So I think about after I saw this MRI. In the past, maybe we will do a laminoplasty for it. It's a gold standard for this kind of severe multi-segmental stenosis. But now, we are endoscopic spine surgeon, so I'm thinking about if I can do this kind of problem by endoscope. So we try to do a multi-segmental full endoscopic unilateral laminophoraminectomy for bilateral decompression in this multi-segment. So this is the video. Sorry. It's stuck in the beginning, so yeah, sorry. So we incise the wound near the spinal process because we need to do bilateral decompression. So near the central is easier to do the ipsilateral side, okay? So we, okay, so, sorry. Okay, we start, the trochanter go from the lamina and sliding to the V point, and we try to find the bony part. This is the lamina. And we try to remove all the soft tissue and try to find the V point. The posterior cervical decompression, the most important is to find the V point. Okay, so remove the soft tissue clearly by anything you have, maybe punches or coagulator, and this is a V point. Okay, so we start counterwise decompression because the cranial lamina is covered on the caudal one, so you should go from clockwise decompression. We don't need, we didn't do the fusion, so we can use the burr most of the time. Okay, we don't need the autograft, but be careful that you should not be too lateral because there's a vertebral artery. So you should make sure the lateral border of your spine, the distance between the lateral border of your spine and your location you decompress is wide enough. Okay, so now we try to do the caudal one decompression. Okay, so after that you can find an O shape of foraminectomy. Okay, this is O shape. Okay, this is covered by the ligamentum flavum. So in cervical spine, you should be more careful. So en bloc resection of the ligamentum flavum maybe is difficult. So I remove it step by step, punch by punch, by the Carson Ronger. And then you'll find the SAP and IAP of the cervical spine. And you'll find a special one called perineural membrane. It's different from the lumbar. This only appear in the cervical spine. You should remove it, and then you can see the nerve, see the root. So you must remove it. And which one's the root? Sometimes you are confused, but root is much near the SAP. So right side must be the root, and left side is the disc. It looks quite the same. Okay, sorry. Okay. So we keep remove the shoulder. You can see there's a root of the disc. Okay, this is a hard disc. In most of the time, we know that hard disk is hard to remove, and you cannot. You just can take out piece by piece. I would try to remove some if possible. If you're lucky enough, you can remove some of the disc and decompress the nerve. In this case, you release the soft tissue on the disc and then try to remove some. Then you finally found that it's really a hard disk, so we get up and keep do the decompress of the nerve root around the shoulder part. You can see there's some ligament frame or soft tissue around the root shoulder, and we keep remove and make it more clear, the field more clear. Okay, if you do the foraminectomy and the surgery is finished, but we keep doing the decompression of the central and opposite side, so we keep do the burying and removing soft tissue on the central. Okay, so I should do some burr of the cauda and cranial lamina to make the space bigger, and try to remove the yellow ligament. And you can see the opposite viewpoint, this opposite side viewpoint. So the orientation is very clear. So we start to remove the ligamentum flavum piece by piece by Kerrison punch. It's a dangerous surgery because this is cord. It's different from the lumbar. So need some experience. And you can see a fossa on the opposite side. The nerve is laid on inside the fossa, so we should open it. When you open the fossa, this is lets you do the opposite side foraminectomy. Okay, so we also can use the Kerrison punch to do our opposite side. And then I use the larger one, and now I use the burr to burr the cranial part because the nerve is lie more cranial in this segment. Okay, so now we change to a smaller one, endoscope, because I use the fusion scope in the beginning, and then we try to change the smaller one scope, regular one scope, because I want to go through the spinal process to go to opposite side and make it more easy for decompression. So the blade of my sheath is lie on the dorsal of the bone, and that will not compress your nerve. Okay. So after the burring of the opposite side, you can see the opposite side SAP and IAP later. And you keep remove the opposite foramen. Okay. So you can see this opposite side SAP and IAP. And the root is just laid near this. Here, there's a opposite side perineural membrane. We must remove it and hope to see the nerve root. Okay. So after remove the soft tissue behind it, and you can see there's a contralateral root. So this is ipsilateral to contralateral root is totally clear for one segment, but you should do this 3 times. So it's really tough in this surgery. You need experience, you need very stable equipment holding, and be brave. So after I do the 3 segment, luckily patient's pain disappear immediately after post-operated, and the numbness disappear about 1 month later. Okay, another interesting is that the endo A-leaf. Endo A-leaves used in some special case, because this case, for example, is a L5S1 spondylosis with hard disk impingement in the foramen and the central canal. So, you know, A-leaves a kind of indirect decompression. So you cannot promise that this kind of hard disk can be decompressed by the indirect force. So what I think is, can I do the direct decompression by the endoscope? Maybe it can. I just dig a small hole in front of the disc, and insert a trial, maybe a T-leaf cage to maintain the disc height and let you insert your scope more easily and do the discectomy. And the right side is a warming device because you go through your abdomen, so the fluid must be warm. Okay, this is the field I do in endo A-leaf. You can see the discectomy area. This is the video. Okay, this is a dry scope, and then I dig a hole and remove some disc and insert a cage in one side. You should do this twice. In one side, maybe left side, and insert your scope to the left side. And open your irrigation and start to do the discectomy. It's quite the same as ACDF when you do the anterior approach in C-spine decompression and caging. So you can use a calcium punch to remove the posterior spur near the end plate. So you can see that the field is very clear. The breathing is small. Yeah. And then you can, after I remove the nuclear polyps, and you can continuously remove the new, so thank you. I'm Kai-Ting Chen from Mackay Memorial Hospital, Taipei. Thank you.
Hello. Thank you, Dr. Chen, for wonderful presentation. You're showing the path of the future advancements with what can be done with endoscopy. And any questions?
Sorry, Hussein, you means which kind of surgery?
In this one. Right, you take a... Okay. Thank you again for the excellent presentation. When you do the endoscopic cervical foraminectomy for the bilateral, do you see a lot of root exiting variations? Then is it affecting your endoscope movements and for maneuvers?
In lumbar spine, I see a lot of conjoint root. There's two roots in one hole. So sometimes you are injured. But in cervical, I don't have this experience. But the most important is that the different segments have different location of the root compared with the disc. Maybe it's above the disc, caudal or cranial of the disc. If you go more cranial, the root maybe is on the disc. And if you go more caudal, maybe C6 or C7, and the root is cranial to the disc, so it's different location. So if you keep in mind this, you will not lose the orientation. Yeah.
Okay, thank you.
Any questions? Okay, I think we'll move to the, yesterday we have seen stenosis surgery, decompression, today endofusion. We have last two talks where, the masters have presented how well to do the live surgery and do the surgery. We have two talks focusing on what can be the complications and how to handle in challenges so that one has to understand those and how to address. So I request invite Dr. Zakiri Rashid from Malaysia to present on challenges and complications in stenosis decompression.
Hi, good evening, everyone. I am Dr. Zakiri from Malaysia. I'm representing the Malaysia Society of Endoscopic Spine Surgery. Okay, today I'm going to talk about challenges in endoscopic stenosis decompression. I'm coming from Malaysia. This is the picture of our beloved Kuala Lumpur. Okay, I think the first main challenge now in endoscopic spine surgery is the inadequate knowledge in anatomy and open surgery. Like Dr. Pramod mentioned in his keynote lecture, nowadays there are less and less open surgeries. Nowadays surgeons are less exposed to open surgery, so in terms of anatomy and exposure, today more junior surgeons are less experienced. So because of that, you can see that usually the transition from open surgeon to endoscopic surgeon will be smoother because of experience in handling open surgery cases. So I think one of the most important thing is we need to have a fallback salvage procedure. For example, if you have a big dura tear, you need to know how to open and repair it. This is some of the, I think, lost arts nowadays because of less and less exposure in open surgery. So basically, when we do endoscopic surgery, in terms of anatomy, we need to know every angle, every curves of the spine, so that when we touch the bone, you palpate the bone, you see the bone, you know where you are. And one of the more important things to remember is the narrower interlaminar space in upper lumbar levels. So sometimes we can make the mistake assuming that the lower levels and the upper levels are the same. But they are not, because they are narrower interlaminar window in upper vertebral levels. And also we need to have in mind that more bony works need to be done in stenosis cases. So basically, when we talk about endoscopic surgery, we are talking about a targeted approach. We try to minimize the collateral damages. So we can do a targeted decompression to relieve the symptoms. Like for this case, this is a case of L3, L4. The main symptoms is severe radiculopathy on the right side. The main problem is facet hypertrophy with calcified flavum. So I just do a targeted one side decompression. I just remove the calcified flavum. I just remove the part of the medial facet. And then the nerve root is free. Patient is symptoms free post-operatively. So now you can see that actually that's the lateral border of the transversing root. So the second challenge would be the inadequate preparation for precision surgery, because the endoscopic surgery is a precision surgery. We need to have a good, precise MRI. You need to have to be sure that we have a good MRI, and you have a good radiologist in assisting you in reading the MRI as well. And camera system is very important. You need to have a very, very clear view during the endoscopic surgery, and you need to have a very nice steady equipment, so your equipment does not break during the procedure. And you have to have a nice radio frequency probe that you can use it very close to the nerve. Sometimes the old radio frequency probe is very sensitive, so when you put the probe very near to the nerve, so you have the jerking movement of the lower limbs. I operated with irrigation. I use the pump. Usually I keep my pump pressure around 40 to 60 degrees. And actually for me it helps a lot, because I know what is my pressure. Because if I just rely on gravity alone, I don't know exactly what is my water pressure. So the pump as well as the irrigation actually in overall help in hemostasis, flushing and small bleeding, and it's easier to identify the bleeding source, better identification of microanatomy, and also we can use the water pressure to separate the tissue layers by the simple irrigation. So actually good camera system helps in reducing the complication, especially in stenosis cases, because we need to have a very clear view. In stenosis cases, usually bleeding is one of the main problem. If you don't have a good camera system, so usually the view will become very blurry. So you need to have a good camera system to see, especially if you want to see the contralateral side. In some cases, because of the bleeding, you can't really make out the contralateral side. So it's very important to have a good camera system during the endoscopic surgery. And then the third one is inadequate exposure. So basically the evolution of techniques all this while is to achieve a good decompression and minimizing the collateral damages. So in endoscopic surgery, the inadequate exposure usually leads to excessive manipulation of neural elements, which then leads to complications. I give example of this case. The level of L4-5 is a stenosis problem. The L5S1 is a simple disc problem. So this one is, I did endoscopic decompression for L4-5. This is the axial view of the L4-5. You can see from the RI image, the L4-5, you don't have any interlaminar space at all. There is hardly any space for the L4-5 interlamina. So this is the video after we did the decompression. That's the ipsilateral nerve root, and that's the opposite contralateral nerve root. This is the ipsilateral side. So for this case, I need to use quite a lot of burr, and that's the contralateral side. This is the post-op RI image. You can see that there are now space at the interlaminar window, L4, L5, and like we discussed yesterday, you can see that we burr the interlaminar window flush with the pedicle line. Visualization of bony structures will be very helpful in orientation. It's a good practice, especially for beginners, to visualize the upper lamina, medial facet, as well as the lower lamina before flavectomy. And thinning of the flavum is very helpful. I give an example of this case. So I burr the upper lamina, remove the upper lamina, and I remove the superficial flavum. Then I can get this view. From this view, I can see the upper lamina, I can see the medial side of the flavum, I can see the lower lamina, medial side of the facet, as well as the lower lamina. And then I remove the flavum, and then I can see the disc, do the discectomy. And then one of the main challenges is the intraoperative bleeding. This is one of the main problem during the especially stenosis decompression. Because we use the wet scope, so the bleeding will obscure the endoscopic vision. Mastering how to control hemostasis is crucial in endoscopic surgery, and that's the reason why we need a very good RF. So how basically to minimize the bleeding? The first one is, I think one of the most important one is to ask the anesthetist to keep the MAP around 70. If we keep the MMP around 70, usually most of the bleeders, especially the bone bleeders, actually you can control it just by controlling the blood pressure. And then to localize and stop the bleeding source early, the common mistake usually during my early days is you try to, once you put the kerosene in, you try to bite as much as possible while ignoring the bleeders. So that's actually a mistake. You try to catch the bleeders early, because if you have multiple bleeders, then it will be harder to control. Use a diamond burr is a good step. It's a bit slower, but it helps to minimize the bleeding as compared to using the cutting burr. Use the sector to press on bleeding point. I think this one was demonstrated by Dr. SUKUMAR yesterday. And you can also use the water pump pressure. One of the main advantage of using the water pump is you can use the water pump pressure briefly to identify the bleeders. So usually my pressure is usually around 40 to 60. I can briefly increase it to maybe to 70 to 80, identify the bleeders, use the RF to stop the bleeders, and then I reduce back the water pump pressure. And then one of the most feared complication is the dura tear. One of the main thing to know how to do open surgery is it will give you advantage in handling dura tear. If not, it will be a headache once you have a dura tear. So one of the most important thing is to create space. Once you have the space, you reduce the risk of your dura tear incidents. And mastering the technique to remove the flavum is essential, because usually the dura tear happens when you remove the flavum, especially if you remove it by piecemeal. And then we have to remember that upper lumbar levels, there will be narrower interlaminar space, so you need to do your more bony work before you remove the flavum, then you can minimize the incidence of dura tear. So if you have dura tear, what can you do? So these are the things that you have to keep in mind, so that you have to prepare beforehand before you proceed with the endoscopic surgery. So for small tests, actually you can just put a gel foam, you can use a taco seal, you can use a Duragen. So you need to have this one available in your theatre just in case that you have an incidence of dura tear. The tacosil is very well described in Korean papers, how they put the tacosil inside the small tear. So basically the intradural pressure will push the tacosil, so it will seal the dura tear from inside. Usually most of the time I never had to open, fortunately. So if you have a small tear, I can just use a small gel foam. Sometimes I just put a small Surgicel, or you can just put you just overlay the small dura tear with Duragen. And what about a big tear? One option is to convert to open repair. The second option, you just convert to UBE. Basically, you just create another portal. I think in UBE, this is an established technique. I think Dr. Bhupesh can attest to that. That you can just, in UBE, because I also do UBE, in UBE, basically, you just stitch it using the another portal, and then you use the sliding knot like you do it in shoulder surgery. You just slide the knot in, and then you just cut it, and then basically you can just do the direct repair without converting to open repair. And then the next challenge would be the incomplete decompression. So this is one of the more common questions being asked. How do you know that you are compressing enough? So that's the reason why we need to really understand the MRI. The degeneration, not all degenerations are our enemy, because it's a normal process, it's a stabilizing process of the body, so not all need to be removed. So that's the reason why most of the time we just leave the disc as a stabilizer. We just remove the posterior element and just keep the disc as the stabilizer. So misinterpreting MRI can lead to decompressing the wrong area. So sometimes we just remove the disc, we don't recompress the lateral recess, so patients still have the symptoms. Too much decompression will lead to instability, so try to preserve the facet. So this is an example of decompression done for 2 levels. For this one, the symptoms is more on one side, but the decompression was done for both sides. But I made sure that from the IFC lateral side that we can see both of the 2 levels, that we can see the shoulder of the nerve root clearly. So then the next one, I think it was mentioned yesterday that a surgeon, an endoscopic surgeon, is not complete if you only know either a transperineal technique alone or the interlaminar technique alone. You need to know both for you to be a complete endoscopic surgeon. So need to learn and master multiple endoscopic techniques, because not all the cases are the same. Sometimes you need the different technique to remove different pathology. I give example for this one. This is an example of a case, or recurrent disc case for L5S1. This patient was done many years ago in another center, and the interlaminar spacer was put in. So if you want to approach this one by interlaminar approach, it will be very difficult to approach, because you need to go in, deal with the fibrous tissue, take out the spacer and stuff. So this is the axial view. So this one was approached by a transforaminal approach. So the disc was removed, the migrated disc was removed. You can see that's the pulsation of the dura. And then the migrated disc was also removed. So that's the area of the migrated disc there. So the migrated disc was also removed. So basically this is a pre-op MRI. This is a 3 months post-op MRI. You can see that the offending disc is completely removed, and the disc has remodeled. This is the axial view of the same patient. So in conclusion, it's essential to be aware of challenges in stenosis cases. Be familiarized with interlaminar discectomy case first, so that you can have a good familiarity with the depth, with the angle, with how to handle the instruments. Learn multiple endoscopic techniques so you can handle multiple pathologies. Take steps to avoid complications, and take steps as well to prepare for complication, like prepare for the Duragen, prepare to have the tacosil, to have the gel foam. And start with simple cases, and always remember that perseverance and patience are our friends. Thank you.
Hello. Any questions? I think we'll move on to the, we'll check from the OT before one last presentation from Dr. Bhupesh Patel. Thank you, Dr. Zakari.
So what I want to do you is give the goose.
Sir, Sukumar sir.
Just use the goose. Just shave it off.
Sukumar sir.
Yeah.
Yeah.
Curator. Hello.
Hello sir. Please go ahead, sir.
Yeah. So the Dr. Praveen curate. Dr. Praveen has just a place. You can curate it. You know, I should have want me to do. Praveen has now deployed his with the serial dilators. This you can. You can see here what he has done is he has gone into the space, disk space. He has done a foraminoplasty first because he want to be safe. So he has done a foraminoplasty, grasp, and foraminoplasty. Then he went inside the disk space. So
we're just getting
first he
before we do the expandable shaver.
So he is removing. He is into the disk. Before use the expandable shaver, he want to be doubly sure whether he is parallel to the end plates or not. So now he is parallel to the end plates. So he will use a He will use a expandable shaver. So as we saw in the morning, this is an expandable shaver. He is showing now the expandable shaver. Can you zoom in here? You can see the expandable shaver.
That one in the middle.
So
Sukumar sir, hand image in the middle.
The camera image bigger. Can you see the expansion?
Yeah, yes, sir.
So now he is undoing it. It becomes a tube. So he goes into the channel now.
Now lateral.
You take a lateral. Shoot. Can you see the lateral image? He's just trying to little bit come out of the sheath. Shoot. Can you see he has come out? He's going further anteriorly. Shoot. He's now expanding it. So he has expanded till 8 now. He's rotating further. He's just shaving it off. So he's just shaving. Can you keep fluoro? Fluoro is, as you can see, he's rotating his shaft inside the expandable device inside. The grasper.
Grasper curette from there.
To the grasper. So he's using a bigger grasper of. So he's taking a shoot there. He's taking out the content now. Because the disc is degenerated, is nothing much is coming out. Now he is using a bendable curette. You can see the bendable curette here. You can see the bendable curette. Can you see that?
Yes, sir.
Yeah. He's using that. He's going inside.
First we can do with the inferior shot.
So he's now working on the inferior. There's nothing there. Probably already it is end plates are prepared. Yeah. Camera and I think. So now you can see the camera again. What he has done, he has shaved the. There's nothing. Already it is completely prepared. End plates are well prepared, and you can just remove the debris.
Endoscope image little bit bigger.
Eight into 26. Graft తొందరగా. needle amma, Jamshedi needle. You can do RF and
Let me get an aura, give the punch.
you want a bigger
No,
punch?
that's why I can't grab anything.
Huh? What happened?
Something to grab.
ఇది పోయిందమ్మా ఇరిగిపోయింది ఇది వేరే తీసుకో టూత్ ఉండే తీసుకో మన టూత్ పంచ్ తీసుకో యు టేక్ దట్ యు టేక్ దిస్ ఫాస్ట్గా చేయరా చేయరా ఏం చేస్తున్నావు నిద్రపోతున్నావు చెయ్యి ఫాస్ట్ సో you can see it's almost end plates are well prepared, just removing the disc for better graft placements. RF.
And on the lateral, it was a little bit deeper, so you can pull this guy. You can give the wrench. RF, I'll do RF now. Get the wrench.
Yeah. Wrench is ready. Here you use that, I use that the curate, flexible curate, and just here you can use a flexible curate to just curate it off. Yeah, you can see here is just going at lifting it out. You can just use this and just have to understand how to use this instrument. So once you are used to it, can do wonders with this simple instrument. ఆ పెద్ద గ్రాస్ పరిగమ Here the advantage of this expandable cage, other than the cost, so advantage is that you want ranch.
Yeah.
Ranch here. So is that you need not, the foramen is not put under stress. Ranch ma, ranch antadi is ranch. Want a grasper again? Yeah. Huh? Color ogalagundi. If you want to ranch, you can just.
Go lateral.
Cage ready, graft. Needle ready na? Needle ekkadundi? Just
We're going to only put like 5 cc's in there.
yeah, and just take the bone marrow for a shoot. Maybe can little bit pull it back. Want to hammer it out or slap hammer? Idundi kadra slap hammer undi kada leda? You want this?
Don't want to pull the whole thing out.
Yeah.
Oh no, this is for the other.
Okay.
Shot.
సార్ నిన్న అన్నారు కదా 40 years ఇండస్ట్రీలో ఎప్పుడు ఇలాగా ఇంత తీవ్రమైన అంటే ఇట్లా బిట్ maybe that is a better. Yeah, I think it should be.
It's fine. We can back it up after the cage goes in
yeah.
also. Okay.
I'll take the.
Okay, you guys can see the end plates are prepared.
So end plates are well prepared here. So that small bit I'll cure it. I'll do it for you. Just cure. The small there is a dorsal soft tissue curate. I can curate it out. Just so I'll just use a curate here. This curate, you should understand, you use to, it's a very slender instrument punch. So initially we used to break a lot. The moment you keep inside and rotate, it will break. So now it doesn't break because you know beyond this force it will break. RF. So then we'll see how anterior we have gone and check with RF, check with the C-arm. Curate. Just there is some tissue, some end plate still on the bone. Just try to remove that also after removing this annular fiber, the disc.
I didn't want to go beyond that just because it looks like almost like a thin ALL.
Yeah, I know. Shoot.
Yeah. Oh no, it's pretty good.
So this fibrous end plate, the cartilage which is become more fibrous there attached to the bottom. So now we have removed all the debris. Now we'll pack the graft after mixing with the bone marrow, the allograft. Then we'll put deploy the expandable case. So we are good to go here. You can see end plates nicely, petechial bleeding, cure it. So we'll go and take the bone marrow, punch. Take the AP pedte bone marrow తీసుకుంటా. So I'll just take the bone marrow, suck the salinama. Yeah. So I'll just remove the small bits which are debris. But suction. I'll take a bone. Yeah, I am taking a bone marrow using a Jamshedi needle here, where he has taken the, it's too lateral, so shoot. Shoot. నాకు రే షూట్ అది నాకు ఈ పక్క ఇట్లా రావాలి, ఇట్లా రావాలి. షూట్ ఇట్లా రాండి రా. యా కాదురా, ఉల్టా పెట్టావు. ఇట్లా ఇట్లా పెట్టు, అది ఇట్లా రావాలి. I'm trying to avoid one more incision in the shoot. Yeah, I'll just go here. Shoot. 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 Hammer. Shoot. Maybe I have to go a little deep. I'll check. So you can see the bone marrow here.
Yeah,
just
yes,
go in the posterior crest and you get a good harvest of bone marrow. And the plan is to pack around 5 cc of graft, so no much blood also is required there. Just I'm taking for around 5 cc, mix with the graft, the allograft. So just remove the, now flat. So can just come, is taking lateral. Yeah. Push her, Rama. Yeah. Huh? So I am putting a graft here now. I am just taken around more than 5 cc, but around 5 cc will pack. That should be enough. My hammer. Shoot. 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 Some more. Put some more graft. I think it's enough. Enough, right? Chal. Yes. Hand. So now you can see the cage he is deploying. It's again the same cage which 8 into 20?
26.
Yeah. Should.
I think earlier one question for Praveen sir.
Yeah.
Sukumar sir.
Yeah.
I think there are two cages, right? One 7 mm becomes to 11.
No, the 7 to 14 and then 8 to 16, I think. 8 to or 18.
Okay.
Little bit bang more, little bit.
7 profile goes to 11 and 8 to 16. 14, sorry.
Should. Can little bit lateral a bit.
Yeah, go lateral.
Better you can go more anterior. So here we are okay. We can little bit impact further so that it becomes in perfect position. Should. I think can go. Should. కొంచెం నల్లగా చేయరా చాలా ఎక్కువ పెట్టావు షూట్ AP you want to little bit come out now?
Yeah, this has to come out.
Yeah.
You want to use a wrench or?
Wrench. I'll do that for you. Wrench. Rama. Hammer. Yes. ఇది కాదు I just came out, shoot. Now he's expanding. Is it pit? Fluoro pit. Fluoro. Now you can just.
Trying to go to a 9, but it's giving me a lot of resistance to go to 9.
Shoot. I think.
Yeah, there you go.
Shoot. So now that's a perfect. I think it's enough.
Yeah, it will fork out. Yep, that's it. Now
Yeah, it's torque. So we'll just take AP and yes, we'll just take AP.
Dr. Bhupesh.
Short. Yeah, it's good.
Bhupesh.
Ferguson. Koncho.
pretty good. I'm not going to reposition it. Right?
Yes, it's okay. What you want?
You would have to redeploy if you want to go more immediate.
No, it's okay. It's okay. Shoot. Achha, you want to see that? Shoot rock, sorry. So just we want to see the cage. You can see the cage there. Can you see the endoscopic image?
Bigger, no sir.
Endoscopic image, please.
No, endoscopic image in the middle, bigger screen.
So that's a cage sitting there. He is coming out with the sheath is
Sir,
coming out.
Endoscopy screen is not showing. Yeah, there.
It's coming out. It's way deeper. It's way deeper. So you can see how deep it is. It's gone way anterior.
There's a lateral
That's the lateral recess fat seen there, and is coming out. It's coming out. So once we come out, should just take a X-ray. Okay, see there, lateral. Very tough space here. Can you see that?
Yeah, yes, sir.
It's good. It's
good.
It's 26. Yeah, we can tighten it and break the top screws and Rama, తీసేరా.
Sir, any summary you can say, because Dr. Bhupesh has a last talk.
Yeah, you can go ahead. We are done here. Thank you. Thank you very much. Just wanted to show the incisions in the last.
Yeah.
Hello.
Yeah, please go ahead, sir.
Cameraman come here? They can show the incision. Then we will just ఇది చూపించు జూమ్లోనే. సో లేదు అక్కడ అవుట్ ఆఫ్ ఫోకస్ ఉంది, కొంచెం కరెక్ట్ జూమ్ చేయి, దగ్గరికి తీసుకురా చెప్తా. అయిపోయింది, తీసేయచ్చు నువ్వు, దగ్గరికి తీసు. మళ్ళీ నువ్వు ఏపీ లాటర్ లాస్ట్ చేయాలి. Just Naresh,
sir,
just see here the advantage what Mahesha was talking about, the cosmetic. Can you see the two incisions for the two screws each, and the small incision we have gone through a transforaminal approach. So that's the end point. Thank you.
Thank you. Thank you very much, sir. Thank you. Any questions from delegates?
Jalpi. The final tightening రాడ్ చేయాలి కదా. లైట్, టాప్ లైట్ తీసి పైన స్క్రూ పైన టైట్ చేయలేదమ్మా. ఫస్ట్ ఇక్కడ పైన టైట్ చేయాలి, ఫస్ట్ టైట్ చేయలేదు కదా. Suction.
ये सब कन्वर्टर सब में चलता है, क्यों? पेनड्राइव में चलाना है क्या सीधा? हाँ। डायरेक्टली पता नहीं, ये कन्वर्टर नहीं चल रहा है, सब बोल रहा है. हाँ, सब में चल रहा है ना ना, था नहीं टाइप से. हाँ ओके, एक बार वीडियो चेक कर. वहाँ मत दिखाना, पर उसको बोल वहाँ मत दिखाना.
Okay. I think we'll have Dr. Bhupesh Patel will share on some of the challenges and complications in across the endoscopic spine surgery, something that all the delegates can, as a take-home message when you start planning or doing endoscopic spine surgeries. So, Dr. Bhupesh, over to you. Yeah. Thank you.
Hello, good evening. Thank you for the last talk. And yeah, we too, since last 2 days, we learn different kind of endoscopic technique, how we do and how we mastered. When we started the endoscopic journey, it was simple transforamen endoscopic. We started with discal debulking, and mostly it was limited to discectomy procedure. So the rate of complication was narrow. But nowadays, with advent of more and more advanced technology, the complication rate is bound to increase, because now we have also moved from lumbar to lumbar fusion, lumbar decompression, to cervical and thoracic pathology. But overall complication, if we see, then less than what we expected in the open surgery. So what are the common endoscopic technique currently we are doing? Most common is transforamen endoscopic, interlaminar for discectomy, interlaminar for stenosis, biportal endoscopy, anterior cervical, posterior cervical endoscopic, thoracic endoscopy, and transcambine PSLD and UB fusion. So this is a good paper recently published in February 2023 in NSSA journal, Neuroendoscopic. So very good paper. They have did good meta-analysis across all paper they compile, and they have given the indication and ratio of how much endoscopic complication are there. But so the overall incidence of complications are less than 10%. Most of the complications are minor. We don't need to do anything, just need to observe. And life-threatening complication can occur, but is very rare. So again, we come to the most common complication, a dural tear. But overall incidence is less than 2.7%. It is higher in stenosis than herniation. Again, if you do unilateral stenosis decompression, the incidence is lesser than if you do bilateral decompression. Least incidence in transforaminal, because it's everything is inside the disc and we move to cannula, and interlaminar, because lot of handling of dural tear is there, so dura is there and root is there, so overall complication of interlaminar is more. Again, biportal, the complication is higher than interlaminar uniportal. In transforaminal, if we see, the outside in has a more complication compared to inside in, because it directly land in outside in into the epidural space. So what are the factors if we consider? So during the surgery, what precaution you need to take? Again, the revision surgery, because of lot of adhesion and fibrosis, the incidence is higher. Narrow spinal canal, developmental narrowing, congenital narrow spinal canal, you have to be very careful, because you have very less space, especially when you are using the Spinoscope. So movement of your instrument scope is not too much. So whenever you are trying to reach to some corner, so whenever you are trying to reach to some corner and you are not able to reach because of narrow canal, so at that time there is chances of dural tear. Instrument handling, and because in interlaminar endoscopy, if you see, we are using 2D, so depth perception is not what we are seeing. So whenever you are using your instrument, you are seeing only 2D, so 3D view is not there. So depth perception is not almost all the time is equal. So you have to be very careful. Why? So violent insertion of the instrument is also not good. Again, the radio frequency and your drill can cause complication. If you are firing towards the nerve root or dura, it can puncture the nerve root, or can puncture the dura, or can damage the nerve root. Again, if there is chronic stenosis, there is a lot of adhesion in the spinal canal. Especially, you can see here, there's a dural band is there. So I made a dural tear here while pulling this dural band. You see? So it start from the dura and attach to the base of spinous process and lower part. So that can commonly cause the complication. And sometimes where you do interlaminar discectomy for large disc, and your cannula is not, you are not able to move the cannula, rotate the cannula inside the disc just to remove the, and fragment is so large that it can occupy entire your cannula, and you cannot see the root, exact position of nerve root. At that time, you can injure the lateral aspect of dural sleeve. Again, the complication rate in biportal is higher because for beginner, triangulation is very difficult. So the chances of lot of muscle trauma is also there. And again, they are not well versed with the biportal, both port and instrument and scopic port, they cannot match. So many times their instrument handling is not good. And where many times what happens when your scopic port, there is some bleeders, you cannot see with that scope. So always it comes in the way and bleeding is there. So you cannot see the proper field of the your decompression. So chances of dural tear is again higher. And again, complex anatomy, it's everywhere is very difficult to delineate the structure. Sometimes if you see the saline irrigation, it can just squeeze the dura on the both side and central area to elevate. So when you try to remove the phloem from the lateral recess, at that time there is chances of dural tear is high. And sometime I think last month their conference in Mumbai, someone has chosen biportal endoscopy, that shaver drill, the dura has engulfed in the shaver drill. So it is you need to be very careful while dealing. So there should not be any fibrous band, there should not be any soft tissue structure when you are drilling with the lamina. What are the management? So complication related to dural tear are very rare because our incision and we are not damaging any paraspinal muscle. So whenever you remove your instrument, if the dural tear is very small, there is no root that comes out from the dural tear, it automatically just closes the space and chances of CSS coming out is very rare. Small tear, almost less than 4 millimeter, we don't need to do anything. If the tear is medium size, you can seal with the fibrin glue patch, or you can apply the vascular clip that are commonly available in GI surgery. If you are working with a GI surgeon, if you're in an institute, they commonly have that vascular clip. You can apply and again you can put the tacosil over there. Large dural tear, more than 12 mm, you may need to convert to open surgery, and nowadays many surgeons tried interlaminar also and biportal also. They try to repair the dural tear with shoulder or shoulder arthroscopy. What we do in rotator cuff repair, we are repairing with like double bundle and single bundle, single row repair. Same we can apply here. So this is a simple algorithm you can apply for your dural tear. Again, this is a small dural tear you see. The size of our instrument, this dural dissector, it's around 3 to 4 millimeter dural dissector. So, and again, the benefit of endoscopy, what happen when you are, we are working in saline medium. So the flow of saline or fluid is from outside towards the dural sac. So there is chances of root coming out from the dura is very rare as compared to open surgery. In open surgery, when we work in the air medium, the inside the water pressure inside the dural thecal tube is higher. So whenever some small leaking happens, the root is just bulge out and it's like comes out like the noodles. So here you don't need to do anything. Ask for patient to stay one day in the hospital. Usually you do some endoscope in the morning or evening, or next day morning we discharge. Keep this patient 2 days in the your hospital. If there is some symptom appears, like patient saying having a headache or something, like, start Diamox, otherwise nothing, and mobilize after 3 or 4 days. Ask him to take adequate rest. Medium size and medium size dural tear. So you need to repair with tacosil, or if you have facility, you can able to do. Here you see that the roots is coming out from the tear. So first you have to put the root again inside the tear. And because here the pressure inside is high, so again if you just leave it apart, again chances that the root strangulation might happen. So you see that, and the tear is, at the part near to bony part. So again, it is a little difficult to repair. So the tacosil is in this case is blessing. So they usually repair in 3 layers. First layer they put in just flush to the dura, and 2 layers above the dura. And this tecosil is now recently being available in India. It was not available till date. Now this is the second layer. Now this is, you can see the third layer. So again, very large tear, more than 12 centimeter. You can see here. This is a slide from one of our friend Akrur from Uzbekistan. He had tried this with endoscopic uniportal, monoportal endoscopic repair with dural tear, and they just opposed the two layer with arthroscopic with instrumentation, and then he just put the tecosil over there. So this is also we can do. We just, because large tear, only tecosil will not work, it just dislodge. So you just need to repair with, take 1 or 2 stitch and then put the tecosil over there, or Duragen patch, whatever available with you. You can do convert the large tear in the small tear. So again the principle is same, root should not cut into the stitch. And is this time to keep the little water pressure little higher, so that root should not come into the view. And again, as Dr. Kai said, the biportal here is very good for, if you can convert uniportal into biportal, it's also good because you have two hands to work. And biportal, I think there is a very well established technique for dural repair. So now they are putting this sealant. Again, the biggest advantage, the preservation of muscle. So even though this is a large tear, and if you even can see there is some CSF is leaking out, even though it's okay because the space is closed completely. Second is recurrent disc herniation and incomplete decompression. Overall incidence again is less than 4%. Obesity, large annular defect. So if the patient is young patient with having large annular defect, you always explain and always counsel for recurrent disc herniation. So ask them to take proper adequate rest, avoid them to strain. Again, patient has a traumatic disc herniation. This patient, because of annular tear, all the layers are torn acutely. At that time, their recurrence is very high. Central disc herniation, because central herniation annular defect is very large. And again, obviously, the incomplete removal from primary surgery. Again, he's 56-year-old obese lady with right leg pain, but no motor involvement. If you see, there is L4-5 here, the disc herniation, and L5-S1. So I did transforaminal endoscopy at 2 level. patient's already all right for 20 days, again start of severe back pain while passing the stool. So when he's straining during the stool, he's got recurrent disc herniation. You see the L5S1, there is nothing, but L4-5 it got huge recurrence. So we did internal minor at that time because. So again, learning all different approach is very good. If you learn internal minor, biportal, uniportal, so whenever you have some difficulty in one approach, you can always try with second approach. So we did almost, when you are doing second time discectomy, don't make the discectomy only targeted. You do almost subtetal discectomy. So you don't want third time patient come with you for again recurrence herniation, or he may not come to you. So any revision, any recurrent surgery, discectomy for recurrent surgery, you have to remove almost as much as possible discectomy fragment. Any loose fragment you should always remove. Don't keep it for targeted only. You see the post-op MRI, I almost remove the entire nuclear material from this. Again, collapse happen, you just explain them. You may need some fusion surgery in the future, if at all, if hurts. Third is post-operative infection. So we almost all have gone through all these different stages. Again, incidences in endoscopy is less than 1%, because continuous irrigation of saline help to flushes out all the material which collect inside the disc and to collect inside disc and it get washed out. Most common is bacterial infection, Staph aureus and E. coli. E. coli again because of very proximity to the urinary structure to the spine, and Baxton plexus is also easily come in and out from the urinary tract. Debridement, lavage, IV antibiotic, 3+3 week, what we are following, 3 week IV antibiotic and 3 week oral. Most of the patient respond well. Yes, if the end plate, even if when patient present to you that if end plates are not good, if end plate is eroded, then don't advise them from debridement and endoscopic lavage. If end plate are damaged, that patient usually having a stiffness and back pain. Even after debridement lavage, even you cure patient out of infection, but that patients are not happy. So if the end plate are damaged during your infective process, or fusion is always desirable. Again, you can see there is one up migrated fragment L5S1 and very severe pain. I did very good discectomy, internal minor, and remove the fragment completely. You see the behind the vertebral body. I completely removed that fragment. And I feel, okay, I'm just a boss and hero. This patient is completely relieved of pain immediately. You see immediate post-op MRI, there is complete removal of disc. But again, she came after 10 days with low back pain and bilateral gluteal pain. And I just asked for some basic investigation because she is not able to walk normally. She had tilted. So there's some kind of sciatic list. CRP was 14 and all other investigation are normal. You see on the end plate, there is some kind of inflammatory changes in the end plate, probably infection. But if we see the discitis pain is very dreadful, but this patient has not that much of pain. Yeah, when she move in the bed and she just changes posture from sitting to supine to sitting or sitting to standing, that time we have seeing severe pain. So again, I waited. We start IV antibiotic for 3 weeks, and at that time we also take culture, but because of antibiotic, culture turned out negative with an empirical antibiotic, and we take successive MRI of 3 to 6 months. This infection is resolved. In the end, you can see the disc space is collapsed. So maybe it is aseptic infection. There might not be any infection because of some chemical reaction. End plate changes are there, and after 3 months, the disc space is collapsed. Usually 3 months it does not collapse because we did only targeted fragmenectomy. And now after almost 10 months, he is walking pain-free. Only stiffness while changing a posture in the bed. Third is root injury and post-operative dysesthesia. Post-operative dysesthesia is very common in transforaminal endoscopy. So it again directly proportional to your handling of the nerve root and your duration of surgery. What happened during transforaminal endoscopy? If you are keeping your cannula too longer time into the foramen, exiting root is bound to be pinched and it got compressive injury. So it present in form of dysesthesia because of irritation and compression of dorsal nerve root ganglia. How we avoid? If you feel the SAP or foramen stenosis is there, wide hypertrophy, facetal hypertrophy is there, you beginning with widening of foraminal window and then insert your instrument. Today, when we did, Dr. Praveen has done this fusion surgery. He initially did foraminoplasty and then he land. Again, safe landing to lower foramen. If you observe yesterday case of Dr. Mahesha, so there is so much lateral stenosis and foraminal stenosis. SAP is too much hypertrophy. But he landed very precisely into the lower pedicle, if you see. So he started even drilling the lower pedicle, and many of us feel how he's boldly drill initial part, because he knows he landed in the safer zone. So there is no structure in the lower part of the disc. So from beginning, so your initial target or the lower lamina, lower part of the foramen is very safe. SAP drilling again helpful. Again, I am telling, short operative time, as much as reduce operative time, don't waste unnecessary time, just finish your job as quickly as possible. Again, a root injury is uncommon in lumbar spine, but is when you do posterior foraminotomy. Yesterday we are discussing with our colleague also. He said he faced this complication. So root injury is very common in when you are doing posterior cervical foraminotomy. Why? Because there's a phloem is very thin or sometimes absent in the foraminal area, and there is thin fibrous band. So when you are doing your procedure, you didn't realize that you have removed everything. The root is just in front, and you damage that membrane. So you see here, roots comes out from the root sleeve. But even though we are lucky that we finished the discectomy, but still you can see the root is completely exposed inside the rootlet. In this patient, sometimes patient usually complain burning kind of pain in arm up to elbow. In this two patient, they are complain almost 1.5 months, the burning kind of pain because of maybe root injury. Third is postoperative epidural hematoma, is mostly with interlaminar approach, PSLD or UBE. It is around 2.7% in various study. Continuous saline irrigation and coagulation of all the plausible bleeder can avoid the hematoma. Yesterday you have seen the SUKUMAR was telling that while removing the cannula from, you continuously observe when there is any muscle bleeder is there. So you should coagulate that muscle bleeder, because once you remove the cannula, there is potential space happens there. So any post-operative hematoma, it can collect over there. And again, this complication happen dreaded when there is retroperitoneal hematoma in transforaminal surgery. When you approach far laterally, the disc approach is far lateral, and that time you may violate the retroperitoneal space and some hematoma occur, and at that time it is very dangerous. Again, increase epidural pressure. So I strongly discourage using a pressure pump, because pressure pump, you are very much giving a pressure, and if the patient is under general anesthesia, you may not realize that patient having raised epidural pressure, especially intracranial pressure also. So increase saline pressure during surgery, increase epidural pressure, can cause neck pain. So I usually do my decompression surgery under epidural analgesia. So anytime patient can have neck pain, we can reduce the pressure, or we can watch for some time. And if neck pain and headache during the surgery, you should wait, and you should not take this thing very lightly. In severe cases, it can cause seizure, blurred vision, or drowsiness. Water pressure usually kept below 30 to 40 mm Hg. And don't increase pressure suddenly. Sudden pressure, sometimes when there is so much of bleeding, suddenly you ask your assistant, push that, giving extra pressure, because sudden pressure can cause more severe symptom than gradual pressure. Avoid using pressure pump. Gravity assisted pressure is most of the time is sufficient. This is case, I did 3-level interlaminar decompression for stenosis. This patient, immediately after surgery, my last level was about to finish, the patient stopped responding. So almost 45 minutes we just waited. Even we giving so much of deep pressure, patient is not responding. Only her respiration is okay. Otherwise she is not responding to anything.
almost after 45 minutes, she just regained consciousness. After that, she's okay, but I don't know what happened this time, maybe due to our epidural pressure. Other complication, yeah, if you excessive do bony work too much and don't care about facets, you can end up removing facet. So post-operative iatrogenic instability. Again, too much use of radio frequency inside the disc may induce a discal cyst formation, or some irritation inside the disc can cause discal cyst formation. Retroperitoneal hematoma, post-operative skin burns is very common in UB, because every time you just go in and sometimes your RF is on, and you just put your RF inside the port and can cause skin burn. Again, wrong level surgery is very common. So if you are not confident enough every time, just check CM, 2 or 3 more shoot of CM doesn't hamper. But wrong level surgery, it happened with me when in UB, whenever I doing my 3rd or 4th UB surgery, instead of L4-5, I just decompress L5-S1. And when I just decompressing the L5-S1, I just realized there was so much stenosis in MRI. Why there is no stenosis here? Then I just check in the CM, because both port you just, I just tilted my orientation. So I just go to L5-S1. So again, in conclude, complication can occur with endoscopic spine surgery. So it is very common. So all who are beginners or you have done very few surgery, it can occur with an early learning curve, but follow the basic principle, complication rates with reduce. Again, major complications are not too high. Very rare when it comes, unless you are too blind and you are too bold, then major complication can happen. Again, learn from your masters. Whatever the tips they are giving, you should percolate in your practice. That can reduce your learning curve and or shorten your learning curve, and also complication also. Triangulation and hand-to-eye coordination is very important in endoscopic surgery. Okay, thank you. So any questions?
Any questions? Are all questions to Bhupesh?
Yeah. Thank you.
Thank you, and really thank you, Dr. Bhupesh Patel. And it was a nice summary as a conclusion for the conference. Maybe it meant to be, you've nicely listed out. I mean, there's a famous surgeon quotes, surgery is planned, prepared for complication. So I think that also part of the whole conference and the training agenda. I think with this, we come to the conclusion of our great 2 days spine endoscopy learning festival from the masters across the country, and also from Malaysia, Taiwan, Turkey and US. And we really an honor and to have you all. And first of all, thank you for your active participation in this event. And without your interest and zeal to learn, this program wouldn't be having this kind of response. Second, as in the last 2 days you have seen, like the 7 live surgeries being performed. Hope this would have enough inspired and to translate into action soon. And please share your feedback or any suggestions that can be improved or inculcate into practice. So together, as we always say, together we can make these programs, these trainings, so that better academic and training activities can be done. And all these things, for the whole reason we are all here, is to do a safe and effective surgery as part of spine care to our patients. And the patients can be our loved ones, anybody. And thank you for the patients who've been part of this conference for the last 2 days. And mainly thank you for all the educational partners and the venue staff, everything. And do keep your suggestions to us. You all have your contact information, mainly about clinical, to Dr. SUKUMAR sir or Dr. Abhinandan. And thank all the international faculty for taking the time and sharing their knowledge. And I hope it would be mutual. I mean, sharing their experience and learning from here. And also all the national faculty for spending their time, valuable time, and sharing all their experiences. I think this would help the young surgeons or the senior surgeons that wanted to get into endoscopy world will only make it more better in the future to come. And with this, we conclude the Spinoscope 2023. And once again, a big thank you for all the participants and everyone involved, Asian Spine OT team, and everybody has put their best, and hope it carrying a lot of good memories and fun. And let's keep the spirit in the years to come and make a big impact in the spine care. I thank you. And last but not the least, and in my apologies if any shortcomings, any inconvenience, nothing is intentional. Maybe it happens when we do such programs, but do share your feedback or suggestions, and we all together only we can make it better. Thank you, and have a safe travels back home. Enjoy the weekend, and Jai Hind.